Good morning, everyone. I welcome you all to the National Neocon 2021. I hope you all had breakfast because it's going to be a pretty interesting session and you won't be able to leave the hall. Despite the trying times, I'm happy we all could make it here, but COVID is still here and I request you all to maintain strict COVID protocols. I'm also very excited that so many health professionals have come forward to impart their wisdom, experience, and knowledge to the next generation. I take immense pleasure in introducing our chairperson, Dr. Ravi TV, President NNF Kerala, President IMA Cochin, past President IAP Cochin, present HOD of Department of Pediatrics and Neonatology, Ernakulam Medical Center. We welcome you, sir.
Good morning, everybody. Greetings from NNF Kerala. Let me express my gratitude for this great opportunity to be the opening batsman of the day on the day one of the CME, 17th of December 2021 at the great venue, Amon Resort, Bangalore. Today's topic is a very important topic as far as pediatrics and neonatology is concerned. The topic is management of shock, the algorithmic approach. Shock, as you know, is a circulatory failure which is defined as physiological state characterized by tissue hypoxia due to reduced oxygen delivery and or increased oxygen consumption or inadequate utilization. It is manifested by physical findings of tissue hypoperfusion, that is cold extremities, across cyanosis, poor capillary refill tachycardia, and metabolic acidosis. Shock is often initially reversible, but if prolonged hypoperfusion and tissue hypoxia continues, it will become critical and will result in cell death, end organ failure, and even possibly death. So to throw further light on this important topic, we have an eminent speaker this morning. It is none other than Dr. Uma Maheshwari. She is the professor and senior consultant .
Sir, you are muted, sir. We are not able to hear you.
She is the Best Poster Innovation Award in NNF 2016, Best Outgoing Student, received 5 gold medals during MBBS, published more than 30 papers in index journals, including Cochrane, and authored many chapters in books and peer review, national and international journals. She established special metabolic clinic as a part of Sri Ramchandra Center of Excellence in Perinatal Health. Over to you, Dr. Uma Maheshwari, for your talk. Algorithmic approach to shock. Thank you.
Thank you, sir, for the kind introduction. And a very good morning to one and all present here, both offline as well as online. I'm supposed to be there in Bangalore because of our NABH audit in hospital. I had to return back yesterday night itself. So thank you. I thank the organizers for the opportunity. I would appreciate if Lokesh, the person's thing is muted, because like there is some crosstalk when you are talking from the desk. Yeah, sure. I hope like the other one is muted. So am I audible? Is it clear? Yes, thank you. So without wasting much time, I'm going to talk for the next half an hour on algorithmic approach to shock. So my objective would be to make the delegates understand the basic pathophysiology of neonatal shock and the complexity of circulatory failure, parameters assessed during shock, and also on a little bit throw light on fluid therapy, inotropes, vasopressors, and steroids. And because I have been given a topic of algorithmic approach, I would like to touch upon early goal director, time-sensitive management of septic shock, and also on pathophysiology based approach. So shock is nothing but, as Ravi sir was rightly pointing out, it is a pathophysiological state characterized by imbalance between oxygen delivery and oxygen demand in the tissue, leading to tissue hypoxia. So the ultimate thing is the tissue hypoxia which is happening in shock. So definitely it is complex. We know that the assessment and everything differs. So if you take, there are various measures you can do in shock. It could be a conventional physiological monitoring in terms of measuring your blood pressure, measuring your heart rate and saturation by pulse oximetry. Or like you should definitely know the demographic details, because with that, based on that, you will be coming to a conclusion what is the etiology of shock. Of course, your lab parameters, namely hemoglobin, septic workup, and lactates will help you to lactate in terms of like how severe is the shock, septic workup in terms of etiology, and hemoglobin because oxygen carrying capacity is important. And clinical evaluation wise, if you see like we will be assessing certain parameters like capillary refill time, urinary output, respiratory parameters, including instability and temperature instability, and also skin color, how is the sensorium of the baby. And coming to the circulatory assessment, nowadays, like it will be a targeted echocardiography, which is assessed in any shock. And there are newer modalities like NIRS, non-invasive cardiac output monitoring, and pulsatility index. And if you see, I have put so many arrows, and with that, like we are going to have a clinical assessment, and we are going to make a decision. So you know that like so depending on so much complexity is shock. Okay, so now going on to the pathophysiology, we know that shock could be due to myocardial dysfunction. It could be due to abnormal peripheral vasoregulation, hypovolemia, and related to adrenal insufficiency. So if we take shock, it is a unique situation, especially in extreme preterm babies and in preterm babies, because the myocardium is immature, and your low intrauterine vascular resistance is going to get converted into a high extrauterine vascular resistance, especially if your cord clamping time is also narrow and you are not delaying cord clamping. Delayed cord clamping will help us to establish the circulation and make the hypotension less in ELBW babies. We have enough evidence for that. And also your positive intrathoracic ventilation, because the babies are not eating spontaneously, will ultimately can make a low systemic blood flow, especially in 6 to 12 hours of extreme preterm babies. So we know that myocardium is immature. There is a study published in PLOS-ONE but by McCoy, who said that like you can see the myocardial fibrils are disorganized. It will be more organized only as the baby is getting more mature. So your myocardial thickness is less in preterm baby. A cardiac myocyte is smaller and less organized, and there will be less intracellular calcium. And also to add on, you have hemodynamically significant PDA, which kind of can cause problems in your initial days. And maybe after surgical closure also, there can be hemodynamic instability because the baby is used to some form of hemodynamicity. And your vascular tone, the inflammatory mediators can increase the vascular permeability. The immaturity of the autonomic nervous system of the infant will add on to the complexity. And also this unique situation, namely related to adrenal insufficiency, because there are plenty of evidence to show that the cortisol levels are low in sick term or preterm babies. And also both adrenal insufficiency and delayed vascular response to catecholamine can contribute to vasopressin-resistant shock, which will respond only to your steroid. So there is a unique concept called as late onset circulatory collapse. So this has been like very well studied in Japan, and they being taking care of very small babies, they have come up with a diagnostic criteria. So this late onset circulatory collapse, they say it occurs outside the transition period. There will be a stable period before the onset of LCC. And you could not find any cause in terms of sepsis or NEC, which is the main cause for late onset circulatory collapse in any preterm. There will be hypotension and oliguria, which is resistant to both volume as well as inotrope. So how are you going to manage this particular late onset circulatory collapse? Is basically by giving hydrocortisone. When we kind of enumerate types of shock, it can be distributive, cardiogenic, hypovolemic, obstructive, and dissociative. I'm sure you would have heard about the terminology distributive, which happens in septic shock, cardiogenic, which happens because of myocardium being like, it could be a transient ischemia following birth asphyxia, or it can be cardiomyopathy, or it could be as a part of shock. Myocardium can get depressed. Hypovolemic, though may be rarer in babies, you have to think in terms of fetomaternal or fetoplacental hemorrhage, and in later stage NEC or your abdominal pathology can cause hypovolemic shock. All these terminologies we are all familiar with. What about obstructive and dissociative? Obstructive is because of pneumothoracis or pleural or pericardial effusions, and dissociative shock is due to methemoglobinemia. So as depicted here, your distributive is due to abnormal vascular beds, cardiogenic because of defective pump, hypovolemic because of inadequate blood volume, obstructive happens in cardiac tamponade pneumothoracis and also in your PPHN. So this is a very important etiology in any newborn, and dissociative can be methemoglobinemia or severe anemia. So coming to the assessments, so you would do a clinical assessment, namely heart rate, capillary refill time, cold peripheries or warm peripheries, urine output, level of consciousness, vitals in terms of heart rate, saturations and blood pressure, lab parameters in terms of lactate and central venous saturation, central venous oxygen saturation, septic workup, hemoglobin, and echo assessment is very important to rule out congenital heart disease, which also can present as shock in newborn baby, and your important PPHN, and also functional assessment. Others would include your central venous pressure monitoring. So basically, first we will go to the clinical assessment, namely heart rate. So heart rate, if it is a mild tachycardia, it is supposed to increase your cardiac output, because we know that the cardiac output is nothing but heart rate into stroke volume. But if you have a significant tachycardia, it results in impaired diastolic filling and also impaired coronary blood flow, which in turn causes impaired cardiac function, leading on to poor cardiac output. Or there could be significant bradycardia, which again obviously will lead on to poor cardiac output. So heart rate is an important parameter to measure. Next is coming to blood pressure. So where does your blood pressure fit in? So blood pressure is nothing but your cardiac output into your systemic vascular resistance. Cardiac output is basically your systolic blood pressure, and your systemic vascular resistance is your diastolic blood pressure. And Of course, your cardiac output will depend on your heart rate and stroke volume. Stroke volume will again depend on your preload. So preload problem can happen whenever there is a hypovolemia. Cardiac contractility, whenever there is a poor cardiac contractility. Afterload problem, whenever you have a high or low afterload. And of course, this peripheral systemic vascular resistance, mainly it has a role in your PD or your warm shock, where there is peripheral vasodilation with reduced systemic vascular resistance. Okay, so coming a little bit to the details of like how this blood pressure behaves in the initial period. The changes in blood pressure in the first 24 hours do not correlate. If you see a study which is done in 1998 and also in 2008, you can see the scatter plot of mean arterial blood pressure against your cerebral blood flow and against your SVC flow. You can see that the scatter is really scattered and it is not. It is having a poor correlation with either the cerebral blood flow or SVC blood flow. So we come up with a concept, namely permissive hypotension. So you can say that, okay, if there is hypotensive in preterm baby, within first 24 hours, you can wait and watch as long as you do not have other signs of shock. But after 24 hours, any blood pressure which is low, you have to take it very significantly. So what does this study adds? This is a epiphage 2 cohort. From that cohort, they have done what is the implication of isolated hypotension. And they said that this concept of permissive hypotension has to be challenged because the immediate outcome correlated well with the lower BP, even in first 3 days of life. And this is one more study published in Archives in 2016 by Batten and group. So they said any infant who is receiving antihypotensive therapy, whether the baby is responding to antihypotensive therapy or not responding to antihypotensive therapy, is significant, and it resulted in an adverse outcome at 18 to 22 months. Okay, so coming to your definition, how did they define this blood pressure? Namely, your mean BP should be at least equal to, or if it is less than the gestation age, you have to take it very significantly. This is only in a conference where there is a British Association of Perinatal Medicine. They came together, and there were only 2 neonatologists in their entire group who defined that. Okay, let us. Can you please unmute? One of the thing is mute, interfering with the talk. Can you please mute, Ashwini? Thank you. Thank you. Basically, so it just came up. After that, they said that you have to do adequate studies to say whether this concept of mean BP less than gestation age is appropriate or not. Whether there are further studies to follow up, actually that is a $1 million question. But this Focus Neo group, they came up, this is a freely available app in this focusneo.org, where they have, based on the Zubros chart, they have gestation age and what is the systolic diastolic. The beauty of it is they will even interpret for you and advise what to do. If the systolic is low, what to do, and diastolic is low, what to do. That advice also will come up in this. So that's the beauty of this Focus Neo group, and it is easily available. Next, the clinical parameter, namely capillary refill time and lactate. Though lactate is a ABG parameter, it is easily available as bedside. So I have put it in the assessment. So we all know that both flash capillary refill time as well as prolonged refill time is significant. So study investigating the relationship between the measures of like systemic blood flow and capillary refill time showed that whenever the capillary refill time is greater than 3 seconds, it had only 55% sensitivity, but the specificity was too good. But if it is going beyond 4 seconds, it is definitely correlating with the low blood flow status, especially when it is associated with the lactate of more than 4. So you can remember 4 and 4. Lactate of more than 4 and prolonged CRT of more than 4 has a 97% specificity, which is too good. So whenever we are doing a clinical assessment, of course, though warm shock may be rarer in a newborn period, even in the presence of sepsis, we have most often seeing cold shock with decreased pulses, with the prolonged capillary refill time and mottled skin. Sometimes we can kind of see warm shock also with bounding pulse, flash CFT and flash. The non-specific finding would include increased irritability or like lethargy, decreased sensorium, etc. So coming on to this particular parameter, namely cerebral venous oxygen saturation. So what is it? We all studied that the shock is nothing but the imbalance between oxygen delivery and oxygen consumption. So whenever there is a imbalance between oxygen delivery and consumption, we know that it is shock. So how do you assess? You assess by central venous oxygen saturation. So what is central venous oxygen saturation? It is oxygen saturation which is taken very near to the right atrium. So in your newborn baby, if you have an umbilical venous line in place, if you are taking sample from that, then you can call that as a central venous oxygen saturations. So basically, you have to understand this concept about extraction ratio. You have oxygen consumption and oxygen delivery. Whenever there is a discrepancy, your extraction ratio might increase. So basically, if you see here, this x-axis is nothing but how much of oxygen is being delivered, VO2, and VO2 is like how much of oxygen is being utilized or consumed. So if you start from this particular point where your delivery is normal, as the delivery is reducing because of early stage of shock, your extraction will increase to maintain your SVO2. But after this particular point, your tissue hypoxia will set in, and that is the same period where your lactate will start increasing. Okay, so what basically we need to understand is, if the SVO2 is showing a lower values, you will expect something above 65 to 70%. If it is showing a lower value, then you know that your oxygen delivery is impaired, even though the consumption is being maintained because of increased extraction. But it can compensate only up to certain level, after which it becomes dependent on the delivery of the oxygen. So at this point where tissue hypoxia sets in, you have to take care of hemoglobin also, because oxygen carrying capacity depends on hemoglobin also. So whenever there is a discrepancy between your oxygen delivery and oxygen consumption, either your venous oxygen saturation reduces, or if it is very high, like it remains in 85, you know that there is a lot of tissue damage and there is no oxygen extraction happening. So this you have to remember. So the next parameter is near infrared spectrometry, NIRS. It is coming up in a larger way and it measures the regional oxygen saturation. In circulatory failure, we know that end organ perfusion is more important and cerebral perfusion depends on the circulation. So what about studies done? In this particular study by Dr. Thomas et al. Group, where they studied about low blood pressure and neurodevelopmental outcome. So what they found is, regardless of whether the neonates were hypotensive, a regional cerebral oxygen saturation of less than 50% was associated with the lower neurodevelopmental outcome score. So this suggests that maybe you have to include in your clinical care NIRS also as a protocol. So, so this is a very important concept, because we are talking about the disparity between oxygen delivery and oxygen consumption, and also the tissue perfusion. Maybe the regional cerebral oxygen saturation will directly reflect the tissue perfusion. But is it standing for good? So they conducted a safe boost trial, which is a phase 2 randomized trial, where they intervened whenever there is a regional cerebral oxygenation saturation of less than 50% or greater than 85%, but they did not find any difference in the long-term outcome in terms of benefit or harm. Maybe this is only one study including 115 babies. So maybe we should come up with more studies to see whether this NIRS is really correlating or not. So next, moving on to your preload assessment. So preload assessment, whenever preload, we know that we have to think about fluid. whenever we are thinking about fluid, we have to automatically remember this Frank-Starling law, because we know that in this curve, the left ventricular diastolic volume is directly correlating to the stroke volume. For the same, if your end diastolic volume is increased by giving a volume, the stroke volume can can I request the delegates to mute? Sorry, like there is some interference. I request all the delegates to mute. Thank you. So, okay, this looks very lucrative. Okay, so maybe if we give fluid, all will be settled. But if you see in the neonatal or fetal period, the response for the preload is it's not as good as an adult or a pediatric population, and it is masked. So we all know that echocardiography has to be assessed in terms of IVC filling, changes during inspiration and expiration, and also an important concept, namely intracardiac filling. Whether your intracardiac filling is adequate or not also has to be assessed for preload. So next is coming to your contractility. So contractility is assessed directly by your echocardiography in terms of eyeballing, and also quantitative assessment of ventricular filling, including fractional shortening, ejection fraction, and also your Doppler pattern of LV filling. So you can assess your right ventricular outflow and left ventricular outflow. Sorry, one second. Hello, anything? Okay, okay. So should I carry on or should I wait? Okay. The online participants, there is a power cut in the hall. So the organizers have asked me to wait to sort it out. Sorry for the technical glitches. So once the organizers are saying, maybe I should be resuming. Till then, the online participants kindly hold on, because there are some delegates in the hall also. So we'll be waiting for them to sort this out. Till then, like if there are any questions or any discussion which we can do in online with the online participants, I'm happy to take them. Are there any discussion from the delegates from online? Sorry, I just gave a call to organizers. They are trying to connect it. We'll just wait for 2 minutes for them to sort out. Those who join, the delegates who have joined now, I think we are just waiting for the organizers to sort out the power problem. So kindly wait, those who have joined online. Can I start back? Organizers, can you please tell whether I can start back? Has it been connected? As I can see Lokesh joining. Organizers? Can I start? Can I resume?
Hello.
I'm not able to hear you.
Hello, ma'am. Can you hear us?
Yes. I can hear you now. Yes. Can I start?
Yes, ma'am. Sorry for the inconvenience.
Oh, no issues. Yeah. So we were talking about the cardiac contractility. So am I audible and my screen visible? Am I audible and my screen visible?
Yes, ma'am. Yes.
Yes. Thank you. So coming to the contractility, we all know that echocardiographic assessment of eyeballing or quantitative assessment of ventricular function is important. Assessment of RV output and LV output is important. But having said that, this has some flaw because of the presence of can you please mute Lokesh? Whomever is there as Lokesh, can you please mute? Thank you. So assessment of SVC flow is very near to cardiac output monitoring. So coming to management, I'll quickly go through the fluid therapy, which we already discussed, and also the inotropic and vasopressor support and hydrocortisone. In this chart, as you are going down and down, the vasopressor effect is increased, and as you are going up and up, inotropic effect is increased. So milrinone is an inodilator. Dobutamine acts mainly in the heart and causes increased cardiac contractility. Epinephrine in your low dose increases the cardiac contractility, whereas in your higher doses, it acts like a vasopressor. Dopamine, it has mainly a vasopressor effect. Your main doses of like 1 to 4 microgram in renal and splanchnic and etc. would not hold good for a preterm baby. They are very sensitive to dopamine and directly acts in catecholamine receptors, and norepinephrine acts mostly in peripheral and vasopressin in the vasopressor receptors. So if you see this beautiful diagram, then the myocardium, you have alpha 1 and beta 1. In your peripheral vasculature, you have your alpha 1, which releases norepinephrine, which acts on alpha 1 to cause vasoconstriction, and beta 2 directly can cause reduced vasoconstriction. So your dopamine will act on alpha 1, alpha 2, and beta 1, and your dobutamine will act mainly on beta receptors. Your adrenaline on top of beta 1 and beta 2, it acts also on alpha 1. Noradrenaline acts basically on alpha 1 and alpha 2. And your hydrocortisone has multiple mechanisms in terms of reducing your catecholamine metabolism, reducing the capillary leak, and also it has a genomic effect in increasing your receptors. So dopamine, very well studied. Because it increases the BP does not necessarily mean that it increases the LV output. The study by this Zhang et al. In 1999 showed that even though it increased the blood pressure, it can change the left ventricular output. Hello? Yes? Okay, okay. So till till this point there was a power. Okay. Okay. Thank you. Sorry again, the delegates, online delegates. There is a power cut from. I got a call from organizers saying that there is a power cut in the hall, so they are sorting it out. We will wait for a couple of minutes for them to sort out. Meanwhile, if you have any questions or interaction, I'm happy to answer. You can unmute and ask if you have any queries, or you can put in chat box. Hello? Okay. Am I audible and is my screen visible? Yeah. Okay. Sorry about the interruption. So dopamine, as I was telling, though it increased blood pressure, the studies, some studies have shown that it can reduce the left ventricular outflow. So whether what is the evidence available, should dopamine be used as a first line of medication? This is summing up of Cochrane review. Definitely dopamine is significantly reduced the treatment failure, namely like it increases the blood pressure, though there was no change in the mortality, PVL or PVH. So there are many studies where they compared head-to-head dopamine and hydrocortisone. And this HIP study, they came up, they wanted to study dopamine in a very systematic randomized manner, and they did for 10 years. But they lacked power and they did not find any difference between standard and restrictive group. But they said that conducting studies in cardiovascular instability was very much challenging. And they also said that dopamine did not affect the regional cerebral oxygenation. And both hypotension and cerebral hypoxia were associated with early intraventricular hemorrhage and death. And there are like many studies, and what we know is dopamine is well studied. Recent meta-analysis showed that dopamine could be used as first line, and pathophysiological approach is better. So I am going to move on to early goal-directed therapy. So early goal-directed therapy is in sepsis surveillance guidelines. I'll quickly go through. So you have to, at 0 minute, you need to recognize that there is reduced perfusion and you have to maintain airway according to NRP guidelines. At 5th minute, you should have pushed 10 ml of amoxicillin. You can give up to 40 ml. and correct hypoglycemia and hypocalcemia, and also think of prostine to rule out drug-dependent lesion and start antibiotics. At 15th minute, decide whether it is fluid refractory. You infuse dopamine plus or minus dobutamine, and in after that, you recognize whether it is a fluid refractory dopamine shock, and you give epinephrine for cold shock and norepinephrine for warm shock. At 60th minute, you recognize whether it is a catecholamine resistant shock. At that time, like of course, your preterm babies and many sick term babies are also at increased risk of adrenal insufficiency. So you can go ahead with giving hydrocortisone to achieve the endpoint, namely normal MAP CVP, SVO2 of greater than 70%, and with your SVC flow of greater than 40 ml. So if it is refractory shock, like of course, after giving hydrocortisone and T3 for hypothyroidism, you can decide on ECMO. And this study by D. Oliveira in pediatrics, they found that this early goal-directed therapy is successful to optimize outcome in pediatric age group. So what about pathophysiology-based approach? Whenever there is a systemic hypotension associated with your reduction in systolic or diastolic BP, you have to approach in this manner. Namely, if systolic BP is reduced, you can think about what is the pathophysiology behind. Is it because of your PPHN, which causes your reduced, you can take measures to reduce your PVR, or is it because of your cold septic shock, where there is a decrease in the myocardium, where you can improve your myocardial performance by giving dobutamine or epinephrine? Or is it cardiogenic shock, again ruling out arrhythmias, whether you have to improve your myocardial systemic performance, giving dobutamine and epinephrine? Remember here, we are not using dopamine as a first line. We are going by pathophysiology-based approach. Again, if your diastolic BP is less, see whether there is systemic hypovolemia and give a bolus. And if it is a warm shock, you can give pressors because there is a lot of vasodilatation. If there is a PDA, try to close your PDA. If there is both systolic as well as diastolic, which is reduced, it will be same spectrum, starting as PPHN or cardiogenic shock and worsening, or it could be same hypovolemia or warm shock or PDA, which is worsening. Of course, at this point, you need to think about adding hydrocortisone also whenever there is a decreased systolic as well as diastolic dysfunction. So I already spoke about this late onset circulatory collapse, where you have to use hydrocortisone as a treatment modality. So coming on to my last slide, take home message, we say that you cannot fit in everything with one size. A simple algorithmic approach would not fit in all. So though my topic is algorithmic approach to shock, you have to remember what is the pathophysiology behind the shock, because it is not a simple thing. It is a circulatory failure and reduction in perfusion. Low BP is a surrogate marker. However, circulatory failure should be assessed. Use of targeted neonatal echocardiography. In your septic shock, you can go for early goal-directed therapy because in pediatrics, it has changed some outcome. And other types of shock, you can go for pathophysiology-based approach. Dynamic change in the status in any particular neonate. You cannot think that, okay, only one pathophysiology will fit in for any particular baby. Initially, it can be myocardial dysfunction, moving on to a hemodynamically significant PDA, moving on to your PPHN. So your dynamicity should be taken into account. Thank you so much for your patience. So I'm happy to answer if there are any questions. Sir, Ravi sir.
There may be some questions from the audience. So you can make a point or two, one or two questions maximum.
Thank you. My question is, can you hear Dr. Uma?
Yes.
Yeah, this is about gynotropes of salts that mention adrenaline infusion, low dose adrenaline infusion for extreme symptom. How about the outcome of using low dose adrenaline? About the CNS outcome and the intraventricular. We found the babies who are put on low dose adrenaline to have a lot of intraventricular bleed or adverse neurological outcome. Do you have any data on
Thank you, ma'am. Thank you for the question. Actually, we in our unit we do use low dose adrenaline. So when you think can I request the delegates to mute? There is a lot of interference. All the delegates, can you please mute your mic? Thank you. So basically, if it is basically cardiogenic and you want to improve the myocardial performance, yes, of course, epinephrine in a low dose, starting with 0.05 and escalating up to a maximum of 0.3 microgram per kg per minute has worked for us. Though we do not have a systematic data to analyze like how was the outcome, but definitely for fewer babies where myocardial performance is the problem, it has worked. The worry is increasing lactate or increasing hyperglycemia in terms of epinephrine. So what we should be doing is we should be sitting bedside and titrating the adrenaline in a very close manner, and we have to titrate so quickly that even in 8 to 12 hours, you should be able to come off the adrenaline once the shock improves. That is how we do. Of course, dobutamine you can continue for a longer period, but if the response to dobutamine is poor, there is no point in keeping on escalating dobutamine, because sometimes it can even cause tachycardia, and that will cause reduced diastolic filling. So we switch over to adrenaline. We have not faced any intraventricular hemorrhage because of usage of adrenaline as such.
Excellent talk. I just wanted to ask, are there any, if you don't have an echocardiography facility, then are there any clinical markers to add milrinone if the patient is catecholamine and volume resistant shock?
Basically, PPHN can be a clinical diagnosis. So milrinone, you will be considering when it's basically if you have had an echocardiographic facility, you will be considering whenever there is a cardiac dysfunction with a normal blood pressure. Because especially at a loading dose of milrinone can bring your blood pressure down. But if you do not have echocardiographic facility, then I will be very careful about my volume also, because volume can be a little bit tricky unless you think that there is a definite septic pathology behind it. I would definitely not give more than 10 ml per kg. I would not be keeping on giving. And if the blood pressures are normal and you think your clinical diagnosis is PPHN and you have reasonably ruled out structural heart disease, which is little difficult without the facility of echocardiography, then definitely you can go ahead with milrinone. Only caveat is you have to have your normal blood pressures. So you can use your pressors. If PPHN is your diagnosis, you can use pressors to increase your systolic blood pressure. Then you can add on milrinone. And if you have to choose a pressor, vasopressor will be the drug of choice because it is known to cause some amount of pulmonary vasodilation. There are a lot of case series which they have studied where it causes pulmonary vasodilation. So it is going to help in both ways. It causes it increases the systemic vascular resistance and the systemic BP. At the same time, it will help in reduction of your right to left shunt.
Thank you.
So there are no more questions. We will wind up. Thank you very much for this opportunity.
Thank you so much for the opportunity, and I thank once more. And I'm sorry about not able to participate offline, though I planned initially.
So please start, sir.
Ashwini sir, you can start. Your PPT is projected.
Okay, fine. Good morning, everyone. It is my privilege that I've been given this opportunity to talk about a very, let us say, an emerging topic on fetal inflammatory response syndrome. My apologies for not being able to attend physically. I booked the tickets, but then keeping the circumstances in view, had to cancel it. Would have loved to see all of you physically. And now when I got this mail from an NF to talk about fetal inflammatory response syndrome, my first thing was why this topic? And as I said, okay, fine, let us see what it is. And then I was before just going through the entire topic, I felt this is something that we need to know as of today, because perhaps this is the future that we are looking at. So coming to fetal inflammatory response syndrome, I'm pretty sure that many people would not have even heard the term fetal inflammatory response syndrome. And that's no surprise. Some of my senior colleagues with more than 20 years of experience asked me what the topic is. Is it FIRS or is it NIRS? So nothing wrong in not knowing about the concept. Perhaps I also heard the first time the terminology fetal inflammatory response syndrome. Now, the concept of FIRS is the fetal counterpart of systemic inflammatory response syndrome. And now I know that every MD pediatrics would have heard the word SIRS, or systemic inflammatory response syndrome, which was first introduced in the year 1992. And realized that FIRS as a terminology began as far ago as 1997. But perhaps it has now become more relevant in the era of COVID. It is characterized by a systemic inflammation of the fetus, as we see in SIRS. It involves involvement of multiple organs in the body, and it is a response of the fetus to inflammation of the amniotic fluid, or it could be a response to the placental fetal circulation, something in the circulation which triggers the immune response. Next slide, please. Now, before I move further into FIRS, we need to understand SIRS a bit. Now, and perhaps the same thing happens in FIRS. SIRS two phases, or let us say two components. One is a pro-inflammatory component, which predominates in the early phase. It is the immune response of the individual to the insult, which could be an infection or anything else, and it causes early morbidities and early mortality. But simultaneously with the pro-inflammatory response starts an anti-inflammatory response. It is not the predominant response early in the course of a disease, but predominates later once the person has become okay, or the pro-inflammatory response has subsided. It is more a dysregulated adaptive response of the individual, and perhaps this is what is responsible for the late manifestations of a disease which an individual has. This could be late sepsis or symptoms which prolong for a long period, as we know now, even in COVID, or reactivation of viral infections. And it is known that babies who recover from a FIRS end up with an increased risk of late onset sepsis. We've been wondering for years what's been happening to our babies, and perhaps FIRS explains some of those wonders that happens in our babies, where we cannot explain the pathology of the baby. Next slide, please. Now, there are two types of FIRS before we move further. One is the typical FIRS, which is the intraamniotic inflammation, the acute inflammatory lesions in the placenta and the cord, associated with rise in typical inflammatory markers, including IL-6, a cytokine storm, and the baby is sick. This could be intrauterine, or this could be just after birth. The other type of FIRS, which I'll just finish here because not much is known about this FIRS even today, is a sort of maternal anti-fetus rejection. Now, we know that that PIH syndrome, the syndrome of PIH and growth restriction is perhaps an autoimmune reaction or an autoimmune reaction of the mother to the fetus. And this is where, again, the immune response of the fetus is stimulated. There are chronic lesions in the placenta. The markers which can identify a type 2 reaction are different, and it causes more of an immune suppression in the baby. And perhaps this is why some of those problems which occur in babies who are growth restricted, like an increased risk of NEC or for that matter, the brain lesions which come in babies who have not had any chorioamnionitis, is perhaps of a type 2 FIRS. Giving the type 2 here only because otherwise we are delving into a thing which is largely less understood. We will stick ourselves to type 1. Next slide, please. Now, coming to an overview of what does this type 1 FIRS cause? Now, typically an intraamniotic inflammation or infection, predominantly the inflammation is caused by infection, leads to either preterm labor without PRM or preterm labor with PRM, both resulting in a preterm delivery. We are very conversant that babies who are born with preterm labor, and that is one of the biggest risk factors for early onset sepsis. They land up with early onset sepsis, and that is easily understood that the baby has a sepsis, so all the symptoms of the baby are explained by sepsis. But so many times we get babies who are not septic as far as cultures are concerned, but behave like the so-called culture negative sepsis. Now, these are the babies who may be more having a no sepsis sort of SIRS, which increases the risk of morbidities, which may not be amenable to antibiotic treatment. And perhaps we need to look at other places to find a management of such babies. Next, please. Now, typically, FIRS has been defined as an elevation of cytokines in the umbilical cord blood. We need to realize that there could be chorioamnionitis, but that does not really translate into the baby being affected. Now, very few babies with chorioamnitis would have definitely infection, although that's again a major risk factor. So not more than 20% of babies with chorioamnitis would have a positive culture. But elevation of cytokines in umbilical cord blood, predominantly IL-6, more than 11 picogram per ml, or presence of acute phase reactants at birth or in the cord blood before birth of the fetus, or a presence of phenicitis. Now, phenicitis means an inflammation of the cord, and this is a histological diagnosis. It's the histological counterpart of elevated IL-6 or a CRP. Either of these could actually signal that the baby has a fetal inflammatory response syndrome, or the fetus has a fetal inflammatory response syndrome, or the baby after birth has a FIRS. Next slide.
Next slide.
Next slide, please. Just a word about CRP and phenicitis. If you were to grade CRP, now realize this is a CRP which is the highly sensitive CRP which we need to do, not the CRP we routinely get in our labs, although HSCRP is also easily available, especially in places where there are cardiac facilities. But most good labs will give you a HSCRP, although the turnaround time is higher than a normal CRP. If you were to grade the level of CRP vis-a-vis the degree of phenicitis, we realize as the CRP increases, the phenicitis is higher. So if we have stage 3 phenicitis, the CRPs are much higher compared to a lower grades of phenicitis. Next slide, please. Now, one question which arises, why was IL-6 chosen as one of the markers for defining FIRS? As I said, FIRS is defined way back in the 1990s. So at that time, it was one of the easily available cytokines which could be measured compared to the other cytokines, which have now become available. But then again, IL-6 still remains the standard for defining FIRS. The second thing is it can be measured both in amniotic fluid and the umbilical cord blood. Now we know that, yes, we need to compare the inflammation in the placental unit vis-a-vis the inflammation in the baby or the fetus. And it is also a major mediator of acute phase reaction in the baby. That is, IL-6 precedes the appearance of acute phase reactants like CRP in the blood. So perhaps it's an earlier marker compared to some of the other markers. And now this is a slide from 1990s. From 1990s, when the definition of FIRS was coined, and if you look at this slide clearly, the relationship between IL-6 and preterm delivery, perhaps this could give us an insight which of the babies are going to deliver and which are not. Remember, this is IL-6 in the fetus done after chordosynthesis, and if we see fetal plasma, if IL-6 is more than 11, we see the most of the babies would deliver by the end of the week after the procedure. Whereas if the IL-6 is less than 11, the babies would continue to remain in utero. So clearly establishing a link between the fetal IL-6 and the delivery. We've always considered that delivery is more related to the placenta and the membranes. But this was one which established that fetus does play a role in getting out of the mother once it is compromised. Next slide. From the same study, if we look at, these are small numbers, but if we were to look at, if both the amniotic fluid IL-6 and the fetal IL-6, they were low, less number of babies. The procedure to delivery interval range was up to 33 days. Similarly, if only amniotic fluid IL-6 was raised, again, the range extended up to the baby could remain in utero for more than 4 weeks. But as soon as we say that the IL-6 in the baby was higher, in the fetus was higher, look at categories 3 and 4, the number of hours or days the babies remain in utero just drastically drops. The numbers may be small, but the trend is extremely clear that if the baby has higher IL-6, the fetus has higher IL-6. I'm sorry using the word baby again and again, but it's the fetus. If has higher IL-6, chances of fetus getting out of the mother is extremely high. So what is the clinical significance? Next slide. That higher IL-6 in the baby, in the fetus, or FIRS in the baby causes spontaneous onset of labor. Coming to the next slide. Let's correlate, is it IL-6 just causes the baby to come out, or there is something else? And let's look at this plot. Severe neonatal morbidity, a high IL-6 on the red and a low IL-6 on the, or less than 11 in the blue. Across the gestations, the risk of fetal morbidities, the common fetal morbidities, is higher if the fetus has high IL-6. Now, I don't think we've considered this, that fetuses have been programmed in utero to have more morbidities, rather than we believe that we are responsible, or some of the external factors after the baby is born is responsible for some of the morbidities. I would come to that again, but realize this has some medico-legal implications, that some babies are now programmed to have more morbidity, a more turbulent course in the neonatal ICU than whatever we may do once the baby is born, compared to babies who are going to be stable. And that is our experience now. That's surprisingly our experience. Some of the preterm babies would just sail through without any complications, and some in the same ICU would just have an extremely turbulent course or may not even survive. So, next slide. The second clinical significance of FIRS is a higher rate of neonatal morbidity. Next slide, please. Now, those were the studies which were done in the early phase of defining FIRS, 1990s. But if we look at, we are all fond of meta-analysis. If we look at a meta-analysis of more than 1,000 units, these are observational studies, organ dysfunction is higher with a higher CORD IL-6 or CRP, which could be in early onset sepsis, a bronchopulmonary dysplasia, more than 6%, 6 times risk, and we'll go into some of the mechanisms. Intraventricular hemorrhage, a higher risk, a periventricular leukemia, a higher risk, a respiratory distress syndrome, which may sometimes be even lower, but in the meta-analysis, it conferred a higher risk in babies with FIRS and increased risk of death. Now, perhaps the time may be coming when we would be predicting the neonatal outcomes by measuring some of the cytokines in the baby at birth or maybe in utero. Also, IL-6 has been associated with increased risk of and progression of severe ROP, and also a systemic inflammatory response, as I said earlier, clinical suspected sepsis with negative culture. Next slide. So we say that FIRS is associated with a spontaneous onset of labor, a higher risk of neonatal morbidity, and changes or dysfunction in multiple organ systems. Now let's look at some of the organ systems involved. Next slide. Next, please. It has been seen that babies who are born through chorioamnitis in some of these studies have decreased risk of respiratory distress syndrome. Now, this decrease in RDS is believed to occur because onset of an FIRS in the baby increases the production of endogenous steroids, and that may actually decrease the risk of respiratory distress syndrome in the babies. And some of the studies did show a decreased risk of respiratory distress syndrome in babies born through chorioamnitis. And in fact, some of the earlier studies which showed even decreased risk of RDS in babies who are growth restricted, and that would be the FIRS stimulating the endogenous hormones. But some of the other morbidities, the new age, the PPHN is higher because some of the vascular remodeling is again dependent on the inflammatory response. There is change in blood pressures, and those actually remodel the pulmonary vasculature. But coming to the more important increase in BPD, the silent BPD, BPD in babies who've never been ventilated or babies who've never had a respiratory pathology in the first 2 weeks of life, we are increasingly seeing babies would not need oxygen in the first 2 weeks, 3 weeks, or 4 weeks, and then go on to require increasing oxygen. Now, one of the reasons behind this increasing BPD is FIRS in the new age BPD. The reason being there is a direct tissue damage due to inflammation, there is modulation of cytokines, and that is what is causing the BPD to increase in babies who've never been ventilated. Next slide. FIRS is known to cause, like any systemic inflammatory response, even in adults, causes hypotension, causes vasoconstriction, but more importantly, decreased cerebral blood flow. Now, hypotension with decreased cerebral blood flow, we know is a precursor for cerebral palsy. We need to understand that, yes, next slide. Next slide. That no, please, one slide back, please. One slide back, please. So, no, the brain, the next slide. Okay. The cytokines can have a direct damaging effect on the brain. They can also increase the permeability of the blood-brain barrier, and decreased blood flow, which is associated with a systemic inflammatory response or a fetal inflammatory response, is what could cause cerebral palsy in the babies without in utero. We know that only around 10 to 15% of all cerebral palsy patients are associated with a sentinel event in the labor. But what about the rest of the 85%? I'm not saying all the rest of the 85% are secondary to FIRS, but sometimes we do see lesions in the brain at birth which are inexplicable. A PVL present at birth, or this could be related to an episode of FIRS which occurred, which resolved and has left a sequelae in the baby. So we need to be careful in assessing the baby at birth, and perhaps this again has a medical legal implication, whereby if we could document a PVL at birth, then the liability of the treating physician in the so-called causation of cerebral palsy would be lesser. Next slide.
Nowadays,
Looking at asphyxia, we've seen many times that the reassuring fetal heart rate resistance, a reasonable umbilical cord blood gases, the babies behave like this. Now, neonatal encephalopathy occurs in approximately 3 per 1,000 live births in developed countries, and HIE is one of the potential causes of.
Select করছি কো হোল্ডার ভালো ভালো টপিক সেটাই
Previous slide, please.
ಶೇರ್ ಮಾಡಿದೀನಿ ನಾನು ಬೇಟ ಮಾಡಕ
Can I have slide 20? Yeah.
देखिए आज बस सोइटी रेस्ट
HIE is a potential cause of neonatal encephalopathy. Now, one has to consider FIRS as a possible etiology of neonatal encephalopathy, even when there is lack of evidence of HIE injury. And that is because of, again, systemic inflammatory response. So the damage has occurred in utero. The baby appears well at birth, but has difficult time transitioning, has a prolonged low Apgar scores. The metabolic acidosis, the cord bloods were reasonably okay, but there is metabolic acidosis which progresses after birth, and the baby lands up with all features of neonatal HIE. FIRS is one of the causes. Next slide. Now, what causes the pathophysiology behind this sort of asphyxia is a placental venous edema, which decreases the transport of gases to the baby, the increased oxygen consumption by maternal hyperthermia, and the cytokine-mediated hemodynamic perturbations. The baby already has the cytokines, so it will be very difficult to resuscitate such a baby, thinking that obviously the baby cried at birth, and then subsequently we say the babies have features of asphyxia and have a fight with their obstetricians. No, the baby was. We realized that we would not be attending all the deliveries, and then again, there is sort of this mistrust between the obstetrician and the neonatologist or the pediatrician, that the baby did cry at birth or the baby did not. Realize baby cried at birth, but baby could have asphyxia secondary to FIRS. Next slide, please. FIRS does not only affect these major organs, the other things which, and we see that neutrophilia, neutropenia are elevated nucleated RBCs, neutropenia and elevated NRBCs we see in babies with growth restriction, and that is some of the genomic effects of a low grade FIRS or type 2 FIRS which occurs in fetuses. Thrombocytopenia extremely common, and we tend to always blame thrombocytopenia on the sepsis, which could be the major reason for thrombocytopenia in the neonatal ICU. But then thrombocytopenia is almost always universal in babies with type 2 FIRS, and perhaps getting a platelet count at birth would reveal the true extent of the problem. The transient hypothyroxemia of prematurity, the thymic involution and retinopathy of prematurity are some of the other effects. So overall affecting, if you'd seen the first slide clearly, we say that FIRS does affect almost all organs in the body. So the endocrine glands, the thymus, the immune system, the retina are not spared either. Next, please. We also know that SIP and NEC are important problems when we are dealing with very small babies. And one of the causes for SIP, which we've not been able to really pinpoint, is a fetal programming or fetal inflammatory response, because SIP occurs very early. And same is true for necrotizing enterocolitis. We end up blaming not using breast milk or rapid progression or decreased blood flow. But what does and how does the decreased blood flow to the intestine result in NEC? It is the low-grade inflammation which is already there in the intestines. And on top of that, we get a full-blown necrotizing enterocolitis. Also, because FIRS leads to increasing steroid levels in the baby, so this could be a part of fetal programming, which all of us are aware of in terms of the fetal origin of the adult diseases. One of the reasons could be FIRS. Next slide, please. Now, coming to what can we do for the FIRS? I've
Mysore Pak original.
Please mute themselves so that people
Those कर दो
who
खाई
are
जाने
interested in the talk can really look at it and really listen to it. Thank you. Okay, coming to interventions, now we said that FIRS is and perhaps is responsible for many of the problems we anticipate, which we are unable to explain. So what are the interventions which are available to us to really decrease the risk of FIRS and its implications? Now, first is delivery of the fetus. Next slide. Obviously, if the baby is in a hostile environment, it is better to get the baby out. But then there is a balance which needs to be maintained between the hostile environment and the prematurity. So it is ideal to have the baby out because the environment needs to be if a person is in the fire, we need to take the person out of the fire. But we also need to say that till we take the person out of the fire, the damage continues. So, but then we impose an extra risk of prematurity, and it would be really nice if we could just extinguish the fire there and let the preterm grow. So the balance, as of today, we don't know what the balance is. When should the baby be taken out? Although, as we've seen earlier, most of the time nature does it for us, that once the baby is compromised, the baby does come out. Antibiotic treatment, we've been doing that for years, although the evidence, the hardcore evidence is for preterm PROM only, that yes, antibiotics do reduce the risk to the baby, but then antibiotics, some of the obstetricians would swear by the fact that giving antibiotics to mothers with cervical insufficiency or spontaneous preterm delivery with intact membranes does improve the neonatal outcomes. Now, perhaps we need to look at those neonatal outcomes in the long term in a larger study, and also compare that in babies who had an FIRS vis-a-vis babies who did not have an FIRS. So antibiotic treatment is another thing which is easily available. Now we're looking at the easy approaches, but we know that some of these easy approaches would not work in the setting of FIRS. Next slide. A new interesting thing would be an immunomodulatory approach, the IL-1 or IL-6 or IL-6 receptor antibodies. These could be the things to try, although, and these things have been tried in animal models and found to be successful to a large extent in ameliorating some of the problems associated with FIRS. But as of today, I really don't think that we would be really utilizing these modalities in the setting of FIRS. The other approach could be using, next slide. The other thing would be using a combinations like antibiotics and immunomodulatory agents. Realize dexamethasone and indomethacin also come in the same category, and indomethacin was used quite frequently in the prenatal period earlier as a tocolytic agent. It also is an anti-inflammatory agent and perhaps does decrease the intraamniotic inflammation, suppressing the local inflammatory response. And it does prolong gestation in experimental preterm labor induced by group B streptococci. So perhaps some of the old wines in new bottles with new combinations may work in this settings. Next slide. But then I think that I know this is an extremely crowded slide. But if you were to look at it carefully, there are a host of molecules which are available, which are being tried or which have been tried in animal models to suppress the FIRS. Reason they have not been used is we're still looking at a non-invasive way of diagnosing FIRS. And once we are there in that, perhaps the time would be ripe to really utilize some of these molecules and see if we can make a difference to the preterm delivery rates in babies who are going to born preterm, or to the complications in the preterm, the exact timing when these drugs are to be used. And these include some of the things like magnesium sulfate. We already are using that. It just the balance which needs. Another interesting thing is the pomegranate juice which is there, and I read somewhere the only thing which is known to reverse aging is perhaps the reversal of aging, not the delaying of aging, is pomegranate juice. And perhaps some of the extracts out of that could be utilized for suppressing some of the inflammation in the baby. Next slide. A word about FIRS and COVID. Now, I know many of the neonatal ICUs have seen this multi-system inflammatory response syndrome, which is post-COVID, the MISC neonatal manifestation. And perhaps this is the first time we are saying that, yes, the fetus has been really markedly affected by a disease which occurred far away in the mother, not in the near vicinity of delivery, and still the baby is affected. And most of the MISN are actually the FIRS. You will not be able to isolate the virus from the baby, but the multi-system involvement is the hallmark, including the heart. And in fact, most neonatal units would say it's extremely difficult to manage a baby with MISN and who has multi-system involvement. And it is definitely immune mediated. Sorry for the typo. And we've been using IVIG and steroids to really take care of babies with MISN and secondary to COVID, and that really works. So perhaps the first time we've successfully used a method to treat the FIRS that occurs and that manifests in the neonatal period. And we know that those high CRPs are not always due to the perinatal region, part of the fetus's life, or the immediate neonatal or secondary to infection, which are the typical bacterial infections. We've had high CRPs more than 200 or 300 secondary to MISN, and even without antibiotics, these babies do well. But we also need to understand that because it is FIRS, it does suppress the immune system, and you could have long-term manifestations, including increased risk of other infections. We need to follow that up. In fact, we had a baby quite recently who had an early onset sepsis and who had an MISC, and it is very difficult to tease the two apart. We just need to treat both the things together. Next slide. When I was reading FIRS, I was reminded of the terminology that my dad used to say or says that in their time, lymphocytes were supposed to be innocent bystanders with no function at all. And that, I believe, I thought about FIRS when I was reading about it, that yes, we've come a slightly a bit farther than that. We know that FIRS is not something which does not exist, but still a lot needs to be understood about FIRS before we can utilize it clinically. Some of that we are doing it, but what we need to do is, one, determine the frequency and clinical significance of FIRS in each obstetric syndrome. More importantly, in preeclampsia and fetal growth restriction, and how to really help these mothers. The preeclampsia remains or growth restriction, the idiopathic fetal growth restriction remains an enigma, remains something which needs to be solved. We've used multiple molecules, but not been able to help the mothers with fetal growth restriction to a large extent. I understand there are a few things like aspirin and calcium which would help, but some of the newer things like sildenafil have really fallen apart. So we need to look at this FIRS2 approach and then see if we can really help these mothers and babies. Next slide. The other research is develop biomarkers for rapid and practical diagnosis of fetal inflammation. How do we diagnose FIRS in utero Now, the two studies that I showed, they did a chordosynthesis, but that is not practical. It's not feasible to do a chordosynthesis in every fetus at risk and then putting the fetus at further risk secondary to chordosynthesis. So we need to have biomarkers, and I'm pretty sure that we should be able to get some in the near future. And then test whether downregulation of the fetal and neonatal inflammatory response with whatever agents, do they improve the outcomes in neonates and fetuses affected by FIRS. So that is the future research. Perhaps it is a topic for the future. People who are really research oriented need to really look into it. This is a gold mine in the research. People need to really take it up, and perhaps then some of the unanswered questions in perinatal medicine would be answered. Thank you. I'll be happy to take any questions. Thanks, Claude.
The mic Kudina.
ಮೈಕ್ ಕೊಟ್ಬಿಡು ಮೈಕ್ ಮೈಕ್ ಹಿಡ್ಕೊಂಡು ಏನ್ ಮಾಡ್ತೀವಿ.
Hello.
Any questions?
So usually we say that on the first day in neonate, even premature neonate, the CRP and these things are mainly maternal picture which we get. So and even suggesting to do placental blood or fetal blood and first day CRP to look whether it is a SIS. So how do I understand whether in case of intact membrane, I'm not talking about the baby with the PROM, how do I know whether it's a maternal infection or it's a SIRS in the children where we are waiting for the blood culture and things?
Oh, that is what I said. Now, if you get a CRP from the baby, now this is not an indication of infection. It's just an indication that the baby has an inflammatory response to a hostile environment. Now, it is very difficult to tease out that from a true sepsis the baby is having. So a high CRP on day one, 100 of CRP on day one, blood cultures are sterile, baby improves gradually. So perhaps you would be justified in just stopping antibiotics early in the baby. This CRP is not necessarily amenable to antibiotic treatment. So CRP in the baby is baby's inflammation. It is not secondary to maternal inflammation. Whether that leaves a sequelae or not, we really don't know. We really don't know. Some babies would land up with sequelae secondary to a fetal inflammatory response, and they are at higher risk. But then this baby will definitely be at a higher risk. I'm not happy to discharge them on day 2 or day 3. I would be happy to follow them at least in the first week, whether we follow that on an OPD basis or keep them in the hospital, but look at problems more diligently in such babies rather than babies who have a normal CRP following a preterm labor, and we don't start antibiotics in those babies.
Even if it is a CRP and IL-6 both is high, and then in that case, do you think of immune modulator? And if we think of it, and when it is
as of today, immune modulators based on cytokine approach or acute phase reactants, I would not say so. But then from our experience in COVID, if there is a multi-organ dysfunction, then perhaps this is the right time to really enroll children into a study and say that yes, children who have a high IL-6 and a high CRP at birth, and if we were to give them a immune modulator like an IVIG or for that matter steroids at birth, does reduce the complications. That is something that needs to be seen, but it does work in COVID, we know that, and that experience can be carried forward to the future, the other forms of FIRS that exist. So I would not suggest that we use immunomodulators today with high IL-6 and high CRPs, because this could be just pure early onset infection also. So we would need to tease that out of it. But then a baby who's critically sick on day 1 with these high markers, I today would say yes, it would not be justified in the absence of a research, but then yes, perhaps IVIG and steroids could be one of the treatments which these babies could get, and then look at the outcomes. Initial would be only observative strategy unless someone really wants to take this up and do a research on it. I believe the research is on the horizon. It is not far off than we would be using immunomodulators for such babies.
Dr. Singhal, just one query or your opinion about one of the postulation is that there is a correlation of periodontitis, maternal periodontitis with fetal inflammatory response syndrome because they share common lymphatics, oral lymphatics and uterine lymphatics, they are common, and whatever microbiota changes they are seen in the with the periodontitis in the oral cavity, they are same reflected in the amniotic fluid also. Your comments on this?
Precisely, that is what I said. We understand very little of that. This is something that that we know for long, that periodontitis is associated with preterm births also in some of these studies. So how does that cause preterm birth? A low level of inflammation in the mother transmitting into a sort of an FIRS2 in the baby? Yes, that could be one of the ways this affects the baby, not only in terms of preterm labor, but also in terms of morbidities in the baby. So our understanding of the mechanisms is just beginning, and perhaps a few years down the line, we would be able to tease out what is the marker and how can we prevent it. The proof, the brilliance would lie in preventing the adverse effects of periodontitis on the fetus and the newborn. So that is still to come. The correlation, we know it is there. How do we take care of that correlation? We still don't know. But perhaps giving antibiotics or maintaining a dental hygiene is a common sense approach. But then there could be a more specific approach. How do we handle that? And perhaps taking care of these things before pregnancy may be more important than during pregnancy.
Thank you.
Good morning, sir. Sir, when to suspect FIRS sir, in the mother, like routinely in all fetal growth restrictions, we have to go on doing IL-6 and the CRPs, the cord. Or there is any special circumstances we have to suspect FIRS?
I think maternal chorioamnionitis needs to be differentiated from the fetal inflammation. So even if you were to diagnose a maternal inflammatory response, does that affect the baby or not? The answer is we don't know as of yet. So the only thing could be in more of perinatal period. It is impossible that it has affected the baby. Mother gets a viral infection in the 6th month, 7th month of pregnancy and delivers in the 9th month. Whether that affected the baby or not, very difficult to say today, because we would not be able to do IL-6 in the cord blood. But I believe your question is more about towards the end of pregnancy. Now, one thing is, as I said, you could measure cord biomarkers, CRP and IL-6 as of today, but maybe more coming up. The other thing is phenicitis. Now, the phenicitis or umbilical cord inflammation is the histological counterpart of FIRS, the other being the biochemical, which is IL-6. So one way to really see whether the baby is affected or not is doing a cross-section of the cord and looking at evidence of phenicitis and the grade of phenicitis. And there is some evidence to suggest that if there is phenicitis, the baby is likely to be affected. So either of the things, either the biomarkers are present or phenicitis is there, the baby is likely to be affected. And these are sort of babies who could form part of the trial where immunomodulators can be tried. So the maternal inflammation does not really mean that the baby is going to be affected. A small percentage of babies born to mothers with chorionic inflammation or placental inflammation are going to be affected. That is why some of these interventions just don't work in settings, because once a small percentage is being affected, your sample sizes will go very high. So if we could really tease out those group of babies who are likely to be affected and then use interventions in or fetuses for that matter, I'll not say babies, fetuses who are going to be affected, then perhaps we would see the true impact of the interventions. I hope I was able to answer that question.
Do we have any more questions?
No more questions? Thank you so much, sir.
Thanks. It has been a privilege talking to the audience here and answering the questions.
Our next speaker is going to be Dr. Shiv Sachin, Associate Professor, Department of Pediatrics, PGIMR, Chandigarh. Qualifications, DM Neonatology. Area of interest, neonatal functional echocardiography, neonatal sepsis and septic shock. We would like to hear your presentation, sir. Thank you.
Kindly confirm, am I audible and my slides are visible? Am I audible, please? Can you confirm? Dr. Kritika or anyone, can you confirm, please? I am audible?
Yes, sir.
All right.
Yes, sir.
Thank you very much. So, thank you.
Can I just
person.
interrupt you?
Good afternoon, everyone. Sorry, good morning, everyone. It's a privilege to be part of this academic event, and I would like to thank the organizers for giving me the opportunity. So the topic which I am going to discuss is overview of newer trials in neonatology. So when I was given the topic, I searched the literature. I found over 600 RCTs or clinical trials have been published in past 1 year. And it is a daunting task and nearly impractical to cover more than a handful of studies in a single half-hour session. So I would like to discuss the studies which have a direct relationship with sustainable developmental goals related to neonatal mortality, which are relevant to low and middle income countries, and which have been published in past 1 year. And hopefully I will be able to give some take-home messages, say 5 to 6 take-home messages by the end of my presentation. So let's begin our discussion with the two most important studies. The first one is antenatal dexamethasone for early preterm birth in low resource countries, published in NEJM last year, December. So this study was a WHO action trial. The basis of this study was the ACT trial, which got published in 2015, which cast shadows on the efficacy of dexamethasone in developing countries. We all know that in developed countries, that antenatal steroids, namely betamethasone, has got a significant impact on reduction of neonatal mortality and intraventricular hemorrhage. However, the ACT trial showed that possibly dexamethasone may not have that impact in developing countries, and on the contrary, it may increase the neonatal mortality. So dexamethasone was the WHO action trial collaborators framed the research question that among pregnant women aged with the gestational age of 26 to 33 weeks of gestation who are at risk of preterm birth, whether an intramuscular dexamethasone as compared to placebo is able to reduce the neonatal death, stillbirth by 28 days of life by 15%. That is from an absolute an incidence of 25% down to 21.25%. And there is possibly no increase in maternal, there is no increase in the possible maternal bacterial infections. So this was the research question. So this is the study protocol. So 26 weeks to 33 weeks, females who are at risk for preterm birth, they were randomized to dexamethasone group and placebo group. In the dexamethasone, the drug was given 6 milligram 12 hourly for 4 doses, and the similar schedule was followed in placebo group. If the mothers were not delivered, the repeat course was given after 7 days. A single course was given after 7 days, and the same was true for placebo group. And these females along with their fetuses were followed for primary and secondary outcomes. Over 7,000 females were assessed for eligibility. 2,852 were randomized. In the dexamethasone group, we had 1544 fetuses and 1526 fetuses was there in placebo group. And they analyzed 1532 fetuses in the dexamethasone and 1519 fetuses in the placebo group. So this table shows us the baseline characteristics. The gestational age at the trial entry was 30.8 weeks, approximately the same in both the groups. And the other thing to notice is the tocolytic agent was given in roughly say 17 to 18%, and Maxelf was received around 10% of the fetuses for neuroprotection. So this is the outcome. So neonatal death was 19.6% in dexamethasone group as against 23.5%, and there was approximately 16% reduction in the neonatal death by 28 days, and which was statistically significant. Again, the stillbirth and neonatal death, a composite outcome, was significantly different, and significantly these incidents were significantly reduced. There was a 12% reduction in the composite outcomes, stillbirth and neonatal death, and there was possibly no reduction. There was no reduction in the possible maternal bacterial infection, and this margin which you are seeing is actually adjusted for non-inferiority design. So if we see the subgroup analysis, it is interesting to see that as the first box, highlighted box, shows the time of the first dose to time of the first dose of dexamethasone to birth, and if it is between 0 to 6 hours, there was possibly no effect. And then as the time from the first dose to last dose to delivery interval increased, first dose to birth, actually time from the first dose to birth increased, there was gradually improvement in the efficacy of dexamethasone for the primary outcomes. And if you see the tocolytic agent, all those who have received tocolytic agent, and we know that Maxelf is the main tocolytic agent, so all those, then it showed a significant improvement when the tocolytic agent was not given. So we can see that the dexamethasone was also associated with significant reduction in the early deaths within 7 days, severe respiratory distress at 24 hours, reduced incidence of hypoglycemia, major resuscitation and birth, and requirement of CPAP. There was no difference in the maternal outcomes. So they conclude, the investigator concluded that among neonates in LMIC countries at risk for early preterm birth, dexamethasone significantly lowers risk of neonatal death, significant reduction in the stillbirth or neonatal death, and no increase in the incidence of possible maternal infection. Thus, the antenatal dexamethasone should be given for all, mothers who are at risk of early preterm birth less than 34 weeks of gestation. The second study is immediate kangaroo mother care and the survival in LBW neonates. We all know that kangaroo mother care is usually given after the initial stabilization in the next, beyond the first few days of life. Kangaroo mother care is routinely given in the neonatal units in developing countries and developed countries also. So kangaroo mother care is associated with significant reduction in the mortality, risk of infection, improved anthropometrical parameters, better breastfeeding rates, etc. So whether kangaroo mother care is possible in the immediate period after birth, say in the first few hours of birth, and whether this intervention improves the efficacy of routine kangaroo mother care, which is given after a first initial few days. So this was the research question, whether among neonates weighing 1 kg and 1.799 kg, whether an immediate kangaroo mother care instituted soon after birth, after initial stabilization, as compared to conventional care in incubator or warmer until stabilization followed by KMC, resulted in 20% lower incidence of death within first 28 days, and also in the first 72 hours of life. So this was the research question. So the neonates between 1 and 1.8 kg were randomized to immediate KMC. The immediate KMC was given in a specially designed NICU, which they labeled as Mother NICU Care. In the control group, the conventional neonatal care was given in the warmers or incubators in the routine NICUs. And after a few days, when the baby is clinically stable for at least 24 hours, the babies were randomized to babies were continued with the routine KMC care in the KMC wards, which was identical in both the groups. So the only difference was in the immediate KMC in the first few days of life, unless they were clinically stable for 24 hours, and they were followed for primary and secondary outcomes. So 5,300 were neonates were assessed for eligibility. Over 3,000 were randomized. 1,609 infants in KMC group and immediate KMC group, and 1,602 in the control group. And I'm sorry. And roughly 13 and 17 were lost to follow-up or withdrew consent, and 1,596 and 87 were compared. So this is the baseline characteristic. This table shows that the mean birth weight, mean gestation was 32.6 weeks, and the mean birth weight was 1.5 kg. The roughly 1/4 of them had multiple gestations, and 1/3 were born by cesarean section. So it is important to discuss KMC characteristics before jumping to the conclusions. The median time to initiation of KMC, so skin to skin contact, was 1.3 hours in the intervention group and 53.6 hours in the control group. Almost 87% of neonates were started on early KMC within 6 hours of birth, and in the control group, the major chunk of neonates, they were started KMC beyond 24 hours once they were clinically stable for at least 24 hours, from 24 hours to 7 days. The median duration of skin to skin contact in control NICU or mother NICU, that was 16.9 hours and as compared to 1.5 hours. When they were shifted to Kangaroo Mother Care Ward, then the median duration of KMC was 20 hours and 19 hours, respectively.
I'll send it to you now.
So this is So this is the main analysis. Primary outcome: death between enrollment and 28 days. You can see that there is significant reduction in the incidence of death by 28 days. There is significant reduction in there was already almost 25% reduction in the mortality by 28 days. Almost 23% reduction in the mortality by 72 hours, and there was significant reduction in the incidence of hypothermia and sepsis. So if you look at the birth weight, then the effect was more marked when we in the 1.5 to 1.8 kilogram as compared to the lower weight range babies, and same trend was evident in the gestational age category. So if you look at the time of KMC, that is 10 hours, 10 to 20 hours, more than 20 hours per day, and see the death between the enrollment, you can see that longer is the duration of KMC, the lesser is the incidence of death. And same is true for the death of between enrollment and 72 hours of each. So the longer duration of KMC was associated with significantly reduced incidence of neonatal mortality. There was significant improvement in the initiation of the breast milk in the intervention group, and the proportion of neonates who reached breast milk feeds by day 7, and they were discharged on exclusively breast milk feeding by at the time of discharge. So they were receiving exclusively breast milk feeding at the time of discharge. So they were significantly improved in the intervention group or early immediate KMC group. So to conclude, there was 25% reduction in the mortality. A number needed to treat was 27 extra babies, which means that 27 babies needed to be treated to have one extra survival as compared to the conventional care, neonatal care. And there was 23% reduction in the mortality by 72 hours, significant reduction in the outcomes. The duration of KMC was inversely related to mortality. There was higher risk of breast milk feeds, and very important, this is that they are able to achieve an KMC duration of 19 to 20 hours per day.
Do we have?
Now, the third study which I'm going to discuss is the BCG-induced non-specific effects on heterologous infectious diseases in Ugandan neonates. And this was published this year in Lancet Infectious Diseases. So we have learned also during the COVID time that BCG is possibly can provide some protection. And this was seen in the experimental work as well. Whether a BCG has got some effect in non-tuberculous heterologous reduction in the heterologous infection. So the research question was that among the healthy infants born in high mortality setting, whether an BCG vaccination given at the time of birth as compared to BCG vaccination given at later on at 6 weeks of age is able to reduce the all-cause infectious disease morbidity. It's not mortality. So this is infectious disease morbidity by 25% at 5 to 10 weeks of life. So the healthy neonates born in in Uganda, they were randomized to receive BCG at birth or BCG at 6 weeks, and they were sampled at birth 5 days, 6 weeks, 10 weeks for some epigenetic studies and some inflammatory cytokines, and they were followed for primary and secondary outcomes. So this slide shows basically the scheme of the blood samples. So this is birth, 5 days, 6 weeks, and 10 weeks, and they have taken the blood sample for 3 studies versus epigenetics. So they looked at the histone trimethylation of the promoter regions of 3 inflammatory cytokines, that is tumor necrosis factor, IL-6 and IL-1 beta, and they have studied the cytokine levels and the iron studies and hepcidin, basically transferrin saturation and hepcidin levels. And they have compared in the 2 groups who have received the early BCG and those have received the delayed BCG. So they randomized 516 units, 280 in each arm, and a few were discontinued, and then they had a good follow-up rate of approximately 85%. So the noteworthy, the birth weight of these neonates were over 3,000. 3,200 and 3,000, nearly 3,200 in both the groups. And the low birth weight, the incidence of low birth weight was just 5% in their cohort. So this is the primary outcome. So this is the Kaplan-Meier graph to show the probability of acquiring infection, heterologous infection, non-tuberculous infection over 10 weeks period. This is 6 weeks, this is 10 weeks. And you have 2 lines. Blue one is BCG who were given BCG at birth, and red is those who were given BCG at 6 weeks. So you can see that the probability of acquiring heterologous infection is significantly lower in those who have received BCG at birth as compared to those who had received BCG later on at 6 weeks of life. So they have seen the incidence of the hazard basically of acquiring these heterologous infections, and they have seen this. The effect is largely seen in the males as compared to females, and largely seen in the birth weight of 2,500 grams. Less than 25 means in low birth weight babies, the effect was marked as compared to the bigger babies. And when they studied the interaction, they could not find an interaction in the sex, but they could find the interaction with the birth weight. So basically, saying that the low birth weight babies have even the effect of reduced infection is largely because of the reduced infection in the low birth weight babies. So this slide shows basically the histone trimethylation of promoter regions in the three genes of let's say TNF, alpha, IL-6 and IL-1 beta. And they have seen the geometric mean fold change in the percentage recovery. So basically, once you have heterologous infection, there is increase in the histone trimethylation. And if you have less infection, and what does this trimethylation suggest? That it suggests that once you have a trimethylation of the histone trimethylation of the promoter region, it means that it turns the DNA on and it is ready to transcribe mRNA and proteins. So basically, in the BCG group, which is depicted in orange bars, as compared to the BCG who are not given BCG or given late, BCG late. So there was a significant difference in the histone trimethylation, which suggests that there was significantly less activation in the BCG vaccinated group, which also suggests that possibly if you have heterologous infection, there will be increased trimethylation. If you have less infection, there will be less trimethylation, which goes hand in hand with the previous, core hard outcomes. So basically, they concluded that BCG given at birth significantly reduces all-cause infectious disease morbidity in neonates. And remember that this was the setting of very high infectious diseases. So the baseline infection rate of the heterologous infection in the Ugandan neonates is 668 per thousand babies. So which means a very high rate of incidence. The severe severe infections severe illness was 23% per 100 babies. So basically, in such a high setting, the BCG given at birth is able to reduce the infectious related morbidity. So this could have some public health benefits in such if the infections are very high in the community. Then the fourth study which I'm going to discuss is hypothermia for moderate to severe neonatal encephalopathy, that is HELIX trial. There's a lot of buzz about this study, and I'm sure you will be hearing more about this. So I will be briefly describing this study and what are the take-home messages for the therapeutic hypothermia in low and middle income countries. So basically, the idea was that we all know that the therapeutic hypothermia is the only modality of only therapeutic modality which works in moderate to severe HIE, and it reduces the incidence of death and abnormal neurodevelopmental outcome by almost 20 to 25%. The studies from developing countries have not shown such an improved benefit. And in fact, some studies have shown that possibly the mortality rates may even be higher in the developing countries. So that's why this trial was undertaken. So the research question was, among 36 weeks or higher, 1.8 kilogram or higher babies within 6 hours of life who have continued resuscitation at 5 minutes, and the other parameters if they are not delivered at the health facility. And the second criteria was they should have moderate to severe neonatal encephalopathy. They were randomized to whole body hypothermia and usual care, and the research question was whether this whole body hypothermia is able to reduce the combined outcome of death and moderate to severe disability by 18 to 22 weeks by 30% as compared to the usual care group. So they have randomized these babies who are eligible babies on whole body hypothermia and usual care. The whole body hypothermia was given by Ticotherm, which is a servo-controlled cooling device. And they have done the MRI at 1 to 2 weeks and Bailey's 3 for the neurodevelopmental outcome at 18 to 22 months. And they have followed these babies for primary and secondary outcomes. And in the MRI study, they have done the conventional MRI as well as diffusion tensor imaging and other diffusion weighted imaging, etc. So they have assessed 2,200 neonates. They randomized 408 and analyzed 195 and 199 in two groups. Noteworthy, just hold on for a second. Yes, please. Okay. Okay. Sorry for the interruption. This was a call from Mekong. Basically, these were the term babies. The birth weight of these babies were 2.8 and 2.9 kilograms, and they had moderate to severe encephalopathy. They almost 3/4 of them had seizures. Noteworthy, these are the two noteworthy characteristics, that the perinatal sentinel events were seen only in 8 and 13% events, whereas in the other trials they were like whole body, like the NICST trial and TOBI trial, that was seen in approximately 2/3 to 3/4 babies they had sentinel event. And the place of delivery, it is noteworthy that the 2/3 of the babies, over 2/3 of babies, they were born in the other hospitals. So the outcomes, the death and death or moderate to severe disability was not different, but death alone up till 18 months of age was seen in significantly higher in therapeutic hypothermia as compared to non-therapeutic hypothermia. And in bleeds related to gastric bleeds, pulmonary bleeds, and thrombocytopenia, etc., coagulation disturbances, they were higher in the hypothermia group. The hospital stay and death before discharge were higher in the therapeutic hypothermia group. If you see the improvement in the encephalopathy, the red shows severe encephalopathy, and the pink shows less or no encephalopathy. Then there was the improvement in the encephalopathy in the first few days of life was less marked as compared to the usual care group. This slide shows the Kaplan-Meier survival curves, and it shows that in control, which are depicted in red, and therapeutic hypothermia, which is depicted in blue, there is significantly decreased a probability of survival, almost 47% reduced probability of survival up till half years of age. So they concluded that the helix did not, therapeutic hypothermia did not reduce the combined outcome of death and disability. It significantly increased the death alone and did not reduce the brain injury on MRI. So it is, they are right up to this point, but then they make a statement, they conclude, and I quote, therapeutic hypothermia should not be offered as a treatment for neonatal encephalopathy in low and middle income countries, even when tertiary neonatal intensive care facilities are available. And we know that this particular statement is not backed by the literature and is not backed by the findings, because they had almost there was a very high proportion of neonates with SGA babies. There was a very low sentinel events, and we know that many of them were born in the outside hospital. So we don't know about whether they were really having the sentinel, the 0 to 6 hour margin window in which the therapeutic hypothermia was given to them. So India is a very heterogeneous country. You have countries, you have states, facilities, outcomes like West in Kerala and many other states, and there are very high mortality rates in other states. So I guess when we have good antenatal care, when we have sentinel event, and we have facilities to tertiary care facilities available, I think the therapeutic hypothermia should still be carried out, and because the results from West can be bought for those scenarios. So quickly, last two studies, transfusion threshold for preterm neonates. They randomized the neonates between 22 weeks and 28 weeks for low hemoglobin threshold and high hemoglobin threshold, and these ranges were set according to respiratory support and no respiratory support, and there was a difference of 2 to 3% between these two groups. Almost 900 neonates in each group, and they found that the primary outcome, that is death or neurodevelopmental impairment, was not significantly different between these two groups, and hence the lower threshold hemoglobin threshold may have equal outcomes in the neonates. In early respiratory stabilization of neonates, we use Ensure, which is intubate, give surfactant, and extubate within few minutes, extubate to CPAP. So they have studied whether in Rexure, that is intubate, they do the recruitment maneuvers, give surfactant after the recruitment maneuvers is done, and extubate, whether that improves the outcomes as compared to the Ensure. and the neonates were randomized between 24 to 27 weeks who had CPAP failure. Yeah, finish. Finish it. Yeah, finish it. Finish it. Finish it.
Okay, sir.
So the need for mechanical ventilation. So this was the protocol. You can find the study in Lancet Respiratory Diseases. This was based on the high frequency ventilation and the Jaijiri protocol. So we can go through that, and they have shown that the mechanical ventilation was significantly lower in the babies who were who followed the Inrexure as compared to Ensure, and there was a trend of reduced in-hospital mortality as well. So my take-home messages is that antenatal dexamethasone for expected preterm birth below 34 weeks should be given. Immediate KMC between 1 week and 1.8 weeks should be resorted. Of course, this requires a lot of preparation, a lot of infrastructure changes, manpower, etc. But that it's worth a shot because it reduces mortality. In a very high infectious disease setting, the BCG should be given at birth. The selective use of therapeutic hypothermia should be resorted to once we have the ideal conditions as we discussed. The restrictive transfusion threshold should be used for extremely preterm neonates, and lung recruitment strategies can be tried to reduce the incidence of mechanical ventilation in those babies who meet CPAP failure criteria. I acknowledge the contribution of my team, my unit, and my institute. Thank you very much. I'll be happy to take up some questions if you have.
Thank you, sir. Due to time.
Can you hear me? Can you hear me?
Mic on ಮಾಡಿ ಸರ್. ಆನ್ ಆಗಿಲ್ಲ. ಸ್ವಿಚ್ ಆನ್ ಮೈಕ್. ಕೊಡಿ. ಯಾಕೆ?
Hello, Dr. Saini, can you hear me?
Yes, now I can hear you.
Dr. Saini, thanks for your excellent and informative talk. Can I just have a quick question before we set up for the next panel discussion? So this is about therapeutic hypothermia. You were saying that we should not, or we need to think twice before you put the baby in therapeutic hypothermia in low and middle income countries, like India. So what should we do in our country with regards to therapeutic hypothermia? Because in Western, as you know, that very well know that you would be person. You don't put the baby in therapeutic hypothermia, the baby fits the criteria for cooling. So in Western, you would be question. So what to do in our country, sir? So just your comments on that.
So yeah, so basically we should know that the ideal settings for therapeutic hypothermia. The ideal settings for therapeutic hypothermia is that babies are very well taken care of during the antenatal period. We know that they have not suffered any intrauterine hypoxemia, and they have suffered a sentinel event close to the birth, which means that they suffered hypoxia within the we have 0 to 6 hour window available from the onset of event to the onset of cooling. So basically, if we catch the baby into that window and ensure that the facilities are available as they are there in several of the good tertiary care centers. So in those settings, the therapeutic hypothermia can be undertaken, but it can be harmful if it is ideal settings are not met. The babies have have a prolonged intrauterine hypoxemia, or if they are caught beyond the ideal time window of more than 6 hours.
Basically, what you were saying is you could still cool the babies. If you get the baby within 6 hours, and if the baby fits the criteria for cooling, you could still cool the babies. Selectively. That's what you were saying.
Yeah, so basically, if we can match the Western setting or developed country settings, yeah, we should.
Okay, sir. Thank you, sir.
Dr. Sani, so you said you have to match your NICU care to Western level before we start cooling.
No, so the Western care.
Baby, or can we do care of PPHN baby or ELBW baby without uplifting our NICU care? So do we want to give a message that only cooling requires standard of care management before you start cooling, but you can manage a 700 grammer or a 800 grammer without having an optimal NICU setup?
So no, so my message is so we have to have a basic minimum standard of tertiary care before we undertake this type of therapies. So we in these trials, basically if you have a refractory shock or if you have a refractory pulmonary arterial hypertension, then the therapeutic hypothermia was withdrawn. So basically it is not useful for that kind of a setting. But what I mean to say is that we should have a bare minimum standard of tertiary care, adequate antenatal follow-up, catch a sentinel event, and then once we have all this set up, then we can undertake that.
Thank you, Dr. Sandhu. Thank you.
Thank you, sir. Thank you, Dr.
And due to time constraints, we'll directly jump into our next panel. Golden hour in management of extreme low birth weight. The term golden hour was taken up from the adult trauma, where we know that how first hour management is important to reduce the mortality and morbidity. Whereas in neonatology, this term was coined by Reynolds et al. To show us how important it is to manage the child in first 1 hour or first hour. So let's see how important it is in extreme low birth weight infants. So I introduced Dr. Amit Upadhyaya, who is the moderator and chairperson of this panel discussion, and he's a current NNF board member of Central Zone, director of Nithima Hospital, and he has more than 50 publications under his name and a research gig. Over to you, sir.
Thank you very much. I would like to invite my panelists, Dr. V. Lakshmi. She is already here. I would like to invite Dr. Venkat Ramarao, Dr. Nelvi George, Dr. Deepak, and Dr. Abhishek. Dr. V. Lakshmi has done her DNB fellowship in neonatology, is head and consultant department of neonatology at Dr. Mehta's Chennai hospital in Chennai, and she has been in neonatology for last 20 years. She has been secretary of TNNF. We all know Dr. Venkat Rama Rao, and he is a MRCP from multiple places and FRCP also from multiple places. He is head of Children Services and Director, Chief Consultant, Neonatal and Pediatric Intensivist at Andhra Hospitals, Vijayawada. And he is also trying to host the National Neocon in coming future. Nilbhai George Matthews, who is DM in neonatology from CMC Vellore. He is a consultant neonatologist at TMM Hospital, Thiruvalla, and is secretary NNF Kerala. We have Dr. Deepak Vasudev, who is a pediatrician and neonatologist and CPCH, and is at Apollo Cradle in Brookfield. And joining us virtually is Dr. Abhishek Aradhya. Dr. Abhishek, are you there virtually? Dr. Abhishek is actually the person who lives closest to the venue. I was surprised to know that his hospital is in Hoskote, Bengaluru, and still he's the only person who is joining virtual. So he has done his MD and DM from PGI, and hopefully we have him connected virtually. Dr. Abhishek, welcome.
Hello, sir. Thank you, sir.
Can we have the slides now? Yes. So I would request my panelists to be, we have only 30 minutes, and I think 4 or 5 minutes have already gone by. We'll be having about a minute for each question, and let's take, each question should have a take-home message at the end, so that what they have to do, we would not delve into numbers like what is the RR and CI, just a question and practicing answer for the young and practicing neonatologist over here. So next, please. So Dr. Vijay Lakshmi ma'am, first question is to you. So what is this golden hour strategy? And especially neonatal resuscitation.
Golden hour strategy was adopted more from the adult trauma care, where they did a set of interventions which are evidence-based in the first hour of trauma, and they were able to translate into a very good outcome. So a similar strategy was adopted to neonatal resuscitation and the neonatal delivery room. So these are the events which are going to happen in our delivery room, whether all of us know about it, and hypothermia, hypoglycemia, and hyperoxia and all that. And they get translated to long-term outcome like IVH, BPD, and ROP. So whatever the events which are occurring during the period of transition in the labor room, evidence-based, and we cluster it and do it in a much smoother way. So that was the basis of golden hour strategy.
Thank you.
Very good. Coming and going. And even the voice also, there is a echo is there. Not clear, clarity is not there.
इससे control कर दे वहाँ से it is not control.
These were all the evidence-based interventions when done prior to delivery, during delivery, and in the postnatal period. So we have to organize ourselves like how we did for the NRP. It's just an extension for an hour or more. And your colleagues, good communication is going to be a part of the golden hour strategy. And it has evidence nicely translated into practice. So many QI studies have come on golden room strategy also to show that it works.
So what is the ideal method of cord management in ELBW, Dr. Abhishek? And should it be delayed cord clamping or cord milking?
I think the cord management in ELBW is like any other baby. Like we need to delay clamping the umbilical cord for at least 60 seconds to promote fetoplacental transfusion. So we have the latest Cochrane from 2019, which says we have evidence from nearly 20 studies in preterms. Out of 2,680 babies, they have shown reduction in mortality. The mortality reduction was 27%, which was statistically significant. As if you delay clamping the cord, you can actually improve survival.
Do you have any problem in delaying? As the baby, majority of such baby may not be breathing at birth.
One challenge would be like if babies are not breathing at birth, many of us may actually move towards umbilical cord milking. But whatever the latest evidence we have from the latest JAMA 2019 RCT is that delayed cord clamping should be preferred in babies below 28 weeks. So umbilical cord milking can be attempted beyond 28 weeks, but below 28 weeks, umbilical cord milking can increase the risk of severe IVH. So the evidence says below 28 weeks, cord milking is not safe.
If the child is not breathing, how will he?
We can wait, delay clamping of the cord if baby is breathing. If baby is not breathing, you can do umbilical cord milking.
And then you cut.
The cord milking hardly takes 5 to 6 seconds.
Delay.
People who have joined online. I would request people who have joined online to kindly post their questions in the chat box. And we will address the questions later or we will answer them in the chat box if the time doesn't permit.
If the baby is not breathing, we can use like umbilical cord milking. It takes 3 to 6 seconds.
So, Dr. Venkat, why is the first hour so important? And any specific things to be looked into resuscitation of ELBW babies?
Thank you. Good morning to all. Golden hour is actually, it doesn't mean that it's only the first hour. And of course, first few hours and the first few days are very, very important in managing these extremely low birth weight babies. Basically, this golden hour is basically coined for trauma management, but we are using this golden hour kind of term to our ELBW babies as well. Yes, golden hour management basically starts from the delivery room management, starting from the stabilization of the baby, initial team setup, and the communication, all those things that matter. And then starting from resuscitation and thermoregulation and delayed cord clamping, all those things are very, very important, and that would affect the morbidity, mortality, survival, and later on neurodevelopmental outcome as well. So basically, team working, high quality care, and of course, safety, effective management is very, very important in dealing with these vulnerable babies.
So if so important things have to be done in first hour, it is imperative that a baby is born at a center where he is to be cared for. So in utero transport should be maximized, and obstetricians should be encouraged to deliver babies not at their centers and then shift the baby, but such high-risk babies should be delivered at a center where tertiary care NICU is available. Would you agree to that, Dr. Venkat? Absolutely. So this is an important take-home message from this panel discussion, that in utero transport should be encouraged and babies should be born at centers where NICU care is to be given. Now, any more? Yeah. So, Dr. George Matthew, what should be the specific point of emphasis for resuscitation in ELBW babies?
Thank you, sir. Whenever we are resuscitating an extreme low birth weight baby, extreme low birth weight or extreme preterm baby, definitely they are going to have increased need of assistance, because they are firstly premature, and they are then the factors which had led to prematurity. So extra care has to be taken from planning stage. Extra instruments, extra personnel has to be mobilized. This is specifically, practically the temperature maintenance. These points you all know, this room temperature polythene bag, then extra you have to add thermal mattress to make these babies less than 32 weeks to be normothermic. But like hypothermia is equally detrimental for the brain. So recheck the temperature in between. Never allow the baby to go into hypothermia or hypothermia. Next thing, coming to the assisted ventilation part. The need for positive pressure ventilation is same as term baby, not breathing, apnea, or heart rate less than 100. But practically what happens is these babies will be having respiratory distress. So don't hesitate to start CPAP early. Start CPAP in the labor room. While this can avoid intubation as well as mechanical ventilation. And the practical thing we should do is, when you're giving positive pressure ventilation, maintain minimal PIN so that to maintain the heart rate. Thereby you are avoiding barotrauma, indirectly voluotrauma. Your long-term benefit will be there. Then need for surfactant. And if you are intubating the baby in labor room for respiratory distress, very clear, for respiratory distress, you are intubating, give surfactant, but only after initial step. And one practical, oxygen is a drug. So give it, so you have to be very clear when to give it. Any baby more than 35 weeks, 21%, less than 35 weeks, 21 to 30%. More important is your resuscitation bed should have an oxygen saturation table, and you have tried to maintain it. And whatever you do is long-term brain is more important. So always handle these babies gently. No head. No rapid IV infusions. That they will control.
Very important point has brought out, that minimize the BIP, always try to give beep along with that, and minimize the oxygen which has to be given. So Dr. Deepak, what are the components of golden hour management? If you could just summarize them and enumerate and tell what is it all about?
Yes, sir. Most important thing is team approach. So your team should have around 4 or 5 members. 2 would be doctors and 1 would be a senior person who would be a leader. Okay, the other one is a provider who will intubate or provide this delivery room CPAP, and also the nurses should know their roles. And also make sure that, you have surfactant at the delivery suite room. And also DCC, delayed cord clamping was talked about, thermoregulations are talked about. It is very important that you make sure that you prevent hypothermia and resuscitation as per NRP guidelines, make sure gentle ventilation. And also the most important thing is to transport and stabilization in ICU. The first 3 or 4 should ideally in a stable baby should take around 15 or 20 minutes. And then when you transport the baby to an ICU, make sure everything is ready. So you have a pre-warmed incubator and you have a set to put up IV cannula and umbilical lines. So delegation and, so making sure the preparation is the key here. And in an ICU, make sure that once you put the peripheral line, start IV glucose soon. Yeah, 10% dextrose to prevent hypoglycemia. Take your cultures, start antibiotics early, and also make sure that your bubble CPAP is ready and gentle ventilation. And the most important other thing is follow the bundles, like to prevent iatrogenesis, to prevent infection and all. And also gentle handling we talked about. And one of the most important thing we forget in such scenarios is communication with the family. So ideally you should begin before the delivery process. So that you explain to the parents what's happening there. And also once the baby, you are wheeling the baby to an ICU, make sure that you show the baby to the mother and also the father. And you tell them that I'll come back and talk to you once the baby is stabilized. And early
communication is the key, and it should begin before the birth, because if you have to give resuscitation, if you think of giving surfactant in the labor room itself, then you need to communicate the family beforehand.
And mainly the other thing is early nutrition. So once we put the lines, we would always start with at least to begin with aminovin and dextrose within 1 hour. So ideally it should take 60 minutes or so, but it may not be practical as Dr. Ramrao stated. So, but it's important that we have at least some time period to start and then attain it.
Yeah, most often these days, ELBW babies, they don't die of RDS or other thing, but they die of iatrogenesis. And sepsis is one of the most important factors killing such babies. So preventing infection, as Sir has pointed out, is the most important thing. If there is one take-home message from this question, that is to prevent iatrogenesis, and you prevent volume overload, prevent hypothermia, prevent hyperthermia, and prevent infection acquisition in this baby. So already many points have been pointed out, but if you have something else to add on, how do we maintain normothermia in ELBW units?
We have to stress about kangaroo mother care here. Kangaroo mother care, kangarooing the baby on the mother's abdomen if the baby is active, vigorous and crying to maintain normothermia is very important. They would have already mentioned about the cling wrap, where they apply the cling wrap very approximated close to the body of the baby without wiping the baby. On a wet baby, you apply the cling wrap to reduce the evaporative water loss as well as the conventional heat loss. And clothe the baby at the earliest. But again, the fourth thing is the delivery room temperature. LB had already told about raising the delivery room temperature, switching on the warmer so that you receive the baby in a warm environment with warm temperature.
What's the optimum delivery room temperature?
26 to 27 would be an optimal delivery room temperature.
So I believe maximum temperature is during transportation, even if it is intra-hospital. So intra-hospital transport is also very critical, and ideally optimally it should be done in a transport incubator. And but if you don't have a transport incubator, would you highlight how do we transport such babies, even if it is from the labor room or OT in that hospital?
You can have a thermal mattress. So many mattresses are available which can keep the baby warm. Or you can adequately clothe the baby, cover the baby. Kangarooing is another option.
Thank you. Dr. Abhishek, one of the strategies in the first hour is to use delivery room CPAP. We are still in the labor room. So is it feasible to give CPAP right in the delivery room? If yes, what precautions should be kept in mind while applying CPAP in delivery room? And what are the indications for initiating CPAP and delivery room in these ELBW babies?
The challenge at birth for all these preterm babies is that they lose the alveoli, undergo atelectasis. So at birth, if you do not give any positive pressure in the form of gentle ventilation or CPAP, will have atelectasis. So it requires more pressure to again open up the lungs. So the best way for a spontaneously breathing infant in the delivery room is to start CPAP. So how do we start CPAP? I think CPAP can be easily started by using a T-piece resuscitator, using a short binasal prongs. I think we can deliver delivery room CPAP by setting the pressures. So whatever the evidence we have is that delivery room CPAP reduces the need for mechanical ventilation, need for surfactant. It reduces mortality, and more importantly for us, reduces bronchopulmonary dysplasia as well. So these are the trials from the Western literature. So I think we are all aware of all these trials: COIN trial, support trial, Von DRM trial. They've all compared prophylactic CPAP with delivery room CPAP. The summary of all the three trials is that they reduce need for mechanical ventilation and surfactant use by 50%. But if you look at the studies from low middle income countries, we do not have similar effects because there are a lot of barriers in LMIC countries. It may be antenatal steroids, availability of CPAP interface, CPAP equipment, outbound. The facilitators would be again steroids, binasal prongs. Having simulations in the unit actually will help in appropriate usage of delivery room CPAP. So next slide, sir. Yeah. So what we need to understand is that we need to try delivery room CPAP in all preterm babies who are breathing spontaneously, that is below 32 weeks. Scores, I feel it should help in monitoring for treatment, but for initiation, it's just a purely based on clinical examination. Special precautions for delivery room CPAP would be use blended oxygen if possible to prevent ROP, use optimum flow to prevent pneumothorax, and at least PEEP of 6 centimeter is what the latest European consensus guidelines recommend to ensure appropriate inflation in the delivery room.
So your line says start delivery room CPAP in all babies less than 32 weeks. So I'm sure it means all babies with distress less than 32 weeks. Start DR CPAP in all preterms less than 32 weeks with respiratory distress. Obviously no distress, no CPAP. So Dr. Deepak, CPAP is definitely indicated, but a new device which is coming is slowly subsequently replacing CPAP in at least few babies, HHFNC. And because of ease of use and the prongs are very soft. So do you think that even HHFNC can be provided in labor room or delivery room itself? Or CPAP is best? Or in subset of babies, we can use HHFNC?
Yes, as you rightly say, the humidified high flow cannula is easy to use. It is feasible to use at birth in less than 30 weeks as well. But if you see the evidence and if the baby has a respiratory distress, you are better off using delivery room CPAP, conventional CPAP, bubble CPAP than high flow. The reason is treatment failure is more in the high flow group and less than it can be in babies more than 28 weeks. Normally people to move away using high flow in less than 28 weeks. Having said that, there are some centers in England who routinely use high flow for stabilization of these babies as well. So on your right hand of your
we can say that more than 30 weeks we can use it as a primary modality, but under 30 weeks CPAP is better.
CPAP is better, yes sir. So more
now
than
the question is, can it, if CPAP versus HHFNC, CPAP is better at least less than 30 weeks. How does it compare to giving supplemental oxygen? So baby doesn't have significant distress. So it means, is it a good modality to give heated and humidified oxygen as compared to just simple oxygen by nasal cannula which we give?
Definitely, sir. Absolutely. So I would prefer high flow. So instead of giving supplementary oxygen, the reason is oxygen titration is possible, and also the high flow, as you know, has gives some sort of CPAP and also reduce dead space. So work of breathing is definitely better in babies who have a lesser lung disease. So it's compared to supplementary oxygen, you would use high flow, and you can also give early surfactant if you know that you are giving 40% oxygen. In some
we'll leave surfactant to a later question. So anybody else has to.
And the hypothermia, sir.
HFNC replacing a CPAP. More than that, we can say you said HFNC replacing oxygen, because you could give oxygen in a more heated, humidified way, and they are known to reduce hypothermia in these babies.
Can we use HHFNC and CPAP during transportation in the transport incubator? Do we have facility enough?
You can use. Yes.
Or without giving 100% oxygen, do we have compressed air?
Yes, you can.
You can use blenders, transport incubator. we can give very safely CPAP as well as HFNC.
In practice, how many times we are giving HFNC in the first hour, there is a question. But definitely CPAP, yes, but HFNC in silky babies.
It is difficult to have it in the room and then especially in transportation. So once we know that, yes, it can be used, then equipment would come gradually. So yes, it can be used if you have facility for that. So Dr. Vijay Lakshmi ma'am, next question is for you. Many ELBW neonates would be born preterm and manifest respiratory distress at birth. So as I pointed out, should we give surfactant right in the delivery room, or should it always be given in NICU after confirming the position of the ET tube, after getting an X-ray and documenting that RDS is because of HMD and not because of pneumothorax or any other reason? How early do we give surfactant? Do we give prophylactic surfactant? Would you please enlighten us with
Surfactant can be given in the labor room or delivery room. Surfactant need not be given in the delivery room. There are very clear-cut indications as to when to give surfactant. And prophylactic surfactant is you give before even you think whether this baby has got RDS, has taken a back seat. So it was practiced earlier in the pre-CPAP era. Every baby preterm who's delivered was receiving surfactant in the labor room. And another thing is, once you intubate and you give a positive pressure ventilation through the endotracheal tube, you are putting a lung at risk of injury, and it gives a red flag sign for your BPD later in life. So you try to avoid as much as possible intubation in the labor room. So we will not go for prophylactic surfactant. As said, already been very well, recruit the lung with PEEP as much as possible. Give a CPAP in the delivery room, titrate your oxygen and recruit your lung. And then you reassess the baby. If the baby has got distress, you go and give surfactant. And Ensure is another nice modality where just because you have to intubate to give surfactant, this baby need not be hooked on to a ventilation. So you have the possibility of giving surfactant. Needing surfactant, you need intubation, you intubate, give surfactant and extubate the baby. But again, in Ensure, you are giving pure positive pressure ventilation, which you think is enough to cause lung injury and BPD later. So now newer modalities like less invasive surfactant therapy, where the baby is breathing spontaneously on a CPAP, and you just intubate and use a vascular or a feeding tube and deliver the surfactant into your trachea and come out, so that you are not using any positive pressure ventilation. So the message is, there are multiple trials which he has already told whether to give prophylactic surfactant or CPAP and early rescue. It's very clear. It is CPAP first, reassess, and then go for surfactant. And it has n number of trials have shown to reduce death and BPD in all these babies. So after CPAP, and then if the baby has got still RDS, then you go for surfactant. So surfactant indications are 3. 1, baby is not breathing. If a baby is not breathing, you cannot give CPAP in the labor room. You have to intubate the baby. So when needing intubation, you have to give surfactant. The second, after giving surfactant, you feel your FiO2 requirements are high, 0.3 or 0.4, or the initial stabilization itself requires a higher FiO2, then you go for intubation, surfactant, and try to extubate and come out of extubation or intubation at the earliest by Ensure method. Otherwise, there is no, but this doesn't mean, okay, I don't have to keep a surfactant in the labor room. You have to keep a vial of surfactant whenever you are going for a resuscitation of a high-risk baby. That's why I said DR, delivery room surfactant, can be given, but it need not be given always. I hope I'm clear.
So you give surfactant if your CPAP requirement is, FiO2 requirement is high. So you need to have a blender with CPAP to give that device so that you know it's a bit high FiO2. And yes.
Can I have a bit?
Yes.
So what would you do now the baby is like 25 or 26 weeker with respiratory distress? Would you give, would you put the baby in CPAP plus surfactant as well, or?
First, you go through the NRP. Once you go through the NRP, you see if the baby is spontaneously breathing. If the baby is spontaneously breathing, try to recruit the lung as much as possible with your CPAP. And then you see what is the FiO2 requirement of the baby. If the FiO2 requirement of the baby is more than 0.3 and the baby has also got signs of respiratory distress, your Silverman score SI is retracting, use grunting, then you consider your surfactant and intubate.
So I would add on in between, in our country, you counsel the family and also show them that you are giving surfactant while you give surfactant, because otherwise people will say surfactant diya bhi tha ki nahi diya tha. So again, point is communicate all throughout, and यहाँ पे point आया था कि spontaneously breathing, then you start CPAP only if distress is there. 25 to 30% of even very small babies may not require even CPAP, leave alone surfactant. So if distress is there, you give CPAP. We have, time is short. So neonates are prone to post-natal growth faltering. So what about nutrition of such babies in first hour of life? We'll leave TP and we'll just concentrate on enteral nutrition, Dr. Venkat.
Yes, no, why not? You know, the baby is stable, stable enough, and the baby we didn't do any resuscitation, active resuscitation, and there is no component of asphyxia as such. And the Dopplers were normally, there's no kind of reverse industrial flow. So even then, in those babies also who could start beats early, within 24 to 48 hours. So I think my take home message is the baby is stable baby, no resuscitation required, no other risk factors, normal Dopplers, better maturity. Why not start beats early?
Which milk you think should be the best for the baby at this time?
It's always,
if mother's milk is not available, then she's in ICU, she has problems, no mother's milk is there for that baby in first hour.
Oh, it's mother milk is not available. And if you have the human milk bank, and if you have the access, get the consent from the parents and get the human milk and then give it.
Excellent. So mother's milk should always be a priority, and formula feeding has its problems itself. And so if you plan to give formula, again, you need to take consent from the family to give formula milk as well. And so this question we can leave because there are no major changes as such in resuscitation guidelines for ELBW babies.
Practically same.
Yeah. So because of short of time, zero separation, again, the previous lecture dealt with KMC lot. So zero separation is ideal. So Dr. Radhe, would you, in half a minute, would you like to tell us about zero separation?
Actually, zero separation is it's not a newer concept. We want mother and baby to be together. Environment is a primary thing which actually helps in adaptation of the newborn. The environment will decide the epigenetic switch at the genetic level, at the DNA level, which will improve the experience of the newborn and thereby the behavior. So it improves bonding, sensitization. Just to be short, I think the oxytocin, dopamine actually will stimulate cortisol production in these newborns. So if there is a separation, this toxic stress can actually affect a lot of diseases, especially non-communicable diseases. So our aim should be to have zero separation. So that will improve bonding, sensitization, improve breastfeeding, improve KMC. So that's what I would say, sir. The environment is most important.
Thank you. Thank you. Dr. George, ultra early onset of sepsis is postulated to arise from birthing areas. So, sepsis onset within 48 hours can still be late onset or acquired sepsis instead of just being a from mother to baby issue. So, what aseptic measures are important in the immediate perinatal period to prevent transmission of infection?
Sir, basically in every step, the gynecologist and the obstetrician and the neonatologist has to join hands. This is an area which is particularly important. Here, from the gynecologist side, there should find out prolonged labor at the earliest and stop it. The 6 hand hygiene should be measured, maintained. 6 cleans should be maintained. And of course, the regular things which can lead on to sepsis, like regular sharing of genital areas and enemas, everything should be abolished. And from the neonatal point of view, first and the foremost thing, in any emergency, hand hygiene should not be forgotten. The next thing, zero separation, immediate breastfeeding, and whenever you have to give support, respiratory support, always go for non-invasive support, because anything invasive, whether it is suctioning or tube intubation, whatever it is, anything invasive you are inviting infection. So that should not happen. Then, of course, proper cord care, and we should be very least invasive in our approach, and except for the feeding part. It comes in late onset sepsis, I just mentioned.
Yeah, so for most of the audience here, this is the most important slide for us, because babies, they don't die of RDS these days. They don't die of PDA because we have interventions and treatment for all these. Mostly we save them through first 7 days and then they die of sepsis, late onset sepsis or resistant bugs which are there. So we have to prevent infection. And do you start antibiotics in all your ELBW babies?
No, sir.
So which babies will get antibiotics and which will not get any antibiotics?
So basically, if there is any obvious risk factor, and if the baby is having respiratory
prematurity in itself is a risk factor.
So, but if we are taking a preterm baby with some other maternal risk factors for high BP, preeclampsia, then we may wait, sir. But practically speaking, these babies, if they have respiratory distress, then we are not sure what is the cause of respiratory distress. So we may end up in starting.
So all babies on respiratory support, Dr. Venkat, would go on antibiotics?
Yes, sir, definitely, sir, because we don't know whether it is.
So you start early and stop early if your infection markers are negative, your blood cultures are negative. So you go in early and stop early as well. Problem is we go in early but forget stopping it even after 5 days, 7 days, and 10 days.
Yeah, probably if the baby is very well, you could even stop antibiotics within 48 hours. Sir, if the cultures are negative with the babies, they are clinically really well.
So one practical thing is, once after starting, I've seen what I've seen is, just because the baby is having IV fluid, IV line is there, people continue.
Or ventilation. So yeah, if IV line is only there, we can stop antibiotics. But if ventilator is on, can we still stop antibiotics? If CPN is on, can we still stop antibiotics? If CPAP is on, can we still stop antibiotics? Can we feed babies on ventilator?
Yes,
can we
we
feed
have
babies
to
on
otherwise
CPAP?
this and atrophy and chance of late onset sepsis.
So
you have to be aggressive in feeding.
Yes. So you have to be aggressive in feeding and you have to be aggressive in stopping antibiotics and all interventions. Minimal invasive approach, as Sir pointed out earlier, is the key. Now going on to the other side of the table, the communication with and collaboration with the obstetrics team. Dr. Deepak, is it possible to have a good relation with the obstetrics around?
Yes, sir. I think we should, because they are our bread and butter, and we should be, there are some difficult obstetric colleagues, sure. So who are busy and who want to do the section and run away, and you have a busy OPD as well. So I think building a rapport is very important here, and also I'm sure that most of the obstetricians do care for babies. So you counsel them before delivery and get the details. As like, the gestational age.
So mother's antibiotic, my specific question would be, which mother should be given antibiotics and which antibiotic should they be given? Can this antibiotic given to a mother transmit resistance also to the baby as well?
If there is any GBS documentation and prolonged rupture,
we will never document in India.
Not here, yes, sir. But if there is prolonged rupture of membranes and then there is evidence of infection, CRP is
Is spontaneous preterm labor in itself a marker of infection?
Not really, not really. So if it's just a PROM baby's mother is absolutely otherwise fine.
Why did he have PROM?
Sir?
Why did he have PROM?
Yeah, there are a lot of things that, but if you give antibiotics unnecessarily, then it can have a adverse neurodevelopmental outcome on babies. The trials have shown that, sir. So
if we have spontaneous preterm labor, we should actually try to document infection in the placenta, in the black cord, and we should send histopathology, because early onset sepsis is a major killer and mortality is quite high as compared to late onset sepsis. So one should always try to document if there is any infection in the perinatal period. And this spontaneous preterm labor, we observe that a lot of infections are there, and with such babies, they don't respond to surfactant as well. So if you are not getting adequate response to your first surfactant, always suspect this congenital pneumonia thing is going on, and you do your PCTs and blood cultures if not done earlier. And steroids, obviously, obstetrician colleagues have to give. Pediatric will come into picture when the steroid has to be given. And is there any, betnisol versus dexamethasone, any preference, or which is available is good?
So we have dexamethasone mainly here. So betamethasone, we don't have it in India, no? So that's my understanding.
And do your obstetricians involve you in counseling of the parents before birth?
Yes, sir.
So that is a very important area. And Dr. Venkat, would you like to emphasize the pediatrician or neonatologist counseling the mother or the family before birth? Pre-golden hour.
Pre-golden hour is, it's basically it's a team. It's not just obstetrician or a neonatologist. I think ideally, in ideal scenarios, it's obstetrician and also neonatologist. Should consult the parents about the problems and the problems anticipated and all.
Especially important if the patient is admitted in the hospital and say if he has absent endoscopy, the mother is admitted and we are waiting for steroid cover. And so this can happen even during that period. So we have to be walking together with the obstetrician. We have to be speaking the same common language, and so that and all possibilities to the family.
I think that the obstetrician, the pediatrician, and the family should sit together in the same language.
So that is very important, which is often missing. Both obstetricians and pediatricians are busy with their OP practice as well. And so coming together at some point is really very important. It is not possible. So the point is, if we are looking after such small babies, then we have to make it possible, or we have to stop looking after such babies. So it is not possible that we keep on doing our busy OPD practice as well, and we also keep on having very small babies also delivering and being treating such babies. So we have to make it possible. That's why we are all here leaving our practice, listening to this neocon in this one. So we will not leave the counseling part. How would you counsel the parent of an ELBW neonate immediately after birth? What points should be covered while counseling the parents?
It's very important. You have to take your time, however busy you are. It's not enough if you do something good for the baby. You have to convince the parents that you have done something good for the baby. The next slide. You make your time. You give a space. Please don't talk to them in the running corridor and lift and hurriedly run away. You make your time. You sit with them. You have a good eye contact with them. It be very simple. You cannot be talking about mortality, morbidity, and respiratory distress here. They in a language, they understand very well respiratory, breathing issues are there, digestion issues will be there. All. These are 4 questions which are going to be bombarded to you when the parents meet you. Will my baby survive? What are the problems? Will he be normal? Will he go to school? Will he see? Will he hear? How long do I have to stay in the hospital? And how much do I have to shell out if you are in a private? So how you should do is you should have your own unit data and statistics. When they come to me, suppose a 26-weeker, I say in the last 5 years, our unit have given 70 to 75% survival for 26 weeks. And I also tell them we have these babies on follow. 65 to 70% of them are doing very well at the end of 2 years. So that gives them a very good picture than groping at words or what to do and all that. So your unit statistics, if you do it every year and keep it, it will be very helpful. And I told you a very simple language in what they understand. The time frame is very difficult. How I counsel is, the first 3 days of life is the baby's breathing and heart, everything adapt to the external world. So you wait for them. If they do it very well, if they come out of the ventilator, the breathing support, the next week we'll concentrate on nutrition, breastfeeding, whether the baby is able to digest the milk. And we may have to do some scans in between to make sure the brain is grossly okay. And then the 3rd and 4th week, we concentrate on the nutrition and growth of the baby and we'll involve the mother to take care. So in the hospital, a 26-weeker had stayed for 6 to 8 weeks. And by the time they go home, this is what the expected birth weight will be. So this is how we have to concentrate. You have to speak eye-to-eye contact in a very confident language, because they watch every move of you, whether you're confident, whether you're stuttering, whether you're swallowing, or you're groping for words. And this should be, you have to take your time to sit in a room separate in the delivery room or in the OT. And when the father comes in, please tell them if there are some other 2 or 3 people with you, you bring them. Because whatever you tell the father in the delivery room, it won't enter his head. He says, oh, all this will happen.
Do you
I
record
never
all this
knew."
conversation?
We have a facility to have a AV recording of all the counseling. Our counseling.
Do you
groups.
document the communication in the files?
We document and we take a signature from him.
So
And
this is
all
very
this-
important take-home
because
message as well.
Definitely, both these, if you don't take time for all this, even if you put your heart out and do something for the baby, I don't think this is going to help you in the future.
And ma'am, you said if your FiO2 is more than 30% gets affected. Does cost change your management as well in addition to science?
No, I do not, because if we see we are going to restrict money in saying we'll feel foolish later and with other things we may have to shell. So it is always these evidence-based guidelines are cost-effective also. So we have to, again, I tell them a 26-weeker who has stayed for 8 to 10 weeks in my hospital, around this money they have to shell out. That also I tell them because they have to be prepared for everything. There is any number of time with beautifully they would have adapted out of cardiorespiratory problem, and we are happy and they said no, enough is enough, we don't want to continue. One relative obstetrician, one relative doctor, somebody told why you want to battle with all this baby, they may not see, they may not hear, and that is the end. So our panel is very convincing. A very empathetic, we know that you are going to go through all that. We are there with you in the journey. We also mention about our support group. In the event you are getting stuck with money at a later phase, but from the beginning we cannot be doing that because all our corpus fund will go for us.
Do you sound too optimistic or too pessimistic in 25-weeker, 26-weeker delivery? Severe PIH?
You cannot be too optimistic at all. We tell them we do not know whether your baby comes in the 25% or 75%. But as days go by, as they respond to the treatment, we can always increase or decrease your percentage. This is how I talk to all the 26, 28, 25 to 28 weeker parents in the labor. And I keep 2-3 people with them and take witness because whatever you say, it will not enter their head at that point of time. And they are over emotionally attached and they want to do everything.
Thank you, ma'am. So finally, one take-home message from each of the panelists. Beginning from you, Dr. Vijay Lakshmi.
My name is Dr. V. Lakshmi.
Dr. V. Lakshmi.
Yes, my message was, yes, golden hour strategy is very important. It has to be practiced because NRP was also very successful. And surfactant, unless after CPAP or needing intubation or needing high oxygen to stabilize, don't be very surfactant, but keep a surfactant in your delivery room. Always take time to sit with the parents and convince them, give your data and make a plan of nice plan for the baby's next 6 weeks stay in your place. Thank you. Thank you.
Dr. Venkat.
My take home message to all of you is golden hour. It doesn't mean that, it's the first hour, first few hours are also golden hours and first few days are also important. Every hour and every day is a golden hour and golden day. So just concentrate on that and first few days is very, very important. Thank you.
My take home message would be to support the families. So be empathetic and support the families throughout the journey.
Thank you. Dr. Vas.
My take home message will be this extreme low birth weight baby. They are very fragile. So be very gentle to their in your approach. Don't do harm. Prevent infection.
Yes, and Dr. Abhishek.
The golden hour is like our preparation is the key there. So we have to prepare before the delivery of the baby, at least 1 to 2 hours prior. Keep your NICU ready, keep your delivery room ready for this golden hour management. That would be key. Preparation would be the key, I would say.
Thank you very much. And my take-home message shall be communicate very well and document all your communication and whatever management you do. Because we are entering into era of medical legal suits as well. And first save yourself, then your colleague, then the patient. Thank you.
Yes,
thank you. Thank you, sir.
Yes. Yes, one question we can.
So we use the delivery room CPAP from less than 32 weeks. So is there any evidence of, you said about 6. So for a 26, 27 weeker, for a 700 gram, 800 gram, what should be the initial PIP in delivery room CPAP?
Yeah, 6.
For anything, up to 500 pounds.
Thank you. Thank you, sir. Thank you, sir. It was a very interesting session and a small gesture of gratitude from Neocon. Dr. Venkatram Rao, sir.
ಕರ್ಕೊಂಡಿದ್ರಿ ಇನ್ನು ಮಕ್ಳಿದ್ರು ಅವೆಲ್ಲ ಕೊಡ್ಲಾ ನಾನು ಕೊಡ್ತಾ ಇದ್ದೀನಿ ಕೊಡ್ತೀನಿ ಅದನ್ನು ನಾನೇ ಕೊಡ್ಬೇಕು.
I would like to thank Dr. B. Lakshmi ma'am.
ಮತ್ತೆ ಕೊಡ್ತೀವಿ ಮತ್ತೆ ಅದ್ಯಾಕೆ ಹೇಳ್ತಾ ಇರ್ಬೇಕು ಕೊಡೋ ದುಡ್ಡ.
Dr. Venkatram Rao, sir. Dr. Nelby Judge, sir. Dr. Deepak, sir. Finally, I thank Abhishek Aradhya, sir. And thank you, sir. Amit Upadhyay, sir.
ಹುಡುಗನ್ ಕರ್ಸ್ಕೊಡ್ಬೇಕಂತ ನಾನು ಗಾಡಿ ಲಾಗಕ್ಕೆ ಪ್ರಭಾಕರ್ ಏನು ನಿಮ್ಗೆ ಹೇಳೋಣ ಲೈಟಿಂಗ್ ಟ್ರಸ್ಸಾ ಕರೆಕ್ಟಾಗಿ ಕೇಳೋಣ ಬಾವನ್ನ. ಎಲ್ಲ ನಿಮ್ಗೆ ಹೇಳೋಣ. ಅದೇ ಬಿಡು, ಅದೇ LED ಹೇಳಿದ, LED ಅಷ್ಟೇ ರಮೇಶ್ ನಿಮ್ಗೆ ಹೇಳಿದೆ, ಯಾರು ಕನ್ಫರ್ಮ್ ಮಾಡು ಅಂತ ಹೇಳಿದೆ ಅವ್ರಿಗೆ. ಅಲ್ಲೇ ಇರ್ಬೇಕಲ್ಲ.
Next we have on stage Dr. Samir Sheikh. He is a consultant neonatologist working at Wockhardt Hospital, Mira Road. Major achievements: DM Neonatology, PGI Chandigarh, received award for best research in neonatology. Worked as assistant professor in KEM Hospital and St. GS Medical College, Mumbai. National instructor for advanced NRC, international board certified lactation consultant, national instructor for NEST. We welcome you, sir.
ಅಲ್ಲ ಇಲ್ಲಿ ಅವರು ಇದ್ದಾರೆ ಇಲ್ಲಿ ಅಣ್ಣ ಸಮೀರ್ ಸರ್ PPT ಹಾಕಿ.
ಎಲ್ಲ ಶೇರ್ ಮಾಡ್ಬೇಕು ಮೇಡಮ್.
ಇಲ್ಲ ಇಲ್ಲಿ ಆಲ್ರೆಡಿ ಇದೆ PPT ಇದೆ ಅವ್ರದ್ದು.
Good afternoon, everyone.
ಅದಲ್ಲ ಇದು.
It's good to start a talk without saying am I audible and am I visible, and staying away from delegates when my nose hairs are not visible. So we'll talk about Ensure and Lisa, which are the talk of the town, the two ladies now. But it's not topic Ensure versus Lisa. I'll remove the versus part and see their how they are interrelated to each other and how they are cousins. So why these procedures have come? Okay, we all are aware that positive pressure ventilation is very deleterious to the developing lung, especially with surfactant deficient. And simultaneously, there are constant efforts to reduce the duration of this positive pressure ventilation. So hence, Ensure come into picture where we intubate, we give surfactant, and we extubate. But after some time, we realized that even brief period of positive pressure ventilation, like I remember a study which is quoted from 1995 when I started my academic journey, when I took admission in my first MBBS, that even 6 breaths in a surfactant deficient animal lung can create an can initiate a cascade of a permanent lung injury. So people started thinking that what to do. So is there any other alternative where there is no positive ventilation involved? Okay, so the simple dictum was no endotracheal tube, no positive ventilation. So we remove endotracheal tube out of the picture. Hence the LISA came, but still the procedure stayed invasive. So this is how we're going to develop on the whole lecture for another half an hour. Be with me. We'll talk a little bit about the procedure, how the INSURE procedure, how the LISA procedure is being done. We'll talk about the data, we'll review the literature. Caveats from the data. So first of all, we'll start with INSURE, especially that is intubate, surfactant, and extubate. So we all know that the scene starts from non-invasive ventilation, whatever mode you choose. And after that, we intubate the baby with endotracheal tube. After intubation, we give them surfactant. After surfactant, we extubate them to non-invasive ventilation. But this is a very big thing. It has been described since the time it was published for the first time and not been revised. Okay, as I told you, when it was described, I started my academic journey. My academic journey has grown so much, but our knowledge simultaneously grown so much. But we have not revised our strategy. We have still stayed very vague. So we'll try to see what happens here and what happens here. So intubation after non-invasive ventilation, when we intubate, it's a procedure which is comfortable and part of curriculum of everyone who's sitting here. Okay, we are very well versed with it. So that's how we do it. We know that by doing this, we are sure that the surfactant is going inside the trachea only, okay, more or less. It is more controlled. So people will go to this modified INSURE at the end of the presentation, that people have tried to more fine-tune and more make it more robust. The INSURE algorithm. It gives a breathing space to identify the confounders, try to identify those are the failure factors and correct them. There is no spillage or wastage involved when you are doing INSURE. And yes, if you are expecting multiple doses to be given, it helps you out. So when you intubate and when you give surfactant, what happens when the baby is intubated? During that time, the idea is to give controlled, even though brief duration, but here the word is very important, that is controlled positive pressure ventilation. So this includes PEEP as well. So mandate is not only PIP. You need to give PEEP because you are doing it, this is surfactant. So there are different choices available with us. So either you connect the baby back to ventilator. Okay, you look at the lung graphics, you look at the parameters, different measured parameters, and see how the volume and pressure graphs are. You can use TP resuscitator, where the PEEP is can weak, you can deliver PEEP with a regular PIP, or if you have a blender, you can even regulate FiO2 also. Now even the ambu bag has also gone a metamorphosis. Now our ambu bag, good old ambu bag, they now come with PEEP or PIP one. So now we can regulate, like this an example, the last one you can see, the first blue knob on top of it that you can rotate it, you can adjust PEEP. The one which is the silver bar is going like this horizontally. This is where you can even measure PIP, how much pressure is exerting. So now there are so many methods available to do so. So it can manage single-handed, and how do you give surfactant? Any dam catheter with graduation, yes, you need to give. You can give it. Feeding tube, even though it is not recommended, indwelling catheter, we are not doing as an indwelling catheter. So you can even use a simple, plain and simple feeding tube also. And umbilical catheter is always can be preferred. And if you want to do it a costly affair, then twin channel endotracheal tube, but they are not much in practice. They are much gone out of because of the formation of biofilm in the side port.
Hall A तो चालू है.
मैं तो physical
आपको आ जाएगा मेरे पे. अरे हॉल ए चालू आहे. हॉल ए चालू आहे. मी हॉल ए मध्ये बोलत होते म्हणून मला वाटलं की चालू आहे त्याच्यात. हॉल बी बघ. हॉल ए मी एकटाच आहे. हो मी एकटाच आहे का?
Yes, sir, they have unmuted it from their laptop.
No, don't give that option. Just mute them.
मुझे मेरी स्लाइड्स लौटा दो। Thank you. So after giving surfactant, we need to extubate. Okay, so and extubate on is ventilation. But people say you need to extubate immediately. Okay, so here the most vagueness comes into picture. You know, all the neonatologists, I will say we are having two more wives apart from our official one. One is objectivity and one is variety. So here everyone thinks and behaves differently. I tell you, if you ask your own mind that what you do after giving surfactant, okay, you will not coincide the single person sitting next to you. We all are different in this. So immediately you should extubate. But immediately, how immediately? Okay, nobody knows. After some time, how much time? 3 minutes, 5 minutes, 10 minutes, how much time you should wait? Few minutes, define few minutes. Okay, so there is no objectivity in it. Some people say, an expert opinion says after 3 to 5 minutes of positive pressure ventilation, because that is required to push the surfactant into the alveoli and some amount of recruitment. So here the two people really, like Sajan sir pointed out a study, whether we should employ some recruitment techniques here, we really don't know. And after a good lung recruitment, so should we take an extubation decision, a conscious decision rather than just a knee-jerk reaction, the way we do in all other our respiratory problems, we take a conscious decision of when to extubate. Okay, so whether we develop exit strategy at that time and then extubate accordingly, yes, we really don't know. We really don't have an answer to this. This is how we do it. So there are so many enigmas there in Ensure technique. Now, how do we do LISA? Okay, that is nothing but least invasive surfactant administration, some call it LIST also. So here the process flow is same, but a little different. That non-ventilation we start with. Then we go on to preparation of surfactant and visualize glottis with putting the laryngoscope inside. After that, we intubate glottis with any catheter with ongoing NIV. The non-ventilation will keep going on. The laryngoscope is inside. We intubate the glottis with a small catheter. We go inside only till the tip of the catheter disappears. That's it. If needed, catheter can be guided by forceps, like McGill forceps, sometimes nasotracheal intubation, and we guided with forceps and we hold it with our finger. That is also possible. And yes, you administer surfactant with continuous of glottis in a single go. So here there are no talk of aliquots. You need to give it in a single go. What can be used for surfactant installation? So bloody any damn tube is stiff enough. It doesn't mediate. It doesn't poke here and there. Okay, can be guided, can be used. So large feeding tube again can be used here. A large umbilical catheter can be used here. Again, if you want to make it a costly for 20 some bucks extra, you can use a surf cap which has a temperature regulated around 30 degrees. And this is how it goes. So this is a laryngoscope. On top of that, it slides like an endotracheal tube. Because of this curve, it slides inside is stiff enough so that you need not to use forceps. Pretty easy, as if we are doing it a very tiny and thin endotracheal tube. It is stiff enough like that. Plus a non-traumatic tip so that it doesn't go here and there. So there is a nice chart which was done in 2020 that with nasogastric intubation, with nasal tube, can it be done? This was Lisa with a 6 French gastric tube as versus Ensure. So there are no procedure failures. All the residents, everyone who was the part of team can do it. There was no significant difference in anything practically. No hemodynamic parameters changed. But overall, during the procedure, the blood pressure and the SpO2, the Lisa group stayed more stable in comparison to Ensure. And otherwise, complication outcome wise, there are no difference between these two. So there's a nice one, which is a feasibility, which is acts as a feasibility trial for us. That it is, yes, it is still possible that you can use simple feeding tube and use it. So what is the rationale behind this Lisa? The rationale is that there are no positive pressure breaths involved. So non-invasive ventilation is going on. There is no positive pressure breaths involved. So you take out the most important factor which is causing BPD. Ongoing non-invasive ventilation is the prima facie. Okay, I've seen people doing Lisa when they try to intubate to put a catheter inside, they put the CPAP out, some beach matter. Okay, then do it. No, you are doing worse than Ensure. So ongoing positive pressure ventilation is the prima facie of it. And so hence there is no loss of PEEP even for a transient period of time, because during in Ensure,
patient was on CPAP, we removed CPAP and intubated and put the baby again on that, whatever transient time, few seconds maybe, but there is some transient loss of PP there which is not there, hence FRC is maintained. So in a nutshell, if you compare both the procedures, Ensure involves traditional intubation, but while Lisa is a relatively new technique which is really demanding and challenging for many of us. It involves positive pressure breaths where there is no positive breath with Lisa. Loss of PEEP is a part and parcel of the procedure, but there is no loss of PEEP because the non-nasal ventilation continues. Respiration is strictly under control because we are taking the airway under control. And here the baby breathes spontaneously. Hence, it is postulated that surfactant distribution is better in a baby if the baby is spontaneously breathing, because that's spontaneous breathing is negative pressure ventilation. What we are giving from outside is positive pressure ventilation. With negative pressure ventilation, the distribution is much better. That's the postulated hypothesis. So Lisa scores there. There is no spillage. Okay, different studies have mentioned different, but approximately you can expect a spillage of 20% of surfactant. Okay, in Lisa. It always comes under control. The baby goes into apnea because essentially you are creating by giving surfactant an upper airway obstruction. So, if baby goes into apnea, bradycardia, desaturation, you have airway under control. So, resuscitation measure does not get delayed by the time you establish good airway. Here were the Ensure scores. So, let's see, this is what goes in our mind. This is what I've seen derived from the procedure. Let's see if that holds truth in terms of data generation and in terms of review filtration. So we'll review the dearth of studies, but we'll select a few and try to get our mindset rolling about the Lisa and Ensure. So Lisa gradually becoming popular. This is data from the almost more than 50 German neonatal unit who enrolled more than 5,000 babies. That over a period of time, starting from 2009 onward to 2017, you can see the popular Lisa going up and above. Cube surfactant like that is coming down. There is no point in discussing no surfactant because that's has become standard of care. But you can see that Lisa is getting more and more popular. So more and more people are using it. That's why more and more data is getting generated, which is pretty varied. And we'll try to sail through that. If you see the physiologic studies, that what happens with cerebral oxygenation when we do Lisa. Okay. So this happened with surfactant deficient piglets who are spontaneously breathing. And there are three groups. One was Ensure, one was Lisa with simple feeding tube, one was Lisa with a typical Lisa cath which was being used. There was short-lasting cerebral oxygenation was noticed in Ensure and nasogastric tube Lisa, but not with Lisa cath. But there is no reason why this happened. But yes, that essentially means because of Lisa, because of Ensure, whatever you do, the some amount of transient cerebral deoxygenation does happen. What happens to cerebral auto-regulation? Because we have plenty of time, we know when you are overzealously doing, we can not many times lose out on, we can create hypocapnia and lose out on CO2 control especially. What happens to cerebral auto-regulation with Ensure and Lisa? The correlation coefficient of SCO2 and mean arterial blood pressure at 5 minutes, and it was measured successively. So it rose a little in both the groups, 5 minutes after surfactant, but it recovered faster with Lisa. So, but it recovered by around 10 minutes in Ensure babies. So, auto-regulation does get affected with both the techniques, whatever you use. But the effect duration is shorter in Lisa, but it is little longer with Ensure. So that's around something like less than 5 minutes to 5 to 10 minutes, but by 10 minutes, everything became all right. So is Lisa cerebral protective? We really don't know. So let's see. So there are a few landmark RCTs were there who are comparing Ensure with Lisa. So the first one which I would like to quote, there are so many, I will go through that and see a meta-analysis of all those studies. So this was the properly designed first randomized control trial by Gopal et al. In Lancet 2011.
Last week he was there. I think our center, I think he's busy with his center answer. He's busy with his center answer.
Speak please.
Allah sir, they are opening their own center, sir.
Please mute your videos.
No, in the middle, sir. Audios. Sir, you know good thing, sir. Sir, everything else, sir.
We're not able to do that, sir, here.
So this is. I'm not going to go off stage. Huh? I tell you, whatever you do. I'll come to that, sir. I was waiting for this. Thank you, sir. So this is popularly known as avoidance of mechanical ventilation, AMV study, where 26 to 28 plus 6 weeks gestation babies who are less than 12 hours of life and less than 1500 grams were enrolled. And in AMV trial, this is the stratification according to the gestation. There was remarkable reduction of need for mechanical ventilation in the first 72 hours of life. And that was pretty significant in comparison to Ensure. Almost in terms of 28% versus 46% in LISA versus Ensure. In AMV trial, infant who received any mechanical ventilation during hospital stay was lesser with LISA, but more with Ensure, which was very significant. And NNT was just 3. So this is pretty surprising that just you need to decrease in any duration of mechanical ventilation during the whole hospital stay, where we keep ventilating such small babies for so many other reasons apart from respiratory issues. Just you need to treat 3 babies with LISA and you get voila, you get the result. And overall LISA group also had significant fewer days on mechanical ventilation and lower need for oxygen therapy at 28 days of life, where you can see this chart which is going down. The dotted one is LISA, the large dots are surfactant treatment, the standard one. But there is no difference observed according to mortality and serious adverse effect. So yes, there are short-term outcomes very promising and numerator rate was very, very, very low. The other one is non-intubated surfactant application, NIN-SAP trial. The inclusion criteria included spontaneous breathing, babies who are between 10 to 120 minutes with signs of respiratory distress, well defined. And this was previously happened with German Neonatal Network. So it was published in 2013. The abstract came into picture. The whole trial was in Germany and it never came into the popular our English literature. A similar trial got published with the same, including this data in 2015 in JAMA. So what we see is the similar result happened in both the studies, that there was huge reduction in bronchopulmonary dysplasia, which was significant at 36 weeks of gestation. And IVH also was less in comparison to the babies who are treated with LISA and Ensure. Okay, don't see the graph where there's no surfactant bars are there because these babies didn't survive only. So that's what happened. So yes, we could reduce the duration of mechanical ventilation or any mechanical ventilation within first 72 hours or during hospital stay, decrease BPD and decrease IVH. Very promising. So this is a nice article which recently got published in 2019, where the Turkey, the single center has published their whole experience over 5 years about LISA. So the LISA decrease in mechanical ventilation and need by first 72 hours of life, and overall the decrease in moderate to severe BPD was also observed. Very good, very good. So even now people are using since such a long period of time. In the meta-analysis, if we pull all the studies starting from 2011, Gopal et al., which I was talking about, to this Gupta 2020, which was much more robust and much more statistically very good study, we can see that need for invasive mechanical ventilation in first 72 hours was significantly reduced. But when you pull all the studies together, the mortality and BPD didn't reduce. Okay. So still, when we are looking at individual RCTs, yes, we are very hopeful and promising that LISA reduces duration of mechanical ventilation, any mechanical ventilation, even BPD also. But when you pool them, the data became something else. So why did that happen? So what is caveats in current knowledge? Why did this thing happen when we pooled our knowledge together? The caveat is that mortality was not a primary outcome in any of the studies. Okay, that is a hard outcome. That should improve. It's surfactant. Okay, you should try to reduce mortality. That's a hard outcome. Okay, soft outcomes are there, yes, but hard outcomes should be taken into consideration. So more or less all the trials were there, they were designed according to soft outcomes. Okay, so more or less almost all they are invariably designed and powered for the need to reduce mechanical ventilation by 72 hours only. While we keep ventilating these babies beyond 72 hours for so many other reasons. Okay, and plenty of time this was not even stated. in the published literature. So what we are left with this huge number of studies right now, start from 2011 to 2020. If we combine all this, see the last two columns. Don't go through this busy slide, but see the last two columns. Power, which was not mentioned in so many studies, see the nose in the first, second last column, and see the bias. Okay, 1 plus includes one type of bias, and many number of pluses includes the number of bias keeps increasing. But see, there are no studies which has a dash there. There are so many biases there. So that may be the reason which has led to the change in the result when we pulled all the studies together. This is the bias which is represented according to cocktail risk of bias assessment. We just try to identify the dashes, the red box in each study. Okay, you will not able to find a single study which has all the green boxes ticked. So that essentially means that all the studies are too biased. Okay, too biased because Lisa was seen to be less painful, Lisa was seen to be less invasive, Lisa was seen to be more safer. So that is the psychological aspect of what the Lisa is. Okay, we have really not studied the psychological aspect till date. So the bias is still there. So with so much of bias, should we accept those data which I was discussing previously, and should we go accordingly? Plus, there were no mention of the standardization of income when they compared it. Okay, the whatever is going on in the unit was taken as a standard of care, and they did. Lisa was standardized, but not the standard of care. Okay, this was taken just like that with her a priori knowledge that whatever is going on is the gold standard. What happened was there was no clear description of duration of ventilation, mode, ventilator parameter, vital parameter, what happened during that time. There are unequal co-intervention because the Lisa was seen to be less painful and the Inshore was more painful. So different use of sedation according to anyone's whims and fancies happened. So babies who underwent sedation analgesia, they're definitely going to take more time to come back to normal ventilation, or they have spontaneous breathing. Whether it was confounded, we really don't know. And there is no reason to believe that the putting a Lisa catheter would be less painful or stressful for the baby, because there are so many physiological studies, will come to that later, that it can be equally stressful for the baby also. Plus the dose of caffeine, the duration of caffeine and initiation of caffeine. Now we have a huge amount of data which says that the caffeine varies so much in terms of the dose and the duration when you start and when you stop. So this was not stated in almost all the studies. So these are the failures still there. Plus we all presume that yes, non-nasal ventilation goes on. Nothing changes. You know, what FRC was there, what recruitment was there was going on. But is it true? Could we prove it? Okay, we presume that. Did we prove it? No, we could not. CPAP plenty of time is not transmitted between the leaks because of almost up to 50% leak is there just because of nostril mouth, because we are trying to intubate, we are opening the mouth. Okay, a huge amount of leak happens. And this, whatever type of method you use, whatever type of interface you use, whatever type of mode you use for non-nasal ventilation, this leak was there. Plus, Lisa catheter significantly reduce the cross-sectional area of the trachea. Okay, it may increase the airway resistance from 40 to 1000 centimeter of water just by using a 5 French catheter with the smallest size feeding tube available to us. So there is no, so this is that. So if we see adult human trachea which is 25 millimeter, and in term neonate with 5 millimeter and a preterm neonate with 2 millimeter, if you put this 5 size feeding tube, see the amount of cross-section area it covers. So there is a huge amount of upper aerosol we are already creating because of catheter. Are we justified in doing it? And there is no real data that if the baby breathes spontaneously, it leads to better surface distribution. Those are our presumed beliefs. We have still not been able to prove it. Overall pain during Lisa is now a well-known thing because discomfort or the laryngoscopy itself is very painful. Okay, and that is a part and parcel of it. Whatever method you use, you call it Lisa, you call it Miss, you call it Ensure, laryngoscopy has to happen. And due to blade-induced stimulation of supraglottic area, which is very reflexogenic, even with a short duration of just 5 seconds of laryngoscopy, can lead to increase in the catecholamine concentration. It rises the systemic and pulmonary blood pressure. Positive tachycardia can cause arrhythmia in adults and also increase intracranial and intraocular pressure. So are we really mitigating any risk by doing Lisa? We really don't know. So these are the still caveats where the well-designed trial are still needed. So what the future holds? So shall we just go back to apply our own knowledge for fine-tuning Ensure, or still we waste our resources and time in fine-tuning LISA? This is a nice study where they approach the Ensure with an algorithmic approach. Okay, this is more than a feasibility study of approximately 15 newborns, where they prepared the whole scene. At the time they did, they decided what analgesia to give, criteria for analgesia. When the oral intubation started, they use the volume guarantee ventilation in between to make the ventilation as gentle as possible and maintain FRC as much as possible. Then sulfate admission was given, and after proper lung recruitment techniques, they were extubated with a predefined criteria. Here where the focus also comes into picture, where you want to induce lung ultrasound in between. There's a modified Ensure which involves X-ray, that is intubate, X-ray, sulfate not extubate. So whether X-ray comes into picture, whether focus comes into picture, we really don't know. So if we see this timer, where the timer turned on, turned off, this is the data of all the babies. So median duration, what you can see, is approximately 6 minutes to 12 minutes, where the whole scene got over. So this 6 minutes, whatever positive pressure ventilation, whatever given with volume guarantee, whether it is critical enough to cause BPD, we don't have data on that. So still there is an enigma on how much positive pressure ventilation is needed to cause BPD. With the sophisticated method and knowledge we have, still we really don't know. So this is the take-home message from my whole 30 minutes, where I tried to create all the kind of confusion in your mind. So that first principle is do no harm. Whatever you have learned and whatever you can do it. There is no point in intubating a baby after 48 hours just because you didn't recruit the lung and kept your collar up. I did LISA, I'm so very well trained guy. No, please don't do that. There is no point in no shame in accepting I'm not a hero. I'm an average guy. I'm an average but a good neonatologist. I'm perfectly fine with that. I don't want to be a superhero. So LISA, again, remember that LISA is not only just a technical procedure. It is a whole bundle of approach which is pretty complex for supporting the baby, which is pretty individualized. Again, LISA invasive procedure and its own pros and cons. Direct laryngoscopy is still unavoidable, which is pretty unpleasant. And it is the most stressful part of the whole process, whether to Ensure or whether to LISA. Reduction of hard outcome by any of the method, okay, it is yet to be shown. So do what you have learned, do what you mastered. Like in ventilation, we say LOVE, L-O-V-E, that is learn your ventilator efficiently. So whatever you do, if you want to go from distance A to B, if you know how to drive a simple Maruti 800, drive Maruti 800, there is no point in getting a Mercedes A-class AMG, okay, where you don't know how this bloody car starts. Okay, so whatever you learned, whatever well versed with, do that, you'll reach more safely. So I leave you with this question that we really don't know because of caveats or literature what to do. Is the fine-tuning of Ensure the final answer to everything? Going back to square one. Thank you so much for bearing with me.
Thank you, sir.
Sure, sir.
Mic on ಮಾಡಿ sir.
It was same, but it was different with different studies. Even the brand changed, the dose changed, and the number of doses also changed. In comparison to single comparison, yes, the same brand, same dose was used, but in different studies, and plenty of time in the same study, in different babies, different things were used. Like that. Yes, sir.
Mic. Anna, mic kodina.
Sir, regarding prophylactic expectant administration, they were contemplating that giving expectant before the first breath also. So it's as early as possible, it's better. So even in that case, if you use LISA technique, still you don't want to go ahead and give few positive pressure ventilation.
Sir, the idea is to reach to LISA. There are so many steps before that, and Amit sir spent almost an hour for that. that it's a good perinatal care, which is important, a safe delivery, thermoregulation, maintaining FRC. Okay, so initiation of delivery of CPAP should take a precedence over advancing surfactant. So that is much more important.
Not being done, but when you decide go with laser technique as early as possible in the labor room, so let me do as early as before first breath or few breaths, where the baby is still lungs are in collapse. You do laser technique and then you straight away go for CPAP, or you don't mind giving any. Or is it okay if we give few positive pressure ventilation bag and mask and then go for CPAP? Just to see that make sure the alveoli get expanded.
No, sir. If given a choice and if the baby is feasible, the level of CPAP is always preferred over positive pressure breaths. And in your question, if you want to see, even the first breath is not baby has taken, and I want to give surfactant first because the better distribution and the alveoli still fluid filled. Yes, LISA can be used, but still we could not have demonstrated that whether the whatever beneficial effect what we have seen is because of surfactant because of LISA. So surfactant is more important than the LISA in the scenario you're discussing, sir.
I mean, we can straight away go for CPAP after.
Yes, yes, why not? That's where the beauty of delivery of CPAP comes.
Thank you.
Yes, sir. Yes, sir. Sure, sir.
Hi, good afternoon, Dr. Smith.
मैं आपके प्रश्न आंसर नहीं कर रहा हूँ.
Excellent presentation, sir.
Thank you, sir.
Sir, just a doubt that when we are talking about the resistance to the airways, are we thinking about resistance in the airways? Resistance in the airways is 50%. Are we thinking that the baby is breathing through that LISA catheter?
Yes. The common belief is that baby breathes while we are instilling surfactant.
But that is too small if we say that airway.
Yes.
So
that's what I'm trying to point out, that our belief that the baby breathes through that such a small area, and that spontaneous breathing is leading to a better surfactant delivery because it's a negative pressure ventilation. That belief may not be true. So that is one of the biggest caveat in our old belief when the LISA came into picture. So there are high chances that what you are saying is true. I also believe the same thing, that it may be the possibility that baby doesn't breathe during that time. Thank you, sir. Sure, sir.
Thank you very much, sir. It was a very great talk you have presented. A couple of things that I wanted to share. Particularly when we are doing LISA, we are going to open the mouth using the laryngoscope. So the question of retain the PEEP is gone. Once you open the mouth, the PEEP is gone. I don't think that we can retain the PEEP. Probably, I think that has been told in many articles, which we think it is true because the CPAP is still on. Even the CPAP is still on, it is not there because they have opened the mouth. That's number one. The second thing is we are still intubating, but with a different tube. So all the things associated with intubation is not being there. So just now about giving sedation during LISA. I don't know whether that is practice. People do LISA without sedation or pain relief, and compared to Insure, where at least in my unit we use morphine before. So that might be a bit of different thing. Regarding breathing, yes, they do breathe because I have witnessed myself, but they do breathe around the tube, not through the small intestine. So they do breathe. Probably that is one thing. The fourth thing that I want to say is, whenever we talk of any intervention for that matter, we need to understand why we are intervening. We are intervening because the quantity of the disease is that itself is the biggest reason why we develop the complications of PPD and all those things. And only thing that we have to say is how gently we can do the things that we are doing. So attributing everything for intubation or LISA probably is overstated.
Yes, sir. Truly stated, sir. And that's the same thing when we brought out the last slide of the pain during LISA procedure. So the way we think, our myth is that it is less painful, it is much more safer, may not be true. You are perfectly right, sir.
Any more questions?
Hello. 30% is big amount, sir. But overall, again, that's why the hard outcomes need to be studied, whether whatever spillage has happened, that has done some role or not. So if we look at just the current present literature with us, that yes, it doesn't matter within first 7 to 8 seconds. Whatever spillage has happened, whatever has gone inside, it is fine at least for first 7 hours. It is doing the trick. Yes, sir.
Good afternoon, sir. Actually, I was in Australia for almost 9 years. One of my senior consultants in Newcastle taught me a new method of giving surfactant in Ensure technique. So what we do is we just, as the baby is on CPAP, we put a tube in, connect the neo with only CPAP. We don't give any positive pressure ventilation. Baby is stable enough. Then we quickly take out the CPAP, give the surfactant and connect back the CPAP. No positive pressure ventilation unless the heart rate drops down or the saturation is significantly low. Baby picks up within few seconds. So no positive pressure ventilation is given to these babies and they do very well. Next 30 seconds, we connect the CPAP and take off the tube. And these babies do really well. What's your opinion on this?
There is no way of doing it. And what you mentioned was doing the CPAP, that is essentially an ET CPAP. So we all know that ET CPAP, none of us are very comfortable with. But yes, since it's a brief period, again, I was stating the same thing again, that in Ensure, if you do it in a controlled way, the mean duration is just 6 to 12 minutes. Okay, overall, the most of the procedure got over during that time. So whatever, however biases are, if we are finishing the procedure in 6 to 12 minutes, whether it is clinically significant, the answer is yet to be devised. So a novel way, sir, we can join hands and we can definitely pull data on this. Definitely, we can more fine tune the whole technique, and we can definitely generate data on this. Very good point, sir.
Thank you.
Thank you, sir.
Thank you, sir.
Thank you so much. Thanks for bearing with me.
Thank you, sir. Next, we have on stage Dr. Amit Tagare, Director and in charge neonatologist, Aditya Rainbow Super Speciality Children's Hospital, Maharashtra.
Good afternoon and namaskar. It's time for nutrition of neonatologist, but I'm going to talk about nutrition. This is the birthing issue. I left this baby in my NICU. This baby was born 26 weeks, 950 grams. One of the twins, the other twin died on day 2. On 23rd of September, so it's almost 3 months. Baby had RDS, ventilated, surfactant, high frequency, HFNC, had PDA. We had to give ibuprofen. NEC stage 2B, managed conservatively, but needed prolonged parenteral nutrition, almost 3 weeks of parenteral nutrition. Had E. coli sepsis. Then this baby around 1 month of age had sudden increase in the oxygen requirement and respiratory support. So when we screened out, it turned out to be a bilateral patchy involvement of lung and a severe GER. And the surgeon wanted to intervene, but the the parents refused. So overall, the baby needed prolonged respiratory support, almost 4 weeks. Had ROP, laser was done. Now is 11 weeks. Baby was in with mother in the room for almost 2 weeks, and this Monday early morning was brought back to NICU because the temperature fell down at 2:30 in the morning. Was planned to discharge on parents' request. Readmitted in the NICU 3 days back after episode of hypothermia, back to HFNC for last 2 days. Current weight is 1200 grams. Now, what is the key issue? So many issues. It's a textbook neonatology case. This is the baby when it came back to NICU. So this is the UGI. This is what we are going to talk about. It's an old problem. If you search the literature for almost last 3 decades, we find this term. And this was the paper in 2008, where it said that it's an urgent need to modify our practices to reduce this. Why it is important? Growth in neonatal intensive care influences the neurodevelopmental and growth outcomes of extremely low birth weight babies. So it is important because it has some long-term implications. We'll see that in detail. Now, this is what we published in 2013. This was the Pune AHBW cohort from KM Hospital. Between December 2006 to May 2008, 47 ALBW babies who survived. So the survival of that cohort was 57. So around 87 patients, of which 47 survived. The weight gain during that time was 5.4 grams per kilo per day. Length gain was 4.48 centimeters per week. And head circumference gain was 0.33 centimeters per week. KM Pune has always been one of the greatest institutes in India when it comes to nutrition. Pioneer in so many things. And this was one of the best places. Now where we are. What is expected? Weight gain at least 15. Ideal is 18 grams per kilo per day. Length gain of 0.75 centimeters per week. Head circumference gain of 0.75 centimeters per week. We are far behind. Now, the most troubling thing about that was a long-term follow-up study. So the patients were followed up and the assessment was done at corrected 1 year. And where we found that there was significant correlation between the head circumference gain during NICU stay and DQ at corrected 1 year. So we are going to affect it in some way. Now, what is EUR? So we know that this issue is there. Probably we are negligent about it or we are ignorant about it. That's why we don't bother about it. Like we are more worried about LISA, but we are still not worried about EUR. That is the fact. Nutrition is always at the back seat. So inadequate growth happening during hospitalization is EUGR. So NICU, during NICU stays from birth till discharge, whatever the growth happens, if it is inadequate, it is EUGR. It is commonly reported in preterm and very low birth weight infants. At discharge, weight is often at lower percentile with respect to the birth and below the 10th percentile expected by the intrauterine growth charts. Length and head circumference go hand in hand with weight and they are lower. Now, how do we define it? So there are two definitions. One is a cross-sectional definition where at one time point we take the weight and head circumference and length. And if it is less than 10th percentile, it is EUGR. Or there is a longitudinal definition where we measure the weight loss during the NICU stay till that time frame. And if it is less than 1 or 2 standard deviations between the birth and that time window, it is EUGR. Now, what is the time window? Different definitions. Somebody takes it at discharge, somebody takes it at corrected 36 weeks, somebody takes it 28 gestational day. What is the incidence? That also varies because of different definitions. But overall, in less than 30 weeks and birth weight less than 1500 grams, it is 59 to 78%, a big number. If it is a big baby, that is less than 34 weeks and the birth weight is less than 2000 grams, it is almost 1/3 babies. EUGR is more common in preterm and SGA compared to preterm and AGA. Now, what causes it? So many factors, prenatal factors, postnatal factors, we'll just touch them. So overall, what defines the growth? Growth is defined by the genetic potential. Here, the intrauterine factors also come in picture. The nutrition that we do during the NICU stay and the social interaction, which is the morbidity that happens and the interventions that we do during the NICU stay. Now, prenatal factors, we all know maternal nutrition in India is a big problem. WHO is telling us about this for a long time. On top of it, there are maternal morbidities. Now we are getting obese mothers with other morbidities. So it once again becomes maternal malnutrition with the morbidities. And the fetoplacental circulation when it gets affected with the maternal morbidities. Now we all know that the maximum growth happens in the last trimester and it's very difficult to match. We have to accept it. We can't absolutely copy the nature. The amount of nutrition that happens during that last trimester is huge and it is very difficult to match when we are doing it artificially. Now, neonatal morbidities and postnatal nutrition are the two things that where we come in the picture. Now, neonatal morbidity is associated with EUGR, low gestational age, which is obvious, high birth weight Z scores, so larger babies have more EUGR. Male babies, those babies who need treatment for PDA, necrotizing enterocolitis, intraventricular hemorrhage, and longer duration of parenteral nutrition. All these things are interrelated, and we can understand why these things happen. So, in general, a smaller and sicker baby with necrotizing enterocolitis is the candidate for EUGR. The postnatal nutrition, why it is important? It promotes the physical growth, that is what we always check, but it boosts host immune system. We all know nourished patients have better outcomes, they have lesser infections. Maturation of newborn gut happens earlier with good nutrition. It enhances the neuromotor development and it prevents the long-term problems like osteopenia of prematurity. Overall, it's a global role of nutrition. Now, third trimester is the vital period and the first 2 years are the vital, and any deprivation happening during this time is going to affect the developing brain. Now, they are missing the third trimester where the maximum nutritional accretion happens. They have low growth, low energy stores, high protein accretion rates and high metabolic rates. So they are at a jeopardy. Delay in initiation of nutritional support leads to postnatal malnutrition, and this leads to measurable growth failure. This has been proved almost 25 years back. Now, the more important thing, when we always talk about the Barker's hypothesis or adult onset diseases, the nutritional factors and other environmental signals could regulate gene expression through epigenetic modification. That is what we call Barker's hypothesis. So epigenetic mechanisms is a bridge between the environmental stimuli, where diet is also very important, and long-lasting phenotype acquired during the intrauterine life and first weeks of life. So here genetic potential remains same, but the expression changes. So it is not the hard change, it is the soft change. DNA methylation is the key component of epigenetic network, and nutrients may modify the pattern of DNA methylation. One of the most important mechanism is epigenetic control is genomic imprinting. So that is what we call it. Indians are thrifty phenotype. We deposit more fat than any other Caucasian. So it is the truth, and that is what is the epigenetic change. Chromosome 11 at the locus of P15 is the key region, and it is involved in the control of the growth and development. IC1 is involved in that, and it is located around chromosome 11. Now it is the independent imprinting control region, that is IC, and that regulates IGF-2 expression. So that is how it boosts the growth in later age and leads to obesity and cardiovascular risk. EUGR for weight and head circumference correlated with increased IC1 methylation. Reduced protein and lipid intake causes IC1 hypermethylation. So it is like that nutritional deprivation happening in first few days of life is going to increase the risk of adult onset disease. IC1 hypermethylation could be the reprogramming mechanism to promote the catch-up growth by means of increased insulin growth factor 2. And that may have potential effect on the metabolic homeostasis. Why I mentioned all this? Because we should understand we are not just talking about the short term, we are really talking about something that is a serious issue in the long life. Now, how do we manage it? The first and foremost important thing is the growth monitoring that lacks most of the time. Quantifying EUGR, unless we quantify it, we cannot understand it. And then nutritional management. Growth monitoring, everybody has his own choice. Fenton's growth charts are used most by many people. Now current standard is Intergrowth 21. With Intergrowth 21, you get a more global view. It actually helps in reducing the number of SGAs in our unit. With Fenton's, we have more SGAs in our unit. Now, how do we quantify? Now, it should be a quality care index. we always have the quality care index, like for any patient. So what is your WAP? What is your duration of NICU stay? This is one quality care index that we should have. Difference between the weight Z score at discharge and at birth. So that will give you the quality, nutritional quality of your unit. Weight in change in weight Z score is influenced by the birth weight Z score and completed weeks of gestation. This should be accepted. So when we are actually doing the audit, then we should take this thing in consideration. But for a number point of view, even difference between the weight Z scores is good enough. Regular assessment of nutritional performance of the unit is important. That regularity we can decide once in a year, once in 2 years, once in 6 months. It all depends. Correlation of current nutrition strategy with performance. I'll show you later on the nutrition audit of many of times we feel we are doing something, but we are actually doing something else. Necessary modification can help in reducing EUGR. So one thing we should understand, if we look at these babies, it is the same group of babies and same time window where it happens. It causes IUGR because of in utero factors, and if they are born earlier, they become EUGR. So probably they are always at risk of it. They are born earlier, so we face it. If they are born later, they become the IUGRs. Like a baby who was supposed to be at 37 weeks, 3 kg. Comes out at 2.5 kg. We don't understand the difference, but he has already lost 500 grams. So that is the IUGR. So EUGR and IUGR are on the same time frame. Now postnatal nutrition. Now it has already been touched in that panel. So enteral nutrition and parenteral nutrition. Now we all know the gastrointestinal system is the inner tube of life. I am not going to talk a lot about it. I will just be going through because we are already running late. But the only thing is ongoing growth and maturation of the preterm babies. So there is increased metabolic demand and there is increased permeability of the mucosa. So there is reduced protective mucus. The motor immaturity of the preterm gut affects the feeding issues and imbalanced nutritional microbiota due to bacterial overgrowth by NICU organisms. So overall, the neonate, preterm neonate is at the disadvantage. Digestive capabilities of preterm are low.
Hello. Ma'am.
Now, what are the decisions? I
Rima,
am going to just touch about it because
you're
itself
the
is a
one
big
only, no?
topic in it. Actually, there are 5 decisions that we take when it comes to nutrition, but I am going to touch only 3 here because we are talking about initiating nutrition. When to start, what to start, how to progress. When to start, as early as possible. The moment the baby is stable enough, start it. Minimal enteral nutrition, it is very important. It is hypocaloric. It is just a protective thing rather than nutrition actually, but it has its own benefits. It stimulates the growth of the GIT. And it has been shown to be safe.
To the same number?
Benefits of trophic feeding are a lot. It reduces the risk of sepsis, early achievement of full enteral nutrition, early regaining of birth weight, and early discharge. Early versus late feeding. Here the early was too long actually. This early was almost 4 days. But what we nowadays talk about early is less than 48 hours. So early feeding shows better weight gain and there is no increasing NEC. Now what to start? Breast milk is the gold standard, we all know. If you don't have breast milk, nowadays we have donor breast milk, which is a good thing to make it available. If not, then the final is the humanized preterm formula, but we try to avoid it as much as possible. Breast milk is a well-balanced source of both macro and micronutrients. It has unique quality that it changes the composition as per the baby's need. Higher bioavailability of the components means adequate, apparently lower levels, but adequate nutrition. Immunonutrition is something that happens with breast milk. It is the individualized immunity by the mother to her baby, because many of the times the early onset sepsis, the organisms are safe and the mother can give the specific immunity. Development of healthy microbiota, it reduces the risk of necrotizing enterocolitis. Higher intelligence, it has a big IQ benefit, and there is a reduced risk of obesity and metabolic syndrome. Human milk fortification comes into picture importantly when it comes to growth. Now, we all know larger volumes are needed for adequate calories, and when fortified human milk is compared with preterm formula, there is lower incidence of sepsis. So that is why we prefer human milk, and if there is any deficiency, we try to fill it with the fortification. Now, this is what are the requirements. We all know energy is 110 to 150 kilocalories. Protein 3 to 4 grams, calcium 120 to almost 240 milligrams, phosphate of 60 to 140 milligrams. Now, what is this is the preterm milk concentration. To cover the energy thing, we have to give almost 200 to 250 ml per kilo of the milk. Protein content is very good in preterm milk in first week of life. Calcium is low, phosphorus. Fortification, there are multiple options, but we will be talking only about multi-component fortification. At least 2 components. There are more than 13 studies. Intake, when you start fortification is individual decision. Short-term outcomes are good. There is increase in weight gain, length gain, and head circumference gain, and increase in nitrogen retention. Long-term outcomes, no much difference. Negative outcomes, nothing was found. Nothing significant was found. So sufficient evidence for improved short-term growth when it comes to multi-component fortification. So proved role for protein, I did not talk about it because the time is a constraint. Protein and multi-component supplement is almost similar when it comes to short-term outcomes. There is no evidence for carbohydrate, fat, or as a monocomponent like Simal MCT oil. Impact only on the short-term growth, but there are no proved benefits on the long-term. Now, how to increase the feeding volume? The usual recommendation. Nowadays, we are doing it faster also. There is no difference between slow feeding enhancement and fast feeding enhancement when it comes to risk of NAC. Parenteral nutrition. We need parenteral nutrition when it comes to VLBW and ULBW babies because the GIT is still developing and those babies may not tolerate enteral nutrition. So this was the 2010 recommended parenteral nutrition guideline of NNF. So all the units who provide intensive care for very low birth weight babies and sick babies should provide it, and all eligible units should be started at one parenteral nutrition at the earliest. Which babies? This is the guideline. All babies less than 1000 grams, all babies less than 1500 grams who cannot go on measurable feeds by day 3. And more than the bigger babies, unless you are sure that they are going on 50% of enteral nutrition on day 5. NEC obviously needs and surgically correctable gastrointestinal anomalies. When to start? Earliest. Energy requirements, it is same. Now the question when this guideline came was, is it feasible in India? So we did a study. It was a randomized controlled trial of aggressive parenteral nutrition on sick very low birth weight babies. This was published in Indian Pediatrics. Now aggressive nutrition was 3 grams of protein and 2 grams of lipid on day 1, and the control limb was the conventional criteria. If we see the outcomes, the average calories received were significantly higher. Average parenteral nutrition calories were significantly higher. So it was the parenteral nutrition that was causing the benefit. Nitrogen retention was high but not significant on day 4 and day 7. Earlier, the babies regained the birth weight earlier, but that was also not significant. But almost 2 days earlier, the babies gained weight. The babies reached full feed by 3 days earlier. And the duration of NICU stay was shortened slightly. Now, biochemical parameters we were worried about, but nothing changed on day 4 and day 7. So there was no significant change, except for the bicarbonate on day 7, which was slightly coming to significance, but it did not affect. There was no significant adverse clinical outcome. So we could conclude that the aggressive parenteral nutrition is safe and feasible in developing world. So we can promote aggressive parenteral nutrition. Now, early parenteral nutrition is significant because it is associated with significantly greater weight gain, and early parenteral nutrition is associated with shorter duration of parenteral nutrition itself. Now, how does it affect the long-term outcome? Every 10 kilocalories increase in first week of life improves the MDI by 4.6 points, and every 1 gram per kilo of protein intake increase is associated with 8.2 MDI increase. So higher protein intake will help in better outcome. So that was the first thing where we did the ELBW analysis, and that was a very saddening thing that we feel that we are doing good, but still we are not close to the outcome. So I did the audit in my unit, and that was between May 2013 to July 2014, and VLBW babies were analyzed for initiation and duration of nutrition interventions like parenteral nutrition and enteral feeding and fortification. So by this time I was thinking that I was doing really good because we are very aggressive. 74 VLBW babies were assessed, around 3,100 grams, around 31 weeks. Mean time to start parenteral nutrition was 1.2 days. I was still feeling that I'm doing on day 1, but because of our logistic issues, it went on 1.2 days. Mean duration and the enteral nutrition was started on mean 2.8 days. So that was still delayed, though I was feeling I was doing good. Mean duration of parenteral nutrition was short, 7.3 days. Mean duration to reach full feed was 9.7 days. Mean time to start HMF was 9.6 days, and mean weight gain was 10.4 grams. So it was 5.4 grams, it reached 10.4. There was some increase in around 5 years. So still long way to go. Incredible things can be done simply if we are committed to making them happen. So we should not lose our heart. Keep on doing it. From 5 to 10, probably in next assessment it might touch the 15. So what is the take-home message? UGR is a serious and common issue in NICU. Probably it's invisible. Both parental and postnatal elements cause UGR. Prenatal and postnatal elements cause UGR. UGR causes epigenetic change and has long-term effects. So we should take it seriously. Growth monitoring of sick VLBW babies is necessary. We are so busy with our other things that we forget to monitor the growth. Nutritional plan for VLBW babies include both enteral and parental nutrition, and sometimes we have to individualize the nutrition plan. UGR should be a quality care index to improve the nutrition performance of the unit. Thank you.
Mic. Anna mic. Mic kodi.
See, from around 3 weeks, this baby the mother was actively involved in the baby's care. And in my unit, we have mother rooms which are exactly in front of NICU. So you open the NICU first door, you enter the mother area, and you open 2 doors, you are in the NICU. So we encourage this. So the KMC was going on, everything was going on. So the mother was actively taking care of this baby, and almost for I think 2 weeks, this baby was with mother, because anyways what things were happening in the NICU were done by the mother, because this baby was not on any medicines per se. Everything was going on was for that. What is spoon feeding? Milk scan was done, and then the barium was done. There was no constriction. So the pediatric surgeon wanted to do fundoplication, which in this case was actually needed because this baby was gaining weight, going back, gaining weight, going back. It was like a pendulum. So, but the parents did not want. Parents were afraid of surgery. Yeah, this is a different scenario.
A lot of fundoplication. They don't have to be 3 to 6 months. So if you have a reflux significant enough, grade 4 to having acute life-threatening event and other things, you have aspiration. No. I have small baby. I have 1.2, 1.5 kgs who have and then know about this.
See, it all depends on the surgeon's skill. See, this is the baby where everything happened. He's not gaining. He went back to respiratory support because of that GR, going to the extent that I did not have the X-ray, but it was bilateral lung involvement. And it was terrible. So we CLD, this baby remained off oxygen for from 1 month of age. When we started this anti-GR things, then the baby went off oxygen. The baby was with mother for almost 2 weeks. Before that, 1 week, the baby was without any oxygen. So it doesn't fit in the CLD definition. And the X-ray was pneumonia. In CLD, we don't get that pneumonia thing.
Can I have just one brief, please? Following this large randomized control studies, grade A evidence came regarding standardized feeding regimes, where based again it is regarding introduction of this total parental nutrition based on some antenatal risk factors like umbilical artery flow and oligohydramnias. In a situation like that, where if we regarding this early nutrition and early parental nutrition, it's a bit more enthusiastic if we start early to improve this EUGR. Are we again, there's any possibility of, because following standardized feeding regime, virtually the neck is almost gone now, almost in extreme preterm babies. So in something like if we start early thinking of EUGR improving, can we have some more, slight increased incidence in neck?
Increased incidence in neck.
Yeah.
See, we are doing so many things in last 50 years. Certain things remain same. The incidence of neck has remained reasonably at the same level. It changes with the unit. But if we pull the data, the incidence remains at the similar level. So it is all about our interventions. And as Samir has shown in that Lisa thing, if I have some certain idea, then I am biased to it. My study is designed in that way and my outcomes come in that way.
No, but for with the standardized feeding regime after this huge randomized control study from Australia, the neck incidence fell dramatically.
See, that's what I'm saying.
Now with a bit of enthusiasm, if we start thinking of EUGR, my worry is, are we against, is there a possibility of the neck incidence increasing? That's all.
See, that's what I'm saying. Individual unit has individual parameter. Now, when we see the prophylactic for fluconazole use, those units, if you check in their and fungal infection, 25%, 30%, that fell down. If my unit has 1%, so this thing, what we are talking, that aggressive nutrition, aggressive parenteral nutrition is going on there for almost 10 years. It has not increased the incidence of neck. It all depends on the individual baby. It is all about a sudden drastic change. If you do some drastic change in your management, your outcomes might change drastically. If you are doing something in the same manner for some time, and that's what we always say, it is not the Ferrari, it is not the Schumacher, it is Schumacher behind the Ferrari. So if you are comfortable with certain thing, there should not be anything like increase in neck because we are doing something different. We are really not doing something different. This is what we are doing it for a long time, and this is what we should keep on doing. The ultimate thing is to avoid EUGR. Now my unit's EUGR incidence is 80%. If I go aggressively, my incidence will come down.
I have to say one thing, your doubt about standard feeding regime. The standard feeding regime now also does not ask you to stop feeding, unlike others. Because even from the GRID trials and other trials which they talked about, earlier we used to stop feeding for children with abnormal Dopplers and other things. So that has gone off now. Even with abnormal Doppler, we have started feeding them earlier. Now only for less than 1 kg with abnormal Dopplers, you be little careful. So even for those babies, there is a standard feeding regime that your rate of rise is little slower. That is probably what Amit has shown in his study, that the rate of increase may be little slow in them. But by trying to keep them nil by mouth, which we used to do early, we probably are colonizing them with bad bug and increasing neck. So by not feeding them, we increase the neck. So you feed them, try to get them onto the full feeds. The small babies which you are talking about, maybe they come out of full feed by day 10 or day 14 based on how small and what the abnormal Doppler are. That's the only what your standard feeding regime is. And but we have to be aggressive with the nutrition and prevent UTR. That's very what we're talking about.
Yeah. Thank you very much.
Hello. Sorry.
If we go through the trials, most of the trials are at different level. Now there are trials where it starts from 120 mils per kilo of enteral nutrition to 150 mils per kilo. So close to your complete feeding. Now we did a trial long back. We did not publish it. Where we started at 75 mils per kilo. When the baby reaches 75 mils per kilo, that is the half of the enteral nutrition, we started fortifying. It did not increase the risk of neck or any other thing. So it is all about your comfort. Now people are starting even at 50 mils per kilo. So it is all about your unit's recommendation. There is no certain recommendation that when to start, but at least 1/3 of enteral nutrition you achieve, the baby tolerates, you can start 45. If you are not getting mother's milk, if you are not getting, you don't have a breast milk bank, rather than formula, it is always better. I use it because rather than using a preterm milk, it's a donor EBM. 45. See, every fortifier is pros and cons. The ideal fortifier should be a liquid fortifier. Availability and cost are the two major things. Now in India, the widely available fortifier is the powder formula. Powder fortifier. That's what people use. It has changed its constitution. Initially, it was 1 sachet for 50 mils of milk. It has come down to 1 sachet for 25 mils of milk. But whatever you use, as I said, it is always about your convenience and your comfort. So your patient should not be, for one thing I want to do, I cannot jeopardize my safety of my patient. So slowly you can change over. And anytime we always say, when we are reading a trial, we check only two things: internal viability, if the trial is worth reading it, and external viability, is it valid for my unit? Something might be very good, may not be valid for my unit because of my conditions. So a fortifier, whatever available, you decide, you choose in between it, and whatever you feel is comfortable, safe, you can start using it.
Also, I want to ask, since we are, we are so much with the early aggressive nutritions, early nutritions, and then fortifications, and then going along. So what parameters, if there are any, that defines excessive catch-up growth? I mean, since when you talk about time-based feeding, 2 hourly feeding or 3 hourly feeding, mother is so much terrified when she goes home that whatever happens to the baby, she looks at the time. If it is past 2, she is going to feed the baby, whether the baby is happy or not. So that is going to take care of his UGI, that is extrauterine nutrition. But what about excessive gain in weight, these kind of specifically post-discharge?
See, catch-up. What we say in catch-up is when we plot the graph, it should not jump the standard deviation lines rapidly. So it should be a smooth line and slowly going to the level. So what we say now, we have a 26 week or 1 kilo and 900 gram. I like him to reach the normal line or jump the lines in first 2 years, not before that, not in 3 months, 4 months. Now feeding thing, now catch-up will not depend on feeding 2 early, 3 early, 4 early or what. See, we always tell the mothers, by 2.5 kg, your baby goes on demand feeding. It is all about the physiology of the baby. Why we are doing it 2.5 early, 2 early, 3 early is all because we don't want that hypoglycemia and all those things. The feeding volumes are small. As the baby is growing, baby takes on its orally, and we usually transfer to breastfeeding around 1.8 kg to 2 kg. By that time, we know how much baby is taking orally. So if the baby is taking orally well, the baby himself starts giving the cues that I am not hungry. And that is the time when the demand feeding comes in picture.
So it should be like a demand-based feeding. See, by the time the baby is discharged from an ICU, just to prevent this excessive catch-up in growth.
See, one thing is we should understand whatever catch-up growth and all these things we are worried about, that is beyond 2 years. There is no data saying that under 2 years giving excessive protein or fat or whatever it is going to cause adult onset diseases. It is EUGR that will cause. The catch up beyond, like overnutrition beyond 2 years definitely is dangerous. Under 2 years still not. Other thing is, it all depends on your discharge criteria. Now in India, we don't follow the standard discharge criteria. I had done a discharge analysis, early discharge analysis of my unit. Many of the babies were being discharged at 1.4 to 1.5 kg because the discharge criteria was with mother feeding, baby gaining weight. Even with that, I found that by going home, they were actually growing better than NICU. He was growing at 10 grams per kilo in my NICU, is growing at 20 grams per kilo at home. Probably because of the maternal social issues and comforts.
Maybe a time-based thing.
Sorry?
Or maybe a time-based thing, that is, she might be feeding 2 hourly or 3 hourly, whether the baby is healthy or not.
Whatever we are worried about a rapid catch-up. So we just have to tell them that, okay, now he is growing faster, you have to curtail it. Now you go to demand feeding. And usually your HMF and all those things stop at 1.8 kg if he is on HMF. So your fortification, all those things stop by the time the baby is 1.8 kg. And then the slow things change over. If they are on breastfeeding, they usually do well. These all problems come when they are on formula feeding. With formula feeding, they grow very rapidly. But you have to warn them. See, obesity is one thing that we have to warn the parents. Usually they come to us, baby is not growing. We have to warn them about obesity. I actually show them on the chart, your baby is jumping here, now in the overweight criteria. Now we will be going to obesity criteria. So that is how we have to warn them.
I mean, excellent presentation. So what is the role of supplements like vitamin D, iron, multivitamins, or calcium, phosphorus in preventing this EUGR?
If we are fortifying the milk, then we don't need calcium, vitamin D, it comes. Vitamin D we still need, but calcium phosphorus supplementation happens with HMF. But iron is not there.
With all the HMF, any difference between these HMF are available?
So that's what we have to go through the HMF thing, what it has. Now the powder HMF that is available widely has good enough calcium, good enough vitamin A, good enough vitamin D. Iron is not there. Now ELBW babies, it depends on the weight of the baby and sickness of the baby and the transfusion that happens during NICU course. We can start iron supplement somewhere between 2 to 6 weeks. I usually start around 3 weeks. That is the time when I start supplementing them with iron. Now, if they are transfused, then we better wait for 3 to 4 weeks. In that time, you can, if you want, you can supplement them with folic acid. Now, if the baby is only on mother's milk, then we supplement them with the calcium. Then calcium, also the preparation of every calcium supplement is different. Some have 82 milligrams of calcium with 50% of phosphorus, some have 150. So depending on that supplement, the ideal thing is you supplement with calcium at around 120 to 200 milligrams per kilo of calcium. Automatically the phosphorus comes in the half range. Iron supplement, now calcium phosphate supplementation. The international recommendation says by the time the baby reaches term or 3 kg, you stop it. Now, you have to do. Now, what I do personally is at 3 months, I check their vitamin D and calcium levels. And if their calcium and phosphorus is more than 5.5, calcium is normal, vitamin D is normal, I stop it. But most of the patients are not at that level. So I continue it and then reassess them at 3 to 6 months, after 3 to 6 months. Iron supplementation is recommended for 1 year. Now, despite that supplementation, if you check the hemoglobin at 9 months, you will find most of the babies are anemic. Now, probably because of the intolerance of iron, the compliance is not good. So, the recommendations are there. There is no definite Indian study, big study, which will say that, okay, you follow this international recommendation of 3 months stopping the 3 kg and at term stopping calcium phosphorus. So, you have to be individualized.
One commercial human milk bank is aggressively promoting breast milk derived fortifier. And do you have any experience and how does it affect the growth?
Breast milk fortifier?
No, breast milk derived fortifier.
No, as still not, but actually it will be good because if you read the studies of protein supplementation, that is that milk, that protein source. Now, long back when we tried doing a comparison of protein and multi-component supplement, we tried a lot to get that protein supplement, but that time nobody in India was ready to do that. The only thing is, once again, we have to check it. We have to compare. We should collect the data and then think about it.
One question. I had some experience with that. There are two types. One is breast milk derived, and they have plus, where they added extra protein from what Amit has said, because the protein content is less in the first one which they added. Definitely the small babies where the risk of neck is more, I think they tolerate it better. And especially those children who are at risk of cosmic protein intolerance and other things, they seem to be doing better. It's very expensive. That's where the cost factor comes in. There are a lot of studies coming from West which sort of favors that. But is it too early for us to change practices? What is the question? But in our small babies, we do use that.
I have a question. In LBW or VLBW baby, if I start the feeding from day 1 and go on increasing by 10 ml per kg per day, 8 to 15 ml, then also to reach the full feed, I will take like 10 days, 10 to 15 days. So what do you do in your unit? You start aggressive parenteral nutrition from the day 1 and stop at some time, or you just wait?
As I told you in the recommendation, all LBW babies straight away go on parenteral nutrition. So it might take 2 hours, 3 hours, 4 hours, but they go on. VLBW babies, where we have cues that this is the baby who is going to trouble us, is very premature, Dopplers are not good, baby has sick respiratory distress, sickness of the any kind. All these conditions where we expect that this baby is going to trouble us, you can wait for 3 days, but ideally, if you feel that this baby is not going to reach at least 50% of the volume, that is around 70 ml per kilo to 75 ml per kilo by 3 days, which usually doesn't happen in most of the Indian units, it is better to start on parenteral nutrition. It is all about, see, even if you are feeding or not feeding, the catabolism is ongoing. And these babies, if you go through the data, at least to prevent catabolism, we have to supplement them with around 1.5 gram of protein per day. That is for prevention of catabolism. Anabolism start beyond that. So to prevent catabolism, 1.5 gram per kilo per day of protein and around 60 to 70 kilocalories per kilo per day. This is only prevention. 58 kilocalories per kilo per day and 1.5 gram of protein is what needed by a VLBW baby to prevent catabolism. Beyond that is the growth. So at least that much should be given to VLBW babies.
When to stop the parenteral nutrition? When you have started?
Usually when they reach around 70 to 80% of enteral nutrition, it is easy to stop parenteral nutrition.
Sir. Thank you, sir.
Thanks, sir.
ಅದು ಅಮಿತ್ ಸರ್ ಪ್ರೊಜೆಕ್ಟ್ ಮಾಡಿ. Dinesh sir.
Next we have on stage Dr. Dinesh Kumar Chilla, Head of Department and Director, Intensive Care Services, Rainbow Group of Hospitals.
Good afternoon, everybody. I thank the organizers for giving me this opportunity to sort of share with you. The topic is about role of neonatologist in management of critical congenital heart disease diagnosed continuously. I happen to work in a unit, which is a tertiary care unit and attached perinatal center. And we have a Rainbow Children Heart Institute, which sort of do 45 to 50 surgeries and procedures. So happen to have a significant experience in managing such patients. So I'll share our experience about how we manage such children. So as you know, congenital heart disease is quite sort of common in India. The various studies quote anywhere between 8 to 10 per 1,000 live births. But what you mean by critical congenital heart disease is somewhere which is happens in 1 in every 4 babies. And typically, this means any heart defects which leads to low level of oxygen. in a newborn or maybe identified using a pulse oximeter screening at least 24 hours after birth, antenatally bifocal echo. Babies with critical congenital heart need surgery or other procedures in the first year of life. And that is the reason why we are sort of discussing that. So how do we diagnose? So there are either we know through a fetal echo, scientifically diagnosed, or very important, which I would like to tell many of the pediatricians are there as the students, fellows who are there in newborn heart screening is something which I would like all of you to go ahead and implement, because that is the best way you can pick up critical congenital heart disease if you do not have a great facility of fetal echo. Because I think in India, we still do not have great facilities of fetal echo. And of course, a lot of things which we have been seeing from long is babies coming in emergencies, which means they come in a very, where they come either in shock or you diagnose them after they come in cyanosis. So how do critical congenital heart disease? Either they have a ductal dependent for pulmonary circulation, ductal dependent systemic circulation, ductal dependent mixing, or total anomalous pulmonary is written with obstruction. So you can have a cyanotic congenital heart disease with a reduced pulmonary bed flow, like a pulmonary atresia with a VSD, or you have a pulmonary atresia with intact ventricular septum, or pulmonary atresia with a complex congenital heart disease, a tetralogy of Fallot, tricuspid atresia with pulmonary stenosis, or like a cyanotic congenital heart disease with an increased pulmonary blood flow, like a TAPVR, transposition of truncus arteriosus versus single ventricle with no pulmonary stenosis or hypoplastic left heart syndrome, and cyanotic heart disease with a normal pulmonary blood flow like TGA. So how do we actually get alerted about a cardiac problem? So many a time when they normally do a TIFA scan, they do a routine cardiac screening. So when do a routine cardiac screening, they get what is called a four-chamber view. In four-chamber view, you pick up 50% of the cardiac problem. That's what you pick up. But what your cardiac problem you pick up, most of them do not have a great prognosis.
Okay, thank you. Look, thank you for the invitation to present at this August forum. I've attended a few times in the past, but it's always a pleasure and fantastic organization, especially thanks to Dr. Shenoy for the invitation. So in these 20-25 minutes, I was going to take you through these subtopics. What are the challenges facing a clinician? What is the role of echocardiography in finding out which is the duct which should be treated, which can be left alone? What's the concept of staging versus a single parameter being used as the entry point to trials? What are the international perspectives where different countries and different groups of researchers are going in terms of diagnosis and therapy? And finally, meta-analysis of all meta-analysis. What does that tell us about the PDA? What I'm not going to do today is to talk about to treat or not to treat. So thank you to the organizers for not giving me that topic, but giving me the topic about international perspectives. But hopefully in this presentation, you would find useful points which you could use in your unit, in your practice, or if you're a researcher in your next trial which you might be conducting. So patent ductus arteriosus is basically a connection between the pulmonary circulation and the systemic circulation, and in the fetal life, the shunt is right to left, which is from the pulmonary artery to the aorta. And of course, in the newborn baby, in preterm babies, it becomes left to right, which is from the aorta to the pulmonary artery. And if you are familiar with ultrasound, you can see it appears like a red color flow from the aorta into the pulmonary circulation, causing either pulmonary overcirculation or systemic underperfusion or both. Now, first important point is to distinguish a patent ductus arteriosus from a hemodynamically significant ductus arteriosus. Almost all premature babies, almost all term babies have a duct open at the time of birth. That's what is called the patent ductus arteriosus. But for the purpose of today's talk and the purpose of clinical relevance and also for the purpose of research, we need to focus on how to assign hemodynamic significance to ductus arteriosus. Either which way, it is quite common in small premature babies, as you can see, 30 to 40% in infants who are less than 1.75 kilos or extremely low birth weight babies. The challenge for the clinicians is that multiple studies, multiple trials have shown the associations between a patent ductus arteriosus or a significant ductus arteriosus with all sorts of morbidities like NEC, chronic lung disease, brain injury, but the causality is unproven. So nobody actually has shown causality. And that's where a lot of medical uncertainty arises, where, when we talk about whether treatment should be done and what are the benefits one will attain from treating. Now, if you look at this data is from New South Wales and Australian Capital Territory, two different states within Australia. You can see in this database, looking at less than 32 weeks, 23% of infants had patent ductus arteriosus, and almost all of them were treated. So the treatment rate in this study was very high, 88%. Complicated by this, if you're looking at a premature baby between 26 and 31 weeks, who is moderately sick, defined as mean airway pressure of about 7 to 8 centimeters of water and about 30% oxygen. If you leave them alone, most of the ducts would close on their own. So the question is to be asked that the 88% exposure rate to NSAIDs, is that justified or is too high? In my own institution, this is data from 2010 to 2015. I work in a unit which is a 64-bedded NICU, which is the biggest unit in the country. With 64 beds, 32 of them are ventilated, and we admit about 100 babies less than a kilo every year. In this cohort, our exposure rate is 18%, and I'll show you more recent data, and our exposure rate over the years has actually fallen to about 14%. And our morbidity data like BPD, NEC, IVH is very much comparable to other comparable units in the country. So you could see that from the same country, the exposure rate in one unit is 18%, and in the other set of babies is 88%. So two extremes you can see, and exactly the same pattern is depicted in the United States. I'll talk a little bit about that. But before that, I just wanted to briefly address what are the benefits or rationale behind using a single echo parameter to make treatment decisions or to make, to perform randomized controlled trials versus using a comprehensive appraisal of an echocardiography appraisal of the patent ductus arteriosus. So certainly it's convenient using a single parameter like, how big is the duct and ductal size. But there are a few trials which have used that, and they have seen that if you use a single point estimate of ductal size, then randomization based on that single parameter has not resulted in, benefits you were expecting, like reduction in BPD or intracranial hemorrhage. The problem with the single measurement, it can be operator dependent, and it makes some assumptions of geometry that this is most representative of a plane for that measurements. So traditional single parameters which have been used are either the PDA size or the LA iota ratio. And as said earlier, using traditional single echo parameters do not predict, even in clinical circumstances, adverse neonatal outcomes. And that is really what you want, echo parameter or parameters, a combination of parameters which help you in rationalizing therapy or designing randomized controlled trials. So this is one approach of using a single parameter versus the approach which the Canadians and our unit also follow, which is a combination of echo parameters. So Patrick McNamara and I, when we worked in Toronto together, we brought out this staging system for patent ductus arteriosus, which on the left side is, as you can see, a clinical spectrum. On the right side is the echocardiography spectrum. And this really tells you that a presence of a significant duct is not a binary. It's not a yes or no. It's not an all or none. It's a continuum of spectrum, and things might be different today compared to, tomorrow or tonight or day after tomorrow. So it's important that you don't take a dogmatic position that this is not a significant duct, I don't want to treat. When you reassess in a day later, your opinion might change. And That's the importance of using a combination of echo parameters. So this echo staging system is very similar to, in concept and philosophy, to other staging systems which you are very familiar with, like the staging system for NEC or HIE. Of course, HIE1 is not treated same as HIE3. And even for NEC, the staging system, categorizes your treatment parameters and treatment strategies. So this is very similar in concept to those staging systems. So moving from a combination of clinical and echo parameters for staging system, we have taken a step forward in focusing a little bit more into how echocardiography, especially in the hands of the clinician or a neonatal frontline caregiver, can give you a bit more information about what the duct is doing. So this talks about characteristics of the ductus arteriosus, into ductal size, velocity, reversal of flow. It also talks about parameters of pulmonary overcirculation, and also talks about, very importantly, parameters of systemic hypoperfusion like ductal steal. And I think any neonatal fellow or any neonatal trainee who's listening to this talk, you're planning to do trials related to PDA, very important from the very beginning, get into the habit of a comprehensive appraisal of a patent ductus arteriosus to make sure that, echocardiographically, this is something which is significantly affecting the baby circulatory system. Of course, there are different parameters I talked about. The ductal size is one, and you also look at the left atria aorta ratio, which is a sign of over circulation. We also talk about looking at the left pulmonary artery. So this is, you look at the diastolic flow here. So this is different compared to this is different. So this is more as compared to this. So if I had to choose between treating two babies and everything else is the same, I perhaps might treat this baby rather than treat the baby on the top. So again, this is a marker of pulmonary over circulation. Now there are a range of other parameters, and the question is, have people used them in clinical setting, and do they help us either in deciding which babies to treat and the outcomes thereof? So this is our recent work. This is, I think, last year, 2020 or so. And we use paracetamol as first-line therapy. And we stratify by echocardiography. That's very important. So we used a pre-published scoring system. We used PDA size, velocity, the size of the duct versus LPA size. And we also look at diastolic flow in the pulmonary arteries, and also the left atria and left ventricle aortic ratio. So we use these 6 parameters to assign a score. And what we're looking for after treatment is either the duct is fully closed, or this score has reduced to more than or equal to 50%. So the idea is either you're able to close the duct, or at the very least bring it to a different trajectory now, which does not remain hemodynamically significant anymore. So that's the outcome. And this is our general guide. So if there's a clinical suspicion of a ductus arteriosus by a clinician, which could be based on ventilatory requirements, murmur, white pulse pressure, we do an echocardiogram and we assign a score based on the scoring system I mentioned before. If the score is less than 16, and this number is coming from some other studies, which I'm not talking about today because of time constraints, this score out of total of 29 has the highest sensitivity, specificity in terms of treatment outcomes and morbidity. So less than 16, we don't treat, we sit tight. More than or equal to 16, we give open label therapy and re-echo after 3 days of paracetamol. And after that, we do a third echo to ascertain whether the duct is patent or it's closed. So this is our approach. And what has this approach shown us? First important thing, as I was mentioning, our exposure rate previously has been 18%. Now it's dropped to 14%. So we don't treat a lot of babies. In this group of babies, out of total 50, we treated 32. We did not treat 18. So I'm just trying to compare the two. But this approach led us to a successful outcome in terms of closure, about 72%. We also found, and that's the message I want to give in terms of whom to treat. The successful therapy was higher when we treated early. Of course, not statistically significant, but trending higher. We had better closure rates in babies who were more than 26 weeks, and we had a better closure rate if the babies were more than 1,000 grams at the time of birth. So in our hands, although we were very selective in exposing the babies to treatment, these are few things which we found in terms of where the treatment success was there. So you look at the echocardiography score. So treated infants ended up were the ones who had a lower gestation, had a smaller birth weight, and a higher composite score. Now, if you compare these 32 babies with 18 who were not treated, we still did not find any improvement in outcomes. Our BPD rates, our IVH rates, our ROP rates between treated and non-treated were comparable. So you could argue that this approach was not working for you, but I would like to argue differently. This composite scoring and using that scoring to decide treat or not treat reduced our exposure. Our exposure was never high, but it helped us reduce exposure, focus more on babies with lower gestation needs, lower birth weight, and greater shunt severity. And this is what I would like to call precision medicine. You really need to use echocardiography skills to treat babies who you think have significant ducts in a scenario where treating ducts make no difference to clinical outcomes. But if your unit which treats, then that would help you to reduce exposure to potentially medications which might have side effects. Now, as I was talking about approaches to PDA, so these are quotes from many people of repute whom many of you would recognize. Some people haven't treated a duct in the last 1 year, others treat prophylactic, others feel it is extremely important to close the PD as soon as possible. So there is a range of comments, range of opinions, prophylactic therapy, targeted early therapy, pre-symptomatic therapy, symptomatic PDA therapy. So all types of all approaches are used. So recently we published this paper in which we combined where the international opinion is in terms of different continents, different countries, how are people managing. As you can see, this is a survey of medical directors of 46 NICUs in the US. And you can see there is huge variation in practice, whether for indomethacin prophylaxis, treatment therapy, ligation. And I think a lot of it is related to the fact that written guidelines are not available in a lot of units. So if your unit wants to take the lead in terms of rationalizing therapy for patent ductus arteriosus, then first step is to make an evidence-based written guideline based on discussion with cardiology or with neonatal colleagues to see which are the ducts you would like to treat. This study is again from the US, compares 2 time points. One is era 1, which is treatment with indomethacin or surgical if symptomatic. And the era 2 is more conservative, where you give less fluids, you give diuretics, use higher PEEP in ventilated babies. And just want to show 2 things. The rate of PDA ligation in the 2 time points was comparable, and the incidence of BPD in the 2 cohorts was comparable as well. So it's important to appreciate that it's not black and white, it's not all or none. The truth is somewhere in the middle. And if you are selective in terms of treatment strategies, then your outcomes perhaps would be similar compared to the group era 1, in which you are more aggressive in treating. As I showed earlier, data from Australia, New Zealand, our exposure rate is 18%, other states is 88%. So this is data from the US, 220 hospitals, premature babies. You can see the proportion of infants having prophylactic indomethacin ranges from 0% to 59%. If you look at treatment for symptomatic PDA, then again, it ranges from 0 to 100%. So there's a wide range of treatment options being explored by physicians across the country. Interestingly, about 10 to 11% infants had a PDA, but were not administered any treatment. And unfortunately, this is data from networks, so there's no information about what are the criteria they use to diagnose PDA, and what's the contribution from various individual centers. But the point I'm trying to make is this, that if you are uncertain about treatment of a significant duct, then you're not alone. People around the world have a range of opinion in terms of how to address this problem. Now, this is data from the same group of 220 hospitals, but more recent data. So the previous slide I showed was up till 2005, and this is from 2016 to 2015. Now you see interesting trends over a period of time. You can see, first important thing, the diagnosis of PDA from 51% 2006 is now about 38%. So statistically significantly lower babies were being diagnosed with PDA. Second important thing, you look at the use of indomethacin as a treatment, or ibuprofen as a treatment. From 32%, it has come down to about 18%. Again, significantly different or lower. These are trends over a decade in the United States, 220 hospitals. You look at indomethacin prophylactic, so 11%, that's down to 7%. Again, significantly lower exposure. Now, you would argue, if PDA was such a bad thing, and of course, there are some babies, and that's where we use our clinical skills, we use our echocardiography skills to distinguish them from babies who can be left alone. So I'm not absolutely arguing that we should not treat PDAs. I think we need to be selective. But if you look at this 10-year trend where the PDA diagnosis is less, indomethacin, ibuprofen use as a therapeutic strategy is less, use of indomethacin as a prophylactic treatment is significantly less. Is it affecting outcomes? Well, no. If you look at the IVH rate, 7.51% to 5.8%, that's less. And if you look at the BPD rate, again, it's not less, it's marginally less, but not statistically significantly different. So essentially, over 10 years or so, what you see is that less number of infants were being treated, but it was not affecting morbidity in any adverse way. You might ask a question, are you more likely to treat if the baby is small, if the baby is less than 1,000 grams? Well, the answer is no. If you look at this data, less than 750 grams, 750 to 1,000 grams, or 1,000 to 1,500 grams, the rates of prophylactic NSAIDs are comparable, and the rates of therapeutic NSAIDs are also comparable. So if you are of the opinion that if the baby is small in terms of less than a kilo, I'm more likely to treat, then that's not particularly borne out by this survey from 40 hospitals in the US. Now let's look at the clinical approach. Now, again, these same 40 hospitals we were talking about, very importantly, you have to keep echocardiographic information in conjunction with clinical information. So the common things we use in terms of making treatment decisions is respiratory support. But you can see the range of indicators people use. Some people use oxygen requirements. Some people use, if they are ventilated, I would treat. If they're on CPAP, I would not treat. Some people use chest X-rays. Others use, wide pulse pressure. Some people would use murmur hypotension. So sometimes these are mutually exclusive. Sometimes they're not. But again, within these bullet points, there is no agreement as to what, for example, what are you looking on chest X-ray? Are you looking at cardiomegaly? Are you looking at pulmonary plethora, or what are you looking at? So again, there is a range of opinions within these bullet points. This is a study from France, where again, they look at respiratory criteria. Again, the range is different. Some people would only treat if the baby is having pulmonary hemorrhage. Others would treat if there is a respiratory failure. In this, they defined as needing more than 60% oxygen. Others would, any increase in ventilation parameters from the last 24 hours would be reason to treat. What was important in the study, there are contraindications to therapy. They would not treat babies less than 27 weeks. And most people these days argue that infants who are 23, 24, 25 weeks, they are the ones who perhaps might be more deserving of treatment. But in this survey, they would not treat babies who are less than 27 weeks. So you see, the range of opinion from different countries is very different. If you look at the echocardiography, a majority of the French units would like to have clinical and echo criteria side by side, and that's the approach we like to promote as well. But about 1/3 of the centers would use only echo criteria. That means regardless of the baby's clinical status, if the duct is beyond a particular size, even if the baby is in room air, even if the baby is on CPAP room air, they would treat. And that's where the issue is. That would promote higher treatment exposure and might bias your clinical efficacy. So babies are already, not symptomatic because of that. So higher exposure rate is likely to happen in these centers which use echo criteria in isolation compared to using echo with clinical pictures. Now, the commonest echo parameter you would argue should be the size of the duct, if that's the only criteria you were using, but that's not the case. It's the left atria aorta ratio, which is used most commonly as compared to in 71% of a ductal size. And again, as I said, within these bullet points, there is no agreement that what's the criteria. Most people would use LA aorta ratio 1.4. But in this particular survey, there is a wide range, and even if the ductal size, again, there's a wide range. So essentially, and about half the units would say if they see a red color jet on color Doppler, that's the same as significant duct. So it's a good example of lack of consensus on the most basic assessments, and over time, it tends to feed into the fact that we have lack of consensus, we have uncertainty, and we can't even diagnose properly, and of course, it feeds into the management issues.
Sir, there are only 2 minutes left, sir.
Okay. So let me just go through in the next 2 minutes the meta-analysis. So this is, you see pooled results of RCTs of prophylaxis. We're talking about prophylaxis here. So this is, you can see, this is, one is the number of studies, 84 is the number of babies in that study. This is 2 studies, number of babies in those 2 studies. And you can see here, the only benefit for prophylaxis, ligation, indomethacin prophylaxis, ibuprofen prophylaxis, or indomethacin IV prophylaxis, IV or oral prophylaxis, or indomethacin versus ibuprofen prophylaxis. The only benefit you're achieving by prophylactic therapy is you're able to close the duct. That is all. There is no benefit in any other criteria, any other outcome, which actually is relevant to the baby. Okay, you're only able to close the duct. That's about it. Prophylaxis. So I'm not surprised that over 10 years, the rates of prophylaxis indomethacin in the US have gone down. This is ligation symptomatic, indomethacin IV symptomatic, indomethacin oral symptomatic. So symptomatic therapy. So pooled results of treatment of persistent significant PDA, which are symptomatic now. So again, the only benefit the baby achieves is you are able to close the duct. But any other benefit in terms of death, BPD, chronic lung disease, NEC, sepsis, IVH, you don't have any benefit. Now, this shows pooled results of RCTs, any treatment of PDA, medical or surgical prophylaxis, or all treatment prophylaxis trials. So 48 trials, more than 4,000 babies. Again, you can see the message is exactly the same. You have less ductal patency. That means you're able to close the duct more often, but in terms of death, BPD, death or BPD, NEC, sepsis, IVH, you don't see a difference. Now, let me just go to something which is more recent. So this is the issue here. When we talk about randomized controlled trials, you can see how many babies in the control arm got treatment. So I'm removing babies who in 50% of more controls were treated. So this first panel is including trials in which the exposure rate in controls was less than 50%. Again, the message is the same. The only benefit you achieve is closing the duct, but in all other parameters, there's not much benefit. Let's look at premature babies. Some of the trials in the past have been 30 weeker, 31, 32, 34 weekers. Let's look at more recent trials, all infants less than 29 weeks. Again, the benefit is only less patency of the duct, but no benefit in other outcomes. You look at age at treatment. As I mentioned, a lot of trials treated infants after 5 days of age, but look at treatment early treatment, the only benefit is ductal closure, but no other benefit in any other outcome. So this is the major slide. If you forget everything in my presentation today and remember this is talking about all NSAID trials together, 51 trials, 5,000 babies. Pooled results of RCTs of NSAID therapy for persistent PDA. These are the bars which represent the 95% CI, and the line at the midpoint is the estimate of pooled odds. Again, you can see here, if you combine all NSAID trials together for symptomatic PDA, the only benefit you achieve is persistent patency of the ductus arteriosus. You can close the duct, but all other parameters, and you can see for ROP, there's a bit of a downside as well. So the benefits you want to convey to the baby in terms of less BPD, less ROP, less MEC, those are missing. Okay, so the only benefit you're achieving is able to close the duct. So I would leave you with some questions rather than answers. Would you treat and want to close the duct? That's one. Or do you belong to a group where you say, I don't want to close any ducts? I think that's wrong. You need to be able to choose your population correctly. Whom are you going to treat? Are gestation age consideration, is birth weight a consideration for you? Whom are you going to treat? Which are the when would you treat? Day 1 of life, prophylactic, early, less than 5 days, or you want to wait for more than 7 days? Because as I said, in 26 to 31 weeker babies, 80% of the ducts might close on their own. Why would you treat? What are the benefits you want to achieve? You need to go beyond wanting ductal closure. You need to be aiming at beneficial outcomes to the baby. And again, how would you treat? Are drugs to use or just ligate surgically? And if you use the drugs, what are the drugs to use? And lastly, what is your exposure rate in your own unit? If you look at premature babies, go and do an audit and see how many babies in this group are you exposing? Are you like us, 14 to 18%, or are you like other units which 88 to 100%? So for people who are into research on this topic, very important last points from me: avoid using a single parameter, use a comprehensive echo staging system to decide, okay, which are the patients to enroll, so compare apples with apples, oranges with oranges, and also look at which is the population which is likely to benefit from treatment rather than simply treating all comers. So that is where I want to end. Thank you for your time and happy to take any questions.
Thank you so much, sir, for that wonderful lecture and simplifying the approach to PDA. Do we have any questions? So no questions from the audience. Thank you so much for being a part of this discussion. Thank you.
I think there's just one question. Sorry to interrupt. Dr. Monica.
Yeah, hi, Dr. Arvind and Dr. Monica. Just wanted to ask, for all these trials which you did in your unit, they are all IV paracetamol or you gave oral? So what's like where we don't have the IV availability, can oral be given with the same efficacy?
Yeah, so majority of our babies got oral paracetamol because what we mandate is if they're on trophic feeds, which is about 10 mils per kilo per day of EBM, I think we are happy to give them oral. So majority were oral, but an occasional baby might receive IV at the same dose. But oral is preferred for us, and our efficacy is comparable. Although, as I said, majority of babies were given oral.
That's all, sir. Thank you so much.
Thank you.
Thank you. Moving on, we have our next talk on BPD recent advances, again from another international faculty, Dr. Ambala Banan. He is the professor of pediatrics and director of the Division of Neonatology and the Division of Neonatal Research at the University of Alabama in Birmingham. He obtained his MBBS from JIPMA and MD Pediatrics from PGI Chandigarh with pediatric residency and neonatology from UAB. He is a founder and director of the Translational Research in Normal and Disorder Development, a program at UAB. Welcome, sir. Can you hear us, sir?
Yeah, I can. Can you all hear me?
Yes, sir, we can see and hear you clearly, sir. Thank you so much, sir, for being a part of the discussion. We welcome you.
Thank you. Let me share my screen. Good morning or the good afternoon for you. Let's move on to the next slide. So this is the overview of the presentation. First, BPD is not one disease. There are multiple endotypes. We want to show you how to predict BPD, how we should approach BPD, how we should prevent or treat BPD, and the future of BPD. The definitions of BPD have changed over time. What we defined as BPD in the 1980s, the 1990s, and currently are all very different. The patient populations have changed over time. The clinical practices have changed over time. So BPD, when it was first defined in 1967, is not the BPD that we see currently. BPD is not one disease. So this is the clinical operational definition based on oxygen supplementation or respiratory support and doesn't specify pathophysiology. It's a bit like saying anybody who gets chemotherapy has cancer, or anybody who gets antibiotics has sepsis. Every baby who gets oxygen doesn't have BPD. So variation in BPD severity, again, mild, moderate, or severe. There are different grades, 1, 2, or 3. And again, variation in pathophysiology, the so-called classic BPD or the new BPD. So infants with BPD exist along a continuum with varying combinations of clinical or pathologic features. So we can see some infants who have a very parenchymal type of phenotype. So this is one of the infants I took care of recently. It's a 3-month-old X25-week, 700 grams at birth with ureaplasma infection at birth. You can see the patchy infiltrates in the lung. This is a different infant who is also 3 months old, X24-week, 600 grams at birth, who had suprasystemic pulmonary hypertension. You can see the very large heart with the right ventricular pressures of more than 80 and a B-type natriuretic peptide of more than 3000. So this is the so-called vascular phenotype. We also have an airway phenotype. This is a 3-month-old X22-week, 400 grams at birth infant who had frequent failed extubations and left-sided atelectasis, and a 3D reconstruction of his airways by CT showed that there was a severe narrowing of the left mainstem bronchus. So how do we do disease endotyping BPD? So this is one of the recent advances. So you can evaluate the lung parenchymal structure by MRI. There are multiple references on that. For echocardiography, we do screening for pulmonary hypertension at monthly intervals, starting at about 1 month of age. And we find it in about 1 in 6 extremely preterm infants. And we do this monthly if they are on respiratory support. What about airway phenotype? We can do lung mechanics. Now we have started screening infants, even the ones who are not on a ventilator, using the TremorFlow, which is an impulse oscillometric device. So there are different ways you can do to endotype BPD. The other important thing is it used to be thought it was just an immature lung, which we are beating up with mechanical ventilation or with oxygen. But now we know it is more of a disease network. We have a lot of genomic influences. There are environmental influences such as fluid overload, impaired nutrition, infection, hyperoxia, which cause multiple intermediate phenotypes, and then inhibition of lung development and lung vascular development, which results in long-term impairment of lung function. So it's not just a simple inhibition of lung development or simple lung injury, but there are multiple complex factors that go into BPD. So heterogeneity exists in the clinical phenotype, the genetic basis, and the pathophysiology of BPD. And BPD is not one disease. Every normal lung is similar, but every abnormal lung is abnormal in its own way. So every infant with BPD is very different. So how early can we predict which infants will develop BPD? So moving on to the next recent advance, we have ways of diagnosing BPD even as early as the first postnatal day. So this is one of the studies which we did recently, where we looked at microRNA in the tracheal aspirates on day 1. And we identified 40 different microRNAs in the discovery cohort that you see on the left side. And we validated 6 of them in a different cohort of infants. And the top signal was microRNA 876-3P, which had an area under the curve of 0.92. So it's a very good predictor. So we see that you can use different biomarkers on day 1 to predict BPD. And we also showed that this is possibly causally involved in the pathogenesis of BPD, because if you use a mimic for this microRNA, you're able to prevent hyperoxia-induced BPD in mice. We have also used bioenergetics of umbilical cord endothelial cells. So this is using a seahorse bioflux analyzer. So if you collect endothelial cells at the time of birth, and if you look at their bioenergetics, if they have a high oxygen consumption, then it means that they are less likely to develop BPD. And this also had a very high area under the curve of almost 0.9. So, and the figure that you see below this decision tree indicates that the most important predictor was the maximal oxygen consumption of more than or equal to 200, which was actually more important than the gestational age or birth weight. So just looking at the cellular bioenergetics gives you an idea of the likelihood of later BPD. The next recent advance is a greater understanding of the long-term impact of BPD. So if you look at lung function over time, normally you're born and then your lung mechanics improve until about age of 25, and then after that it's all downhill. So it's better to be young than older. But what happens if these babies are born early and they have BPD? So the trajectory of lung development is irreversibly altered. So they have a lower peak FEV1 and then a more rapid or slower decline based on the other environmental exposures, not just smoking, but maybe environmental pollution as well. We know that there is pulmonary hypertension and permanent structural impairment of their lungs. So Karagos had actually done cardiac cath in young adults who were born very low birth weight, and found that about 45% of them had either borderline or overt pulmonary hypertension. And if you do lung mechanics, you can also see that there is abnormal FEV1 and FEF in them as young adults. So this is a permanent impairment of lung function and pulmonary hypertension. It's not that once they grow up, their lungs become normal. So the implications are that there is marked variation in respiratory outcome, and even the infants without a BPD diagnosis may have impaired lung development and long-term abnormalities on lung function. And children born very preterm may have abnormal lung function, increased airway reactivity, and abnormal airways such as subglottic stenosis, airway malacia much later. So how should we approach BPD? Some of the potentially better practices, obviously, antenatal steroids, antimicrobial therapy to the mother if she has chorioamnionitis, postnatally gentle management of the ventilator, CPAP, and gas exchange, surfactant therapy with or without budesonide, fluid and nutrition management, and multiple drugs, of which probably only vitamin A and caffeine are most useful. So antenatal steroids, as you all know, reduce RDS, but they really don't reduce BPD significantly. And that is because you're basically causing a left shift. So you're improving survival, but not necessarily improving BPD at that gestational age. So if you look at this, for example, this is the antenatal steroid effect by gestational age. You reduce mortality significantly starting from about 23 weeks all the way up to 34 weeks. So it's not like you have a certain specific gestational age at which effect starts and then another gestational age at which it stops. You have a pretty uniform effect. But then if you look at BPD, you see a small improvement only at 23, 24 weeks. Overall, there's no effect. And that's because the infants who are really small, they tend to survive without with BPD, whereas the larger infants survive without BPD. Antimicrobial therapy has been shown to reduce oxygen use at 28 days, but really not much effect on the 36-week BPD outcome. Recent large trials with current practice indicate that early stabilization on CPAP with selective use of surfactant is better. So don't go about intubating all these micropremies. Try them on CPAP first and give them surfactant only if they need to be intubated. Oxygen saturation targets, there have been multiple studies, the support, CORT, BOOST2, and so forth. So we currently use a saturation target limit of 91 to 95 rather than 85 to 89. The 85 to 89 reduces ROP, but it doesn't reduce BPD. You really want to reduce mortality, and the lower saturation target increases mortality. So therefore, we have moved to a 91 to 95% target range, and most centers currently use that through the at least the initial hospital course. So early CPAP, surfactant if the infant needs intubation, target saturation 91 to 95, target CO2 of 45 to 55, avoiding more than 60 in the first week. And after the first week, you can go up much higher, even up to 70 or higher, as long as the pH is more than 7.2. Ventilator supported 36 weeks is 1% the minimal ventilation, that is if you target higher CO2, and much higher, 16% if you target less than 48. Therefore, we try to keep your target CO2 much higher. And usually we get transcutaneous CO2 in most of our infants. There is no strong evidence supporting elective high-frequency ventilation or volume-targeted ventilation. There is some literature supporting their use, but there are no large randomized trials supporting volume-targeted ventilation, and there are risks as well. Surfactant with budesonide, as I mentioned, is a potential intervention. We are currently doing a large randomized trial, but currently I would consider this experimental. Fluid electrolyte management, we all know that restricted fluid intake reduces PDA, NEC, and trends to reduce BPD, IVH, and death. You all listened to the previous talk on PDA, but it's probably better to prevent a PDA by restricting fluids earlier rather than trying to manage it after it happens. So restricted fluid intake is important. Vitamin A is one intervention that's been shown to reduce BPD, BPD or death in extremely preterm infants from 62 to 55%. We give it intramuscularly, but if you give a higher dose orally or intraorally, it's probably somewhat effective as well. So caffeine in the CAP trial was shown to reduce BPD without any change in mortality. But in that study, they restricted the use of open-label methylxanthines. Therefore, you don't want to restrict the use of methylxanthines. You want to use it liberally. Higher doses of caffeine may be better. At our center, we go up to 20 milligram per kilogram per day. And we have shown that it reduces apnea and potentially reduces intermittent hypoxemia during the hospital stay. And some centers use it from soon after birth. Other therapies with varying amounts of evidence, postnatal steroids, diuretics, bronchodilators, inhaled nitric oxide, antimicrobials, I put a question mark because there is very little evidence for their use. This little hard data randomized trials are needed, and we usually direct treatment towards what we think is major pathophysiology, but like I said, there's not much evidence for their use. For steroids, however, there is use. I mean, there's a lot of data, but again, it's somewhat controversial because there are short-term risks as well as long-term risks. There are multiple alternative strategies which have been tried: lower dose DEX, lower dose hydrocortisone, inhaled steroids. There are some larger studies which have been done and which are being done. We have recently completed a large trial of hydrocortisone, but overall, except for dexamethasone, the alternatives don't seem to work as well. At least with moderately early or delayed therapy of Dexamethasone, we do see some effects. You can see with moderately early the relative risk of 0.7. With delayed therapy, it's 0.91. So if you're going to use them, it's better to use a bit earlier. So summary of BPD management: prevention is better. Use oxygen, initial fluid restriction, optimize nutrition. We do see some short-term benefits with bronchodilators and diuretics, but there's really no data on long-term effects, so we don't use it routinely. Avoid steroids except in short courses for extubation or if the infant is critically ill with respiratory failure. So what does the future hold? In the last few minutes, I'll talk about what we will be doing in the next decade. So one is NAVA, or neurally adjusted ventilatory assist. So this uses the diaphragmatic signal for triggering ventilation. We have been using this for many years, and it's really useful for the chronic BPD infants. It really helps ventilate them better without needing sedation. However, as I mentioned, we really need large randomized trials. The next recent advance or future advance is the server control of oxygen or automated oxygen control. This has become more common in Europe, but it's not really made inroads in other continents, in which the saturation is continuously input into the computer, which adjusts the FiO2. So you don't need to stand by the ventilator or the oxygen blender and keep adjusting your oxygen manually. It's done automatically. And it's been shown that the duration of mechanical ventilation is potentially shorter. Really interesting is the artificial placenta. So this has been tried in lambs. So this is an extrauterine system to physiologically support the extreme preterm infant. Currently, it works very well in the lamb. So you can actually see this lamb, which was maintained for 4 weeks ex utero, and you can see it's really grown. With normal growth, lung maturation, brain growth, maturation. But I think it's still going to take some time before we start doing it in babies. There's a lot of risk involved with these approaches too. There are other things which are closer to the horizon. For example, single dose of this antibody nirsevimab for prevention of RSV. We know that 50% of these babies who get RSV will end up back in the hospital. So a single intramuscular injection has been shown to reduce RSV respiratory tract infection by 70% and almost an 80% reduction in RSV hospitalization. You must all have heard about the exosomes and stem cell therapy. This is one of the hot topics in literature these days. And I think there's a lot to be said about the potential for this, for everything from brain injury to ROP to NEC to BPD. But I think we are still a few years away from using it clinically. There are still a lot of unanswered questions, such as the source of exosomes, the duration that you need to give it, as well as other characteristics that you need to be monitoring for potential adverse effects as well. And finally, preventing preterm birth. If somebody manages to prevent preterm birth, some of us will be out of a job, but I think that's also highly unlikely. We know that there are multiple etiologies for preterm birth, both iatrogenic as well as spontaneous preterm birth. But we are getting a better understanding of the mechanisms of preterm birth and also the preterm birth risk factors. And now we are able to start intervening and being able to reduce the risk of preterm birth. There are some genetic factors which we can also identify and get an idea of the amount of risk. So this is the final slide. BPD is a very complex multifactorial disorder. The operational definition saying that somebody has BPD just because they are being given oxygen doesn't capture the phenotypic and genetic heterogeneity underlying the pathogenesis. All normal lungs are similar, but every abnormal lung is abnormal in its own way. A better understanding of an individual's genotype, phenotype, and omic biomarkers, like I was mentioning about cellular bioenergetics, microRNA, and so forth, may suggest potential targeted personalized interventions suitable for a given infant. Reduction of BPD is possible, but first we need to implement proven interventions, caffeine, vitamin A, antenatal steroids, gentle ventilation, use CPAP as much as possible, don't intubate unnecessarily, limited fluid intake and so forth. We also need more evidence on common interventions. We need randomized trials on diuretics, bronchodilators, azithromycin, PDA management, and so forth. We also need to analyze center practices on long-term outcomes. It's not just short-term outcome of whatever we call as BPD, but also the long-term lung health of these infants as they grow into young adults. And most importantly, we need careful QI processes and monitoring of outcomes to ensure that outcomes are not worse after we initiate an intervention. We don't want to make things worse by what we think is potentially better practice. We want to make sure that what we are doing improves outcome. Okay, thank you. I'm ready for any questions.
Any questions from the audience?
Yeah, Dr. Ambal, I'm Dr. Monica. Thank you for a very excellent talk. Just wanted to ask you, you talked about caffeine 20 mg, you're giving irrespective of gestation to every baby. This is, you're talking about loading dose or
so for caffeine, we start at about 10 milligram per kilogram, but then if the infant continues to have apnea and bradycardia, which is severe, despite CPAP, then we would go up to 20. So it's not routinely, it's as needed.
You went as if it is like a routine practice, so that's why I wanted to clarify. Thank you.
So there's another question.
Hello. Thank you for the excellent talk, sir. Sir, just wanted to ask whether vitamin A you're giving in a unit intramuscular or oral?
We are currently giving it intramuscular because we have the preparation, but it's an expensive drug and not many centers have it. If you're going to give it orally, the dose may need to be modified. There are several studies, some which have come out of Australia recently, also looking at the optimal dosing of enteral vitamin A. Most centers, if you're going to give it intramuscular, will give 5,000 units 3 times a week for the first 4 weeks. If you're going to give enteral vitamin A, the dose is usually about between 2,000 or 3,000 international units daily for the first 28 days. There's still a lot of research that's being done on enteral vitamin A, and I think it varies to some extent based on the center practices.
Thanks.
Hello, thank you for an excellent talk. I have one question regarding fluid restriction. So when we mean fluid restriction, how early, to what extent, and is it in general for all the babies for extreme low birth weight, or do we recognize those who are going to go for PPD and restrict fluids?
So good question. So it's important to prevent. So it's important to start right from birth. And when I say fluid restriction, how do we know that we are adequately fluid restricting? We try to keep the serum sodium in the mid 140s, that is around 145. If our sodium drops below 140, then I know that the infant is probably getting too much fluid. The other thing is we look at daily weight, and we try to make sure that they're losing about a total of about 15% from birth weight. So we try to make sure that they're losing sufficient weight, that they're not stabilizing the weight in the first few days. So generally, you know that they lose a lot of extracellular fluid and their weight drops. If the weight is staying the same in the first few days, then we know that they're probably getting too much fluid. If their sodium is below 140, we know that they are getting too much fluid. So generally, we want to make sure that we are not giving too much fluid right from day one. And we start liberalizing fluids after about 2 weeks of age. And even after 2 weeks of age, generally my practice is to restrict them to 140 cc per kilo per day or so, at least until about say day 21 or so, until we are sure that they're out of the risk period for developing severe lung disease. Because once they have severe lung disease, it's hard to go back to an earlier stage of lung disease.
Sir, this is the last question. This is Dr. Kamal. Sir, we talked about ventilation and then the CPAP, the gentle ventilation. We are talking about nowadays the laser technique and the mist techniques.
Yes.
So what's your take on that, sir? Decreasing the BP incidence, because we discussed this in the morning also.
Yeah, I think that's a good question. We want to minimize the amount of volume trauma or mechanical ventilation induced trauma. So ideally, if you can give surfactant without the need for intubation, that would be better, whether you use a technique like LISA or MIST, or now aerosolized surfactant delivery is being developed. I think the problem is right now, there are a few studies which suggest it might be better, but many experts still believe we need more data. I think LISA and MIST are, in my experience, I think it's better for the larger preterm infant. For the very small preterm infant, sometimes we have difficulty keep maintaining them on those techniques. I think it's highly promising, but I think we need some more data. And it also is somewhat user dependent, and people need to be trained in appropriate delivery of those methods.
Thank you so much, sir. That's the end of the questions. We're very glad to have you as a part of the discussion. And thank you so much, sir.
Thank you all. It's been great meeting you all virtually.
Thank you, sir.
Thank you.
We'll welcome our next speaker, Dr. Roger Roy, who is a consultant neonatologist in Lauders Hospital, Kochi. He specialized in preterm care and perinatal asphyxia. What do you say?
Thank you. At the outset, I would like to thank our organizers for giving me an opportunity to speak in this particular conference. Though myself and Abravan sir is from the same alumni, just like Ishant Sharma coming to bat after Virat Kohli getting out. So unfortunately, I've made up my presentation for the postgraduates, but I could hardly see any postgraduates over here. All the senior people are here. So please bear with me for this. Slides, please. Yeah. And this is my highlights of my presentation for the day. So I'll be talking a little bit of history, some definitions and examinations, imaging, treatment, and evidence-based medicine on the developmental dysplasia of the hip. Now, it's always better to know the history of any particular disease before starting learning about this particular disease. So when I went back and looked up this history, I was shocked to see that the first description of this particular developmental dysplasia of hip was given by none other than Hippocrates. And even the British Museum was supposed to have a specimen of a dysplastic hip from the Neolithic times. And the Dupuytren was the first person who was written down about the congenital dislocation of the hip. And the two well-known pediatricians, one from Italy, Dr. Ottolani, and one from England, Dr. Barlow, we are indebted to them for the tremendous work which they have done in this field of hip dysplasia. A little bit of about the growth as well as the development. Embryologically, the acetabulum, the femoral head, all develop from the same primitive mesenchymal cells. A cleft developed in these particular cells by around 7th week, and that defines both structures. By 11th week, the hip joint is fully formed. And acetabulum growth continues throughout the intrauterine life with the development of the labrum. And it's supposed that we all know that hip joint is a ball and a socket joint. And for the proper formation of this particular socket, this ball, that is a femoral head, has to be there within this particular socket. Along with this, other requirement things are the appositional growth of the cartilages, the secondary ossification centers, and the development of the bones in and around the hip. If these development does not happen in a proper way due to any factors, that can result in developmental dysplasia of the hip. Now, as such, this DDH encompasses actually a spectrum of diseases, not just one particular entity, which ranges from dysplasia to dislocation. So what exactly is dysplasia means? So dysplasia is nothing but an abnormal morphology of an acetabulum and or femoral head secondary to aberrant development of the joint. Unstable hip is the femoral head is reduced within the acetabulum at rest, but has the ability to move in and move out of the acetabulum when it is subjected to a stress. A dislocatable hip is the one that is a posteriorly applied force to the hip joint. Position in adduction leads to complete displacement of the femoral head from the margins of acetabulum. Now, what exactly is subluxation? Subluxation is a femoral head is partially displaced from the acetabulum with some degree of contact still remains between the femoral head and the acetabulum. If there is a complete loss of contact between the femoral head and acetabulum, that is called dislocation, which may or may not be reducible. Now, these are the pictures which shows this. You can see here the normal socket with the deep acetabulum, and that side we can see a shallow acetabulum, and this is picture showing subluxation, low dislocation, as well as the high dislocation. Now, dislocations are also further classified into three. The most common type is the typical one, or the idiopathic variety. It occurs in otherwise healthy infants, may occur in the prenatal or a postnatal period, and the direction of dislocation is postero-superior in relation to the acetabulum. Teratologic variety occurs in association with arthrogryposis or a congenital syndromes like this. It always occurs prenatally. They are often high dislocations and they are fixed. Neuromuscular varieties occurs in association with a neuromuscular disorders like cerebral palsy or a meningomyelocele. Generally presents later in the childhood. It is secondary to the abnormal stress in and around the joints, or maybe because of abnormal tendon structures over there. Now, no wonder this topic has been chosen for this particular conference, because the most common orthopedic disorder in the newborn, the incidence of DDH is 1 per 100 newborns. An incidence of dislocation is 11 per 1,000 infants. And it's more common in females. In the ratio of 6:1, Native Americans have slightly more higher incidence than other racial groups. Now, to remember the risk factors, I put, most of the textbooks says 4F, I put 5F. First thing is a firstborn. Why? Because the primate has slightly rigid, more rigid pelvis and the uterine structures than a multi, which causes an extra stress on the hip joint. Female babies, we all know, it's mainly because of the effect of the maternal hormones like estrogens and relaxants on the hip and the surrounding joints, which actually causes much of relaxation of the joint. Feet first, it's a breech. Whatever be the mode of delivery, the breech babies are more prone for having DDH than a cephalic presentation. In fact, the frank breech has more high incidence of DDH than other forms. The family history has a strong genetic implication to it. The first degree relative, if it is affected, there is around 10 to 12% risk of DDH. And in the monozygotic twin, the one twin is affected, 40% risk is there. And dizygotic twin, something around 5 to 10% risk is there. Anything that causes crowding inside the uterus will actually result in DDH. So it may be secondary to oligohydramnios, or which because of macrosomia, those things can result in development dysplasia of the hip. And the swaddling, if it's not done in the proper manner, can result in DDH. That's why the Native Americans are more prone. We all know it's a method of reducing the pain. It's done in the hip, in the total extension and adduction. It can result in DDH. Now, this always suspect DDH also with associated with other packaging deformities like congenital muscular torticollis, metatarsus adductus, and congenital knee disc. So if you have these, or if you have a baby with bilateral cleft foot or any form of this, always suspect this may be associated with DDH also. Now, conventionally, the left hip is involved more than any other hip. 60% involvement is there. Why? Because the left occipital anterior is the most common position. And because of this, the left hip of the baby will be in close contact with the maternal lumbosacral spine, which actually leads to excessive stress on the hip. That's why the left hip is more commonly involved. In fact, after the left hip, the second incidence is high for the bilateral, then comes for the right hip. So the disease itself is a dynamic process. Not all cases may not be present at birth. And even at small, for girls, they tend to have a self-limited instability can be found in newborn girls, and hip instability may improve or may deteriorate with the growth. It's a continuous process. So initial instability is a pathophysiology, whatever be the reasons. can lead to dysplasia of the acetabulum, typically in the anterior or anterolateral acetabulum, which may result in subluxation or a dislocation. And repetitive subluxations can lead to thickening of articular cartilage, or it's called the limbus. Now, if you don't detect the dislocation, or if it's not treated in the proper manner, these changes can occur in and around the hip joint, which can result in irreducibility of this particular joint. Now, based on the mode of clinical examination, we have classified DDH again into subluxable one, that is a Barlow suggestive, dislocatable one, that's a Barlow positive, and dislocated ones is Otolany positive early, when reducible, Otolany negative late, when late. Now, how do you detect it? Obviously, you don't want to miss it. The most important crux is a physical examination. This again can be divided into based on age group, less than 3 months to 1 year, and more than 1 year if you miss it. What is it for the less than 3 months? The most important thing, so two important tests which you all know, that's the Barlow test and the Otolany test. Now, in Barlow test, the manner we try to subluxate or dislocate unstable hip from acetabulum with gentle hip adduction. Since I have a very poor memory, I use this mnemonic. If you go to bar, you will get dislocated. And the hip gets dislocated when it is adducted. There are 2 Ds for adduction. So hip gets dislocated when it is adducted. And Otolany manner is a manner tries to reduce a subluxated or a dislocated femoral head back into acetabulum with gentle hip abduction. If you go to ortho, if you are dislocated, they will relocate you. So remember like that. So, and positive Otolany sign is the most reliable finding to detect dysplasia as per certain studies. Now, what exactly is the procedure? First of all, you explain the procedure to the parents, because this may cause a little bit of pain to the baby, and maybe may start crying after this, and parents may become cranky. So we should follow all the basic sterile precautions for as for any examinations. Calm the newborn first, make him lie supine on an examination table. You perform only one leg at a time and stabilize the hip. For stabilizing hip, there are 2 manners. One part we can do is like the opposite hand, the thumb and the index finger or the middle finger are placed on the anterior iliac crest simultaneously, or you can keep the opposite limb in the same manner as the examining hip. Okay, so and the finger post, and for the examining limb, what you do is like, for the purpose of doing this Barlow as well as Otolany, what you do is like you use your thumb, you keep it over the medial aspect of the thigh. The index finger and the middle finger, middle finger are kept over the greater trochanter. And you can see in this picture, the hip is flexed to 90 degrees and knees are also flexed. The opposite hip is held in the same manner as the examining hip so as to stabilize the hip. Now, when you're doing a Barlow, as I mentioned earlier, we are trying to dislocate or subluxate a hip, see whether by adduction to see whether hip is dislocatable. So by doing adduction, you are giving a posteriorly directed pressure along the axis of femur, and you're feeling for the clunk on the index finger and the middle finger. Remember, it's not a click, it's a clunk. The clicks are because of the iliotibial bands which gets tapped over the greater trochanter. You feel for the clunk, even the clunk can be visible. The Otolany sign, the fingers are held in the same manner as per the Barlow, but in this manner, what you're trying to do is like, while abduction, you're giving an anteriorly directed pressure with the help of your index finger and the middle finger kept over the greater trochanter, and you're feeling for a clunk on the thumb that is kept on the medial aspect of the thigh. In this way, you can feel whether the hip is relocating back into the acetabulum. This is how you do a Barlow as well as Otolany. Barlow as well as Otolany. I had a video, I think they have given the wrong presentation to me. And detection of a dislocated hip also can be done because of the limitation of hip abduction is one important sign. Adduction of 30 degrees and abduction of 75 degrees should be possible in most newborns. And remember, we can also look for asymmetric thigh folds and gluteal folds and the Galassi sign. These are only present in cases of unilateral hip dislocation, not be present in bilateral hip dislocations. This is what is known as asymmetric thigh folds. You can see them scrolled over here. And what is meant by the Galeazzi sign is you make the baby lie on a supine on examining table and hip flex the hip to 90 degrees at both hip as well as the knee and see whether there is any difference in the height between the two sides. If there is a difference in the height, that side will have a dislocation. That is what is known as a Galeazzi sign. And what if you miss in the newborn period, when your child comes, you are 3 months or 4 months. Now, after 3 months of age, the limitation of hip abduction is the most reliable sign after 12 weeks. Remember, Barlow and Ottolani is sensitive only up to 12 weeks or 3 months. So abduction restriction to less than 60 degree, when tested at 90 degree of hip flexion is the most reliable sign. Leg length discrepancy also can be seen. So you can see here the limitation of hip abduction when the hip is flexed to 90 degrees. Now, what if you miss even then? Child comes around 1.5 years of age, and then what we can do, see whether there is an evidence of DDH, look for any pelvic obliquity, look for any excessive lumbar lordosis, occurs in secondary to hip contractures, Trendelenburg gait, secondary to abductor insufficiency, the toe walking attempt to compensate for the relative shortening of the affected side. For all these things are there, always look out for developmental dysplasia of the hip. Now, this is one test which is done to know whether it's a bilateral dislocations is there or not. So you place the fingers over here and you draw a line from the long finger placed over the greater trochanter and index finger over the anterior iliac, superior iliac spine. And then this straight line should point towards the umbilicus. Now, if the hip is dislocated, the line will point halfway between the umbilicus and the pubis. And this one thing is used to detect bilateral dislocation because asymmetric typhoons and Galeazzi will be only positive in cases of unilateral hip dislocations. Now, what are the indications for ultrasonogram? Now, if you have a positive physical examination, that is one thing. As per the AAP, ultrasound should be done at 6 weeks in patients who have high risk of despite normal examination, that is family history of breech presentation at birth, and monitoring of reduction during Pavlik harness treatment. Most studies shows, however, it's not cost effective for routine screening and is only recommended as an adjunct to the clinical evaluation rather than as an independent screening tool. And you look for what the radiograph look for is a static as well as a dynamic. Even though we can do before 6 weeks, say if you have a doubt in your mind that physical examination will show, some doubt is you can do it 4 weeks also, but at this point of time, you may pick up some unstable hips, which might improve later. So it may create a havoc in the patient's mind. So ideal time will be something around 6 weeks of life. Now, if you want to see the image, obviously they try to confuse with a lot of values. Remember, for your purpose, only 2 things. By 2 angles, they mention alpha and the beta. Alpha has to be more than 60 and beta has to be less than 55. People who are interested can go and read what is known as a graph classification, on the basis of which the hip dysplasia has been classified. Then, what is the imaging modality of choice after 4 months of age? Is nothing but APV of the pelvis. That is the imaging modality of choice. And there are a lot of lines to be discussed on this because lack of time, I'm not going to detail. It is freely available. You can go and see. And these are the lines which the orthopedicians and the radiologists look for if the child comes later. Now, what about the treatment? Treatment always depends upon the age and presentation. For less than 6 months with reducible hip, the treatment is a Pavlik harness. It is a dynamic orthos. That what does it mean is that it allows the baby to move the limbs freely. So that in that way, the baby's hip movement is becoming better, helps in proper modulation of the hip, the femoral head, and the acetabular. Apply immediately on diagnosis. The length of treatment depends upon the age of presentation. Keep on monitoring the progress with the help of ultrasonography. And effective in 100% of stable hips, 90% of dislocatable hips, that is the Barlow positive cases, 60 to 90% of Ottolani positive cases, but only in 40% of irreducible dislocations. Now, remember, contrary to the popular belief, triple diaper or double diaper is not a recommended treatment for the developmental dysplasia.
5 minutes left.
Yeah. Treatment of a dislocated hip is by the Pavlik harness can be still be tried. Abandoned is there is no improvement within the 4 weeks of split. The next important treatment option will be a close reduction and the hip spica. Most of the times less than 6 months this is the only modality which is required. But if this is also not possible, do an arthrogram and see what exactly is causing hindrance to the reduction. Accordingly, you may require open reduction and the spike. Now, coming to the last part, the recommendations to make you more confused. Now, all infants require a physical exam, screening examinations at birth. Successful screening requires repetitive screening till walking age. As per the US Preventive Task Force, there is insufficient evidence to recommend any routine screening, including physical examination, because a no screening program has ever proven to eliminate late development or late presentation of DDH, because even in the best of the hands, DDH can be missed with the physical screening. Repetitive examination is imperative in 2 weeks with equivocal findings and mild instability, and keep on screening till walking age. And moderate evidence supports performing an imaging study before 6 months of age with infants with 1 or more risk factors, as I mentioned earlier. Little evidence supports the practitioner might obtain ultrasonography in infants less than 6 weeks of age with a positive instability examination finding that is on Barlow and Ortolani to guide the decision regarding the brace treatment. Limited evidence supports the use of an APV of pelvis instead of ultrasonography in children aged more than 4 months. And limited evidence supports observation without brace for infants with clinically stable hip, even though there are morphological abnormalities on ultrasonography. Some evidence supports immediate brace treatment for hips with positive instability findings on physical examination. When you have a positive Ortolani and a Barlow, and it persists beyond the usual age of spontaneous resolution, that is around 2 weeks of life, one should refer them to the orthopedician for further interventions. Even if the Barlow and Ortolani was positive initially, age-appropriate imaging is still warranted. And this is my take-home message, and this can be the patient later. I'm very sure your people are all in this particular state and can all get up for the next interesting session.
Thank you, sir. Due to time constraints, we won't be taking any Q&A now. So we'll be taking the questions at the end of this session. We'll move on to our next speaker.
So we have our next speaker, Dr. Seema.
Yeah.
She's there.
Yeah.
Hello, ma'am. We welcome you. Dr. Seema, she is the Director Professor of Pediatrics in charge of Division of Genetic and Metabolism from MANC Delhi. We welcome you, ma'am.
Yeah, so I think Dr. Madhulika would start.
Good afternoon, everybody. Thank you for inviting me to moderate this session. I am really happy to introduce Dr. Seema Kapoor, who is a great friend and a very dear colleague. And she has done pioneering work in the area of newborn screening and inborn errors of metabolism. And I would call her as a champion from India in this area. So welcome, Seema. Please begin with your talk on case-based approach to inborn errors of metabolism.
Thank you so much, ma'am, for the wonderful introduction. As a friend of yours, I would just start with my acknowledgements to everybody in the field and the program for Delhi, which is called Mission Neve. For all the neonatologists, it's Neonatal Early Evaluation Vision. And for all of us, it's Strong Foundation, Great Nation. So here I'm just going to dwell on how do we look at IEMs? How do we understand what is a small molecule, what is an intermediate molecule, and what is a large molecule? And this I would take through by addressing certain cases. So let's go by the first case. This is a typical case of a 4-day-old male newborn who develops feeding difficulties, gets admitted in the nursery afterwards, after going home and becomes hypothermic. This child is irritable and mottled. His antefontanelle is bulging. What is exactly seen is a boxing convulsion, which we know they're all multifocal clonic or subtle seizures. So if you're having alternate tight seizures, probably it's a boxing convulsion, after which when IV glucose is given, almost all parameters for sepsis are normal, glucose is normal, pH is normal, electrolytes are normal, ammonia is base 80, but urine shows ketones. Now, that's the most important message here, that in every newborn nursery, it's very important to look at ketonuria. So what was the clinical clue in this case? This was a typical encephalopathic presentation with raised intracranial pressure. The C's were typically boxing in pattern. Somebody who could have managed to do an EEG, most of us can't, could show this typical comb-like rhythm, which is practically impossible when a neonate comes to you scissoring or in encephalopathy, and you are actually able to pick up this abnormality. But what was most important is you did the primary investigations. The first of blood gases, which showed primary metabolic acidosis and secondary respiratory alkalosis. The anion gap, which is very, very important for all of us to understand as a very easy marker, because all of us have access to sodium, potassium, bicarb, and almost some of us to chloride as well. Now, establishing ammonia, here in this case, which was normal, the glucose was normal. So there was no hypoglycemia, and the ketones were positive. I would here like to bring your attention to a very important point, that in newborns, the ketones are 3-hydroxybutyrate, but while the ketosticks actually checks acetoacetate. So in a newborn metabolic defect, acetoacetate only comes into view once the 3-hydroxybutyrate pathway is saturated. So if you have ketones, probably either you are dealing with a neonatal diabetes, which is very, very rare, or you are dealing with an IEM. So it's important that I think everybody who has access to ketones, and if the ketones are positive, if there are convulsions which are not looking at the typical multiple seizures, you would think that probably you are dealing with an inborn error of metabolism. So what is GLAC? GLAC is glucose, electrolytes, lactate, ammonia, and ketones. And for the anion gap, you require sodium, chloride, bicarbonate. Please mute yourself, those who are on mute, because this is a virtual meeting, and I'm sure I'm not able to give my best. Now, very important is we have the KISS principle. That is, keep it simple, stupid. If you have evidences of sepsis, don't think of an IEM, but understand that almost all babies with organic acidemia have metabolites which suppress the bone marrow, causing neutropenia, thrombocytopenia, specifically the propionic and methyl malonic acidemia group. And therefore, just because you have sepsis, don't think you cannot have an inborn error of metabolism. So how to basically check the ammonias with so many different values? How do I actually go about? So it's very important to look at the units which are used and a conversion in which 1 microgram is equal to 20.7 micromoles per liter. Very, very important that don't start searching for labs after taking the specimen, but send the patient whose ammonia has to be sent first to the lab and then only to the patient, so that you do not give rise to an artifactual ammonia increase. Yes, we are all used to using arterial lines, so lactate is not as challenging as ammonia, but it's very important to know what figures you're using in milligrams per deciliter and what's the conversion. So believe me now, both of these tests are available as point of care tests, and you can do them at bedside in almost any laboratory without analytical issues. It's very important to repeat these tests before you go ahead and think of a metabolic error. What are the further investigations, and what was this case? Obviously, baby who does not have any other abnormality but just shows ketones has something wrong with his branch chain amino acids, which give rise to these keto acids, which are alpha hydroxy isovalerate and alpha ketoglutarate. So something is wrong with the branch chain metabolism, that is leucine, isoleucine, and the commonest disorder of this kind obviously is BHKD or maple syrup urine disease. So what message did you get? The technique which was used based on very simple tests called GLAC went on to use a technique which is called tandem mass spectrometry, which in biochemical genetics is called LC-MS-MS. So because you use 2 mass spectrometers in tandem with each other, these are tandem mass spectrometry. Now, why is this a small molecule? Why is it presenting in the neonatal period? It's a small molecule because it has crossed the blood-brain barrier, and therefore you have encephalopathy. It is a small molecule in which you can diffuse the mass spec and will give rise to a mass to charge ratio. It is a small molecule because all what you need is a good CRRT hemodialysis, and if not, a peritoneal dialysis. And now with so many companies allowed to import duty-free diets and indigenous diets being prepared, you can actually just diagnose them and give them a complete, nearly modifiable course. And they also do not present in utero because the mother's placenta is acting as a dialyzer. So this is when we use the first choice as tandem mass spectrometry. Now, what substance to use? You could use dried blood spots, all of you know about it. You could use plasma, you could use urine, you could use bile, you could use amniotic fluid, and even the aqueous humor. So that's very, very important, as interesting as technology has moved from the lab to the bedside. So how do you collect the spot, and what is the story of this collection? Remember, you may think metabolic, so collect the blood when symptomatic, because the body buffers will come into play. And the moment your excretion improves as the baby ages in postnatal days, you would not get much on the blood. The also important thing is that this dried blood spot almost freezes your all parameters at 48 hours, and therefore you can actually analyze this even later and up to 2 months if it's at -20 degrees. Well, do you really need to prick the heel? No, you can take a spot from any IV sampling. It need not be a capillary sampling. And in a critical area where there's a chance of apnea, it's very important to tell your residents while taking CRP at 24 hours, please also take dried blood spots, and just 3 spots would be okay. So don't overlay the spots. You decide the disease, because this is exactly what you would get on a filter paper. But this is if you have let it not dry, you will have this picture. And if you let it bake at 40 degrees, you will have a totally charged specimen. So depending upon the hematocrit, you would have a very good picture on the mass spec. And this is the entire story. What you do actually from this, you just punch 1/8 of a millimeter and put it into ELISA plate. And this is what actually gives you the diagnosis of amino acids, organic acids, and fatty acids. And that's what's very, very simple. I know it's very easy to speak when you're on the other end of the spectrum, but mass spectrometry is basically looking at what you know. So if you have a deuterated isotope, not a radioisotope for leucine, alloisoleucine, phenylalanine, tyrosine, and you run it with the normal substance, which has just 2 mass charges separately, you will know, okay, this is eluting here, and this is exactly what my leucine concentration in the body fluid is. Then, do you need any other technology, or just go by mass spectrometry? And why is it still called screening? Because it's targeted analysis. You can have many antibiotics, medium chain.
ड्रग्स में हमने फैक्टर नहीं रखा, हमें लगा वो ज्यादा हो जाएगा. फैक्टर 8 कंसंट्रेट भी रखा हुआ था. We thought कि वो
These
ज्यादा
will
हो जाएगा,
actually
वो नहीं रखा. बाकी तो I
continue
think
to
काफी
be.
ज्यादा है.
Please
तो सारे
mute
नहीं
yourself.
लगता.
It's a request, because it's very difficult to speak if you are not muted, right? So the best thing is to do targeted metabolomics on tandem mass spectrometry, or if you have urine, it will continue to excrete substances
Meningococcus
much
नहीं,
after your
pneumococcal.
blood has become normal. So if you will actually do amino acids, organic acids, you could do it on any filter paper, could be Wattman 3 or Wattman 4. What is the additional advantage of taking those blood spots? And what should you do in case your mass spec shows you some metabolic error? Ideally, you should collect blooded EDTA, which will be a good source of DNA, not from the baby itself, but also from both the parents, because most of these are autosomal recessive, and you could get the variation in the parents and confirm segregation. Yes, samples from the parents will also be an important thing for providing prenatal diagnosis. Now, in this case, you had a homozygous variation in the BHKB gene, which is the commoner gene in our country compared to the A variant. So what do you do once you get the diagnosis? You always know that these metabolites are accumulating. So you have to stop the formation of these metabolites. While you stop this, you still give adequate calories so that catabolism does not stop. Then you add something which will help you excrete these toxic metabolites. And for most of these, there is a chaperone or a cofactor which will help you excrete the metabolites early. Also, of course, as a neonatologist, you would treat the seizures and you would avoid sodium valproate because that will actually give rise to an artifactual ammonia if you're measuring that to measure what are your levels. You will maintain euglycemia, normothermia, and of course, acid. What do you do? Once you have the upper limit of normal, which is about 200 in a neonate, you will immediately stop all protein, give about 120 ml per kg of an IV glucose by a peripheral line, and if you exceed 12.5% by a central line, and start carnitine, biotin, and B12. Now, many of us ask, how do we get this? So it's okay, you can just add 1 ml of MBI to whatever IV fluid, and you would get enough cofactors. But carnitine, which is still not available as an IV preparation, can be given through the NG tube in these babies. But if the ammonia exceeds 500, you would actually begin continuous renal replacement therapy. And the time it actually crosses 500 determines how much is going to be the intellectual or spastic development in this child if we were to be able to survive. And then, so with, you could also add intravenous lipids, and alternative things which are available are sodium benzoate, both of which have got an easy remembering. It's 250 milligram per kg, and then you can go from 250 to 400 milligram per kg. As yet, the IV preparation is not freely available, so most of us go by the oral preparation, and we still don't have sodium phenylbutyrate because benzoate and phenylbutyrate will actually start excreting these metabolites much more easier. And you also, because the metabolism is not going well, add L-arginine if IV preparation is becoming available now in India. And obviously, most of us do use phenobarbital, but with the current recommendations to use sodium valproate, levetiracetam equally well, we still stick on to our old age of using phenytoin in these babies. So this was a classical neonatal encephalopathy with maple syrup urine disease. And that's a prototype with every neonatologist almost agreeing that you use the basic tests, you use mass spectrometry tandem as primary diagnosis, use urine gas chromatography, and then go on to molecular diagnosis. But what are more challenging than this? Now look at this 5-day male infant, absolutely well, has seizures in day 3 of life. These are multifocal clonic. We have given 2 anti-epileptic drugs. All your workup is normal, including sugars and calcium, and it's refractory neonatal seizures, but there is no HIE. Now, all of us know that we could have anything from HIE, the worst being neonatal hypoglycemic or neuroglycopenic brain injury, to brain malformations, to epileptic encephalopathy, probably caused by single gene. And here we are talking about metabolic disorders. Now let's look at what could cause metabolic disorders. It could be pyridoxine dependency, folinic acid responsive seizures, pyridoxal phosphate deficiency, glucose transporter defects, and of course, a very common missed, easily treatable defect like biotiradase deficiency. Now, this is a child who did not have any features of encephalopathy, but landed with you ex utero. Imagine you could have this baby coming in utero also with limp and cyanosis at birth. And this in utero seizures give rise to poor Apgars, and you start thinking, what is the perinatal event which occurs? And you also now know that there are many treatable causes like creatinine deficiency syndromes, serine biogenesis disorders, and of course, the other common ones like sulfite oxidase and molybdenum cofactor deficiencies, to which a very simple clinical clue is looking at low uric acid to distinguish between these two phenotypes. So this is an important metabolic cause. And many of them are becoming treatable. So as a primary neonatologist, I would not like to miss any of these diagnoses. Now, do my basic tests like GLAC, tandem mass, and gas chromatography answer these? Not all. So actually you look for an important analyte, which is ASA, amino adipic semi-aldehyde dehydrogenase on the GC. This is usually seen, but you have to request for it, because sometimes the peak of AAA may actually not be there, visibly there, and you would definitely tell the person in the lab, like, I'm suspecting pyridoxine-dependent seizures. So these are babies who have very early onset seizures, onset within 48 hours of life, and these seizures could be anything, remissing, abnormal movements, and the best possible thing, as they have a dramatic response. What are the features in the clinical part which will tell you? Now, these are the babies who have hyperacusis even in the neonatal period. They may have patterns which are burst suppression, hips arrhythmia a little later. They may have usually a normal MR, while we usually defer MR so the myelination is complete, and mass spec is completely normal. So what do? Only look for ASA on GCMS, or like anybody else, give a trial of pyridoxine, of which IV available is not IV pyridoxine, not easily available. So you use vitnurin or any other metabolite which contains 50 milligrams per ampule. And then you switch on to using 30 milligrams per kg per day, and then continue by Benadon, B-long, or pyric content. What else could you do? If you were to collect a CSF, you would get an important analyte, which is called pipicolic acid, which can also be standardized on a very easy test called high performance liquid chromatography. So in the metabolic armamentarium, there are basic tests, there is tandem mass spectrometry, there is gas chromatography, and there is high performance liquid chromatography. High performance will look at particular analytes. GC will give you a snapshot like a barcode. Tandem will pick up certain amino acids and certain acyl carnitines. So these are the CSF levels if you were to look at them and decide what is abnormal. So it's very important that we give pyridoxine, and there are situations in 10% while you also give folinic acid. And if there is a response, you definitely think that this is a metabolic refractory seizure, and with or without encephalopathy, I can give this child a perfectly normal outcome long term. Let's go by another case. So we had a case which was prototypic. We had a case where we could have missed or mislabeled as HIE. Now we have a case straightforward, not looking like metabolic at all. Now this is a 2.1 kg baby who's born to an L1P1 mother with a positive non-stress test and is born severely hypotonic. You actually start giving nasogastric feeds. He's told that it looks like Down syndrome, and you get a call and you look, this is hypotonic. And in the back of my mind, if it was not like dysmorphic, I would have thought of Prader-Willi, which is an imprinting disorder. But do I have any radiological phenotype which will give me the diagnosis? Now, this baby, as courtesy Dr. Sunil here, almost looks like Downs if you can look at it. But the MR picture is quite revealing. Now, with the presence of dysmorphology, with the presence of hypotonia, you would think of a chromosomal cause. That means something wrong in the numerical or structural abnormalities of the chromosomes. Now, how does it tell me that this is metabolic? All metabolic disorders are actually acted by the placenta, and nothing should be there in a baby which can affect the phenotype. What is this genotype? Now, not all molecules, like the small molecules, are transgressed by the placenta. And amongst these, you get good radiological signs if you get pachygyria, polymicrogyria, or periventricular pseudocysts. Or if you were to actually be very careful in the neuroskeletal picture and look at the patellar calcification, or something which will tell you there's something hypoechoic in the kidneys, or there is hepatomegaly. So this is a radiological phenotype which is complementing the neonatological confusion or suspicion that this could be metabolic. So what is this? Very long chain fatty acids. Now these are fatty acids, or these are acids which are attached to 24 to 28 carbons. So those who have actually look at mass spectrometry. So from C22, C24, C26, and C28 are the very long chain fatty acids. And above them, from C30 to C38 are the ultra long chain fatty acids. So both of them can actually transgress the brain, and you may get a suggestive neuroradiology. They may transgress the skeleton. You may get those small calcifications, and they transgress the musculoskeletal system, and you get profound hypertonia. So in the current paradigm, tandem mass spectrometry can also identify these very long chain fatty acids, giving you the clue that this is basically a peroxisomal disorder. So we saw a classical small molecule disorder as maple syrup urine disease. We saw a neurotransmitter disorder, which was not picked up by mass spectrometry, but could have been picked up by gas chromatography. Now we're going to another end of the spectrum where you're actually getting a hypertonic dysmorphic child, again turning metabolic. And since the discovery of Smith-Lemli-Opitz syndrome, being a totally dysmorphic syndrome, but actually having classical phenotype as 2-3 syndactyly, we now know that we are moving closer and closer to identifying metabolic defects, which might actually give rise to a clinically dysmorphic neonate. So what do? You can also do a CSF analysis. Now, it's whenever you do a CSF analysis, whether you do it for a situation like phenylalanine, which is raised. So in classic PKU, you will have levels beyond 1200, but in the hyper-Phe spectrum, that means you don't have very high levels, but you have levels, say between 1000 to 400, you're looking at biopterin synthesis defects. So whenever you are collecting CSF, it's very important to know what to collect, how to aliquot. So the first 0.5 ml, you can send for biogenic amines, which may be the biopterins. The next 0.5 ml, at least, if possible, store at -80. And if you have a lab nearby, store or ship with dry ice. And these will give you almost all metabolites on the CSF. What if you have not been able to do anything and you're losing the child? Don't worry. You might be able to give a diagnosis in the next pregnancy, collect blood, epirinize for chromosomes, CDTA for enzyme and DNA. If you can collect urine and CSF, store them at 20 degrees. If you've been able to collect skin biopsy, wonderful. You would get almost DNA and good. If you've been able to do muscle and liver biopsy, and if not, please take a clinical photograph, take an infantogram, and this verbal autopsy. In the previous demised case, will get closer to your fingerprinting, because when you send the sample for DNA, your phenotype decides whether the lab looks for an adequate genotype. So to looking at phenotype, genotype correlations, the verbal and metabolic autopsy with these mobile pictures